Thank you. Morning, Jia.
Morning, sir.
Morning. How are you?
I'm good, sir. Thank you, sir.
Okay, good morning. Good morning, Avinash. All set?
Sir, all set.
Okay. I have talked to Dr. Arun Maya, sir. He is there and he is going to handle properly. So no issues. He will be finishing by around 8:50 to 8:55 because we want to switch to our international symposium again. Good morning, Ajay sir.
Good morning, Manish sir. How are you?
Absolutely enjoying IPACON fever.
मजा आ गया. Great effort. मजा आ गया.
Yes sir. Yes sir. Yes sir. सब लोगों का बहुत शोरों शोरों से मजा भी आ रहा है और काम भी सबका हो रहा है अच्छा.
चलिए, I am ready. मैंने कहा टाइम से पहले पहुंच जाते हैं.
Yes yes yes. आपको मैंने कल का आज के वर्कशॉप का सब भेज दिया है ना एजेंडा. आपको कौन सा वर्कशॉप इंट्रोड्यूस करना है आपको पता है ना?
थर्ड है ना मेरा. थर्ड है ना?
Yes 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 sir. Yes.
थर्ड है मेरा. ठीक.
Yes yes. We are aware that we are live. I know that.
Yeah, that's great.
Okay sir. Avinash, please continue music for 5 minutes. 5 minutes, 5 to 7 minutes.
Good morning, everyone.
Good morning, sir.
क्या हाल है जी? आज तो फटे.
Good morning.
Yes, yes.
Good morning, brother.
Yes, good morning. Yes. Dr. Joy.
Yes, brother.
Good morning, sir.
Good morning, Dr. Raval. How are you?
Sir, fine, sir.
Welcome. Ajoy, you have got the slides of workshop 2.
नहीं सर उनको भेज रहा हूँ मैं कल थोड़ा इधर उधर हुआ ना.
वर्कशॉप 3 है ना मेरा.
उनको 3 दिया है सर.
ठीक है.
कॉस्मेटिक वाला. कॉस्मेटिक पोडेट्री.
Offloading techniques.
Dr. Ajay sir.
Yes.
Dr. Alok Gupta sir is not picking the call. आप उनको थोड़ा कॉल करके इन्फॉर्म करेंगे?
हाँ मैं बोलता हूँ.
हाँ सर प्लीज. Sonika ma'am, good morning. This is Dr. Manish here.
Good morning, sir. Good morning.
Good
You are
morning.
the core behind the managing the conference.
Just not myself. Everyone is working hard, ma'am. Everyone working hard.
Yes, sir, everyone is working, but more of all the messages had been updated by you only.
I am just a mediator, ma'am. Everyone is working.
Right.
Good morning, Dr. Dinakaran.
Very good morning, sir. Very good morning, sir. How are you, sir? And it was a very nice workshop, sir. Sorry, conference, sir, yesterday.
Yes, yesterday was all very nice.
All great success.
No, it's all because of you all people joining us, loving us, and helping IPA. It's a combined effect of all IPA faculty. It's
Sure,
not
sir.
a one man's job.
Sure, sir. It was really nice. Very nice. The Malaysian doctor and
The good thing was that usually all virtual platforms, they always get delayed. Okay, some hiccups in joining and all. So back-end team had meetings and more, and Dr. Manish, Shriti, everyone was working very nicely.
yes, sir. Yes, sir. Yes.
All chairpersons, moderators, they were all coming on time, and
Yes.
sessions were going very well.
And today, there is a separate any link for that workshop, sir. That some of the doctors just want to join our workshop.
Workshops will be there's a separate link, but now what we have done, all workshops will be in the same hall, so they don't need to log in through the separate log in through the same delegate or faculty link.
Okay, sir. Okay.
Same main link. Only we are shifting session 11 outside, and all sessions will be in the same hall.
Perfect, sir. Perfect. Perfect.
Delegate.
And e-posters will be after session 11. That should be noted.
All workshops are in the same
Right,
hall.
Yeah. Mr. Zia is there, na?
Yes, sir. Yes, sir.
Yes, sir. Just get the things noted out properly. We are starting our e-poster session at exactly 3 p.m.
Yes, sir.
and they will be joining once the session 11 is over. We have to continue the hall just like that. The people will be joining there.
Very good morning.
Good morning, sir. Good morning.
Good morning, sir. Good morning, Dr. Maya, sir.
Good morning, sir. Good morning, sir.
Yes, welcome, sir.
Yes,
All
sir.
set for the workshop?
Yes, sir. Everything is ready, sir.
Very good, very good. Is Dr. Animesh joined?
Actually, he sent a video.
Okay.
So he's traveling so that we have his video. I've already shared with our team also.
Yes, yes.
So
And
we will
Dr. Sampath will be joining?
Yes, he will be joining.
Good
Sir.
morning, sir. I'm already there.
Oh, good morning. Good morning, Dr. Sampath.
Good morning, sir.
Nice to see you on the podium.
Thank you, sir.
Dr. Sampath, actually, we have to restrict less than 9 minutes, sir.
Sure, sir. Sure, sir.
Okay, I will not take more than 7 to 8 minutes.
Sure, sir.
Dr. Shailesh also I told 9 minutes he said he will take. You also restrict to 9 minutes.
Okay, sir. Perfect, sir.
Last 5 minutes we will keep it for the Q&A.
Sure.
Exactly by 50 minutes we have to conclude the workshop.
Sure, sir.
Dr. Suri, sir.
Yes.
Let us start. 20-second left. Introduction will be in the proper time.
Good morning, all of you. Good morning, sir.
Good morning. Good morning.
Good morning, Maya, sir.
Attendees.
Good morning, Dr. Manish.
Good morning, sir.
Ajay sir and Ajay.
Is all the faculty joined?
Yes, sir.
Almost all the.
Dr. Alok is joining in a minute's time.
Okay, sir. Let us wait then. Let's wait. I thought he joined.
Who are the chairpersons for this session?
Just a minute. Dr. Sonika ma'am, Dr. Alok Gupta, sir. Our third one.
Good morning, Dr. Sonika, ma'am. Good morning, Sampath, sir.
Good morning, sir.
Good morning, sir. Good morning.
Good morning, Maya, sir.
Good morning, sir. Good morning.
Dr. Sampath Kumar, Dr. Alok Gupta, and Dr. Sonika Rawal are chairpersons.
Yes, yes.
Dr. Maya, sir, Dr. Animesh Hazare, and Dr. Shailesh Chotala are speakers.
Even Dr. Sampath will be delivering, as we said.
Yes. We are aware of that. We are aware of that. No issues.
Good morning, Dr. Shailesh.
Good morning, sir. Sir, as we discussed, we are shortening the. Yeah.
Yes.
No problem.
Srishti, good morning.
Good morning,
Good
sir.
morning, Sisti.
And let's start.
Good morning, Dr.
Good
Shailesh.
morning. Good morning, sir.
Welcome. You can start, Srishti.
Okay, sir. It's a glorious day to go after your dreams. Small steps in right direction can lead you to your desired destination. Good morning, ladies and gentlemen. New day starts with a new beginning. We should all remember the only competitor we have is ourselves, and person I am competing with is the version of me I was yesterday. With this motivation, let's begin our workshop 1 of loading. I would like to call upon stage Dr. Alok Gupta, sir. Sir is fellow UPDA, a fellow of Diabetes India, and a fellow of Indian Society of Hypertension. A very warm welcome, sir. Further, I would like to welcome Dr. Sampath Kumar, sir. Sir is currently practicing in Dubai. You are welcome to the workshop, sir. Next, I would like to welcome our chairperson, Dr. Sonika Rawal, ma'am. Ma'am is a professor and HOD of Medicine Department at Kanpur Medical College, Haryana. Welcome, ma'am. I hand over the podium to the chairpersons. Over to you, sir.
Dr. Alok sir is there, na?
Not yet.
Let Dr. Sonika continue for a while, and Dr. Alok will join in a short while.
Right. So without delay, we'll start our session. May I request to just enroll the details of the, yes. So today for this forum, we have Dr. G. Arun, sir. He's Professor and Dean, MCHP. He's Chief Center for Diabetic Food Care and Research at Manipal University of Higher Education. Very nice to know, sir. Even I am also alumni of Manipal only.
Okay, madam.
And he has many achievements to his credit. And so let's have sir with us. Sir will give us an overview of.
I think I need to allow that share the screen permission.
Yes, sir, please.
Now you can. Please. Yes, sir. You can do.
Yes, sir. Yes, sir.
Loud, sir.
Yes, sir will be elaborating on understanding the implications of offloading tools in the management perspectives in diabetic foot syndrome. As we all know, it's diabetic foot we see right and left, and the management is a very difficult part. So, Dr. G. Arun will be giving an light on the management of this. So, may we have a pleasure to first welcome you, sir, and sir, please.
Thank you, madam, and the respected national president of our Indian Podiatry Association, Dr. APS Suri sir, all the chairpersons, and also my the other faculty members. Once again, on behalf of the Indian Podiatry Association, IPACON2021, I extend a very cordial welcome to all the delegates and the chairpersons. So my sessions will be understanding the implications of offloading to the management perspectives in the diabetic foot syndrome. The most important thing is, what is the need for an offloading in the diabetic foot? How exactly an offloading helps in the healing of the wound, as well as also improve the mobility, the functional capacity, and improve the quality of life. What all various offloading techniques as a preventive strategy we can use in the diabetic neuropathy as well as in the diabetic foot, and also the various rehabilitation strategies. This will be subsequently discussed by our other speakers. So Dr. Sampath, Dr. Animesh, and Dr. Shailesh will be highlighting on the offloading tools and the rehabilitation strategies. As all of us know, the diabetic foot syndrome is a pathology which leads to the damage to the neuropathic, vascular, and the structural change. As we are repeatedly highlighting this point, the foot complications, even in the developed country, it's one of the main reasons for the hospitalizations in the diabetes patient, not focusing on the glycemic control. Mainly, the managing the complications is a challenge to the clinicians, even in the developed countries. And as we all of us aware that every 20 to 30 seconds, there is one amputation happens across the globe and in India, and we need to focus on preventing this amputation, as the slogan of Indian Podiatry Association is, I prevent amputation. I'm just giving a simple case discussion. We had a patient with chronic diabetes for the more than 25 years. And with the uncontrolled diabetes, he also developed various end organ complications. Unfortunately, he had all the end organ complications like severe neuropathy, nephropathy, retinopathy. And because of the nephropathy, and he had to go for the regular dialysis, and also he developed other subsequent complications that therefore the patient has to be immobile for a longer period. With that, he developed a very severe pressure ulcers on the bilateral heel, and it was suggested that he need to go for an amputations in the other hospital. Then immediately he shifted to our institutions or the hospital with a comprehensive approach, focusing on managing the glycemic control, managing the nephropathy, managing the retinopathy and cardiomyopathy, as well as the neuropathy. The patient is a well-to-do patient, and only he requested that, sir, how I can able to prevent the amputation. With the various vigorous approach, and also we focused mainly on the offloading technique. It took almost 2 months for us to relieve or completely heal the ulcer. What I observed here is a customized offloading have to be given in these patients. Even the most important thing is this patient was, as I mentioned earlier, immobilized for a more than 1 year duration. And because of that, he had a very deconditioning effect. And what we focused is, along with the offloading, a graded mobilization, and appropriate other conservative approach to heal the ulcer. So one important point here I would like to highlight is, whenever we have a very severe ulceration, this type of ulcer patients, along with the offloading, it is important for us to focus on the other aggressive management. Therefore, along with the offloading, we will be able to heal the ulcers as early as possible. So the most important thing in the offloading is we have to identify the specific region. The diabetic patients can develop severe changes like either maybe a pronated foot or the supinated foot. That leads to the either an excessive arch or the loss of arch. This is the most commonly we see. And if the patient is having a severe motor neuropathy, the patients are prone for developing an high arch that can lead to the most of the time we get the tip of the toes. Also, because of the repeated injuries, they develop an ulcer, or predominantly you see the neuropathic ulcers in the base of the metatarsal heads. So what type of offloading will be decided based on the how much is the maximum plantar pressure the patient is having in the various region of the foot. This point I will not go in detail because in the subsequent session there will be all these points will be addressed, and what all the newer technology can be given in these patients will be discussed by other speakers. So one important research also highlights that a good use of a customized footwear is one of the important preventive strategies either in the neuropathic or in the diabetic foot ulcer patient. And the significant amount of, we can say that a regular use of customized footwear will helps in redistributing the plantar pressure more than 40%. Because in our practice, what we observed is a moderate to severe neuropathy will have an almost an 150% increase in the forefoot loading as compared to the hind foot. When we go for an customized footwear within 6 months to 1 year of duration, there is almost 40 to 50% of the reductions in the forefoot plantar pressure. Therefore, offloading is an important line of management in the diabetic foot. What the evidences also says, the recent evidences is highlighting that the use of therapeutic footwear with the rigid rocker sole in patients with diabetes with polyneuropathy and the history of ulcer to reduce the risk of plantar ulcer recurrence. Then the second important recent studies also highlighted that the presently the evidence for the diabetic footwear or the offloading technique is the level randomized control trials are available, and if you look at the hierarchy of the level of evidences, it comes under the level 1 evidences. So with this quick introduction, I will be concluding my session, and thank you all for the opportunity.
So that was a wonderful presentation by Dr. G. Arun. And I think, am I audible to all of you?
Yes, sir. Yes, sir. Very loud and clear.
Yeah, and I think that offloading is the core theme of diabetes management. Whether you manage a diabetes as a whole, you have to offload the nutrient overload and reduce the central obesity, reduce the weight. If you once reduce the weight, overall weight transfer to the foot is reduced. And if there is any ulcers and arch deformity or some extra pressure points created, if you offload that weight from that foot, you make the ulcers heal fast. So offloading is I think the center theme of whole diabetes management, whether it be foot or a comprehensive diabetes management. So that is a very good presentation. And we should always be very much aware that a proper footwear customized, which is very difficult in many of the small cities to get, because we don't have such people who can make customized footwear, and we have to innovate ourselves with some local cobbler. But that helps much in healing the ulcers fast. Dr. Ajay,
Yes, sir.
who is the next speaker now?
Yes, sir.
Dr. Animesh Hazari, yeah, from UAE. He is assistant professor, Gulf Medical University, UAE, and has published more than 25 publications, authored 2 books. So I will just invite him to talk on the newer offloading techniques.
Very good morning to all the viewers. This is Dr. Animesh Azari. Currently, I'm working as an assistant professor at Gulf Medical University, Ajman, UAE, and I have been associated with the Indian Podiatry Association, the Karnataka chapter, since 2 years. The focus area of today's session is techniques and guidelines for offloading in diabetic foot ulcers. Please allow me to share the screen. Before I jump onto the different techniques of offloading, I would like you to understand the need for offloading. And if you look at the pathophysiology of diabetic foot ulcers, we find that there is a strong correlation of high plantar pressure with diabetic foot ulcers. As the plantar pressure increases, the chances of diabetic foot also increases. And thus, the offloading need arises. And before we do the offloading, we need to understand there are certain clinical points that we need to make before prescribing an offloading device. We need to identify the area of peak pressure, which can be clinically determined by presence of ulcers, callus, and corns on the plantar aspect of the foot. Or we could also use the advanced devices such as plantar pressure analysis and motion analysis devices. We then need to select the technique of offloading or the method, which is our area of focus today. Give proper guidance towards prescription and foot hygiene to the patient. Assess the balance and then normalize their gait pattern. In all these points, we need to understand that our primary goal is to relieve and redistribute the plantar pressure at the vulnerable site. So once we have made a decision, we thus now need to identify the techniques of offloading. In the literature, there are various techniques of offloading given. However, we are going to focus on majorly these four: the total contact cast, charcot restraint orthotic walker, air cast pneumatic walker, and customized diabetic foot shoes. The total contact cast is considered as the gold standard for offloading devices. It is applied in prone position with the flexed knee and the ankle in neutral position, such that it allows full access to the sole of the foot. It uses plaster of Paris, which is mounted carefully according to the contours of the foot. We can also use fiberglasses or specialized soles to reinforce the cast and to avoid the pressure that may be caused by weight bearing. The mechanism of action for the total contact cast is very simple. We understand that pressure is directly proportional to the force and inversely proportional to the contact surface area. So if we can increase the contact surface area, we can reduce the plantar pressure as it is seen with total contact cast. However, there are limitations to the use of total contact cast, though it is being considered as the gold standard. First thing is that it is very time consuming. We cannot assess the foot or the wound on daily basis. It also has less compliance due to difficulty in activities of daily living for the patient, such as bathing. There can be chances of postural instability due to the bulky nature of the cast, and it is also contraindicated in certain conditions such as acute infection and ischemia for grade more than 3. An alternative to the TCC is charcot restraint orthotic walker, also known as CRO or neuropathic walker, which is very effective in neuropathic ulcers. It is a rigid full foot enclosure ankle foot orthosis that can accommodate with customized insoles and orthotics. It is internally lined with soft foam, which may aid in redistribution of plantar pressure and also absorbs shock when the patient is walking. The good thing and the advantages of the CRO in comparison to the TCC is that it can be used with full weight bear and allows the patient to ambulate freely. It can be removed, unlike the TCC, for inspection of ulcers, and can be also used to apply dressings or topical medications. It has got a good patient satisfaction, and it can be also used for control of edema of the limb. One of the limitations is that it is bulky in nature and it is heavy, and thus it may not be suitable for frail individuals. And there's also a chance of likelihood of irritation of the skin and breakdown. The third one is the aircast pneumatic walker, which is a removable semi-rigid plastic offloading device with internal ASLs, which helps to reduce the shearing force due to presence of the air cells. It can also reduce the peak plantar pressure, which is equal to the TCC in the forefoot, midfoot, and the hindfoot. So the advantage is that it can also be used in midfoot ulcers such as Charcot foot. Now we move on to the customized diabetic foot wear. The first one is the conformer boots, which is consisting of the auto mount, memory foam, and dual density midsole. And it promotes offloading and prevents movement that causes breakdown of the skin. It has also got aluminum boot shell, which is adjustable to accommodate most of the leg sizes. So it can also be removed on daily basis for application of topical medications and washing. Thus, this is a device which is very much effective and very much satisfactory for the patient. However, one limitation to this is, again, it is heavy and bulky to wear because it is consisting of a lot of heavyweight materials. In comparison to the conformer boots, we have a strap-based diabetic foot wear, which I have also been using in my clinical practice. The material consists of the polyurethane or the lycra or the microcellulose rubber. And the difference between the mechanism of action for TCC and other offloading device compared to this is, here, instead of increasing the contact surface area, we are trying to reduce the contact area with the ground of the vulnerable site. So this device, for example, has been used for the hindfoot diabetic foot ulcers in such a manner that the ulcer is present here, but this is not coming in contact with the ground. When the site is not coming in contact with the ground, the reaction force or the ground reaction force is also very less, and it promotes foot healing or diabetic foot ulcer healing. Similar to this, this is a footwear which can be used for offloading the forefoot area. These are the different diabetic foot types which has been used for clinical practice, and I hope that the information that I've shared here could be useful in your clinical practice. These are the references that you could go through. We have recently published a book on the clinical biomechanics and application of diabetic foot, which can be useful for all the viewers. At last, I would like to thank all the entire administration of the Indian Podiatric Association for giving me an opportunity to share my ideas and information on this platform. Thank you.
Thank you, Dr. Hajari. So, friends, we have just seen that we have got different devices to either offload the pressure point from the high pressure areas to make the ulcer heal fast, or to redistribute the plantar pressures to those areas which are still healthy and they can bear the weight, and to offload the weight from the area where we don't want weight to be. And gradually, from total contact cast made of plaster of Paris, we have moved much ahead with the invent of many new materials which are lightweight, have got memory, and can be used freely now. So that was a very good presentation, and I hope that in coming future, we will have some more newer devices which are much lightweight and can be very easily used by our patients, not bulky. Dr. Ajay, it's over to you now. Dr. Ajay.
Sir, you have to introduce Dr. Shailesh Chotala.
Yeah, Dr. Shailesh Chotala is the president of IPA Gujarat. So, Dr. Chotala is founder and owner of Dr. Chotala's Sheona Hospital, Surat, Dr. Chotala's Jeevan Jyoti Hospital, Surat, and Foot First Podiatry, the foot and the ankle clinic, and Jeevan Jyoti Medical Footwear Service. This is something very unique that he has also started footwear services, because whatever we are learning here, the barrier is that when we want to apply that learning with respect to the footwear, customized footwear, we are stuck up. Whom to contact, where to go, how to get a customized footwear for our patient. And he has done a commendable job by starting a footwear services also. And he has many achievements regarding to the podiatry and the foot services. So I will just request Dr. Shailesh Chotala to now present his talk for the newer techniques of offloading.
Yeah, thank you, sir. Good morning, everyone. Good morning, Suri sir. I especially thanks IPA, and on behalf of the IPA, I am presenting this the talk of the newer offloading techniques in diabetic foot. I want to take a permission to share my screen.
Yeah, yes, sir, please.
So, as Dr. Arun Maya sir and Dr. Animesh already highlighted something about the newer techniques and some footwears. So I'm not going to detail into the biomechanics and types of the foot, but I want to as a conclude part of the biomechanics, as we see in this slide, the pronation, overpronation, supination, and imbalance of the body. Once a patient have a neuropathy and the changes in the foot biomechanics, there will be more chance to get foot misaligned. After that, knee also and whole body will be misaligned by the time. So we have to look after the biomechanics of the whole body. As compared to the diabetic foot, non-diabetic foot also affecting by the bad biomechanics. So there is a some forces which we have to I mean we have to understand that while we walking and running, we have lots of this type of forces applied in the foot. So first of all, the horizontal and shear forces. After that, the vertical and pressure forces. So this type of forces will the main component of the forces applied in the plantar pressure, and after that the shear stress and vertical force will be the friction load and the temperature. So according to the biomechanics of the foot, the types of the foot, we are getting pressure in the normal as well as in the diabetic foot. So this type of walking, we are doing the initial contact, after that the forefoot contact, hindfoot contact, and toe up. So according to this slide, we are getting more pressure on the step by step. And if we have a neuropathy, if diabetic patient have a severe neuropathy or any previous ulcer site, then this type of forces and this type of walking is dangerous, and we have to offload at the same time, and we have to prevent amputation after this offloading the ulcer. So as Dr. Maya sir already highlighted, these things is the main cause of the diabetic foot is a peripheral neuropathy, peripheral vascular disease, and altered biomechanics. Sometimes we are facing three of them altogether, and sometimes any one or any two from this. And this is the important thing from my side, that plantar tissue stress and in diabetic foot ulcer is very important to understand. Repeated pressure over the plantar surface of the foot, it will leads to the fascia to remove either on the back side or front side. At that moment, callus formation is there, and after repeated same pressure, some subcutaneous hemorrhage also be there. And just because of the peripheral artery disease or any reason, there will be the chances of the foot ulcer in a very short period of time. After that, if we understand this pressure scan slide, then if the pressure is on the same area, even if the great toe amputation is there, there is a chances of other part of the foot has to be damaged. So we have to look after other parts of the feet as well. And sometimes there will be the midfoot amputation, and then also the rest of the foot also developing ulcer, and we have to understand that we have to prevent that ulcer as well. This is some one of the slide from my side, that neuropathy will change leads to the skin problems, callus cones, and it will leads to the high pressure area, ulcer area. After that, on the other side or other part of the foot also get the ulcer. If we don't give the good offloading footwears, then patient is walking on the heel, and after that heel developing the ulcer on the heel as well, and sometimes on the other side of the leg as well. So this is the scenario that gangrenous changes, amputation is there, progressive amputation is there, midfoot amputation, still the ulcer is developing, and below knee amputation is there, still there is a ulcer on the stump of the that patient. So this is real patients. So after that, we have to understand the biomechanics, as Dr. Sanjay Sharma sir yesterday in this one of the session, they already covered all the things that we have to understand the angles of the foot. We have to assess thoroughly to give offloading footwears and give the good service to the patient in terms of the preventing the amputation. This is another cases from my side. The deformities develop and ulcer is on that lateral part of the ankle area, and as we can see, bulky foot and deformed foot. When we are seeing this type of patient, we are literally say that you have to prevent and you have to wear that proper footwears along with all the services. So I prevent amputation. IPA stands for the glycemic control, debridement, and offloading is key factor. And dressings, infections, that infections, the process, vasculature, and advanced wound care. This is also necessary thing, but offloading is the key and central part of the I prevent amputation protocol. So as already my senior Maya sir already told that the less than 200 kPa pressure has to be the target for the every patient, and we have to offload. One thing I want to highlight today, that we are talking every time regarding ulcer offloading, but the important part from my side is even if patient has a no ulcer and no callus even, then there is offloading term we can use, because we have to reduce a particular area pressure in terms of the equal pressure of all the foot and opposite foot as well. So we have to start from there. We can't wait for the ulcer formation. So offloading terms used also in normal foot as well. So in orthopedic condition like plantar fascia is there, then high pressure of heel and spur also develops. So we have to offload that area as well, even if there will be no chances of ulcer. So offloading terms we can use anywhere. I mean, any part of the foot we have to offload in terms of corrections. And when we offload an area under the foot, we onload another, increase of pressure. So we need to know that the tissue can manage this pressure. Measuring the equipment can help us to here also. So one sort of, I mean, the foot scanner plate, something other Harris mat also, we can easily come to know that there will be the high pressure or low pressure. So offload and onload, there is an important terms. As Dr. Animesh Hazari already covered this part, the different types of footwears, and I don't want to go into details again. And now I want to highlight the important thing, the different techniques in the rockers offloading. The shoes also coming with the front and back rockers, and that will be very useful in the some non-diabetic conditions. But here we are here for the diabetic foot IPACON. So we have to understand that in the latest technology, in-shoe pressure measuring system also there will be the this type of the sensors in soles which we can use in the shoes, and we can with this device we can monitor the walking, running, and every activity of the patient. So that way we can utilize this technology in terms of offloading techniques. In latest, I think the Optima company, the smart shoe offloading also there, and this is the device, and they are using the in the European countries and even in US, Canada, and in this with this device, they are monitoring. There is a sensor here. They are regularly monitoring the patient's activity. So doctors and the prescriber come to know that patient is wearing or not, and if patient is wearing, then what sort of pressure is going on there. So main aim to the offload the previous techniques, I mean the older techniques or newer techniques, there will be main aim to equal pressure distribution. If it is there in the any sort of deformity patient is having, the main pressure is on the forefoot and hind foot. So we have to redistribute with the use of the any kind of offloading footwear. We have to redistribute equally on the foot because every foot is important. This is some sort of example from my side that a patient is having amputation, but still we can manage easily with the customized insole, and we can design the sandals from this insole. So patient having this compromised foot, still we have to the things in our mind that we cannot give any type of footwear, but we have to offload that area, and we have to prevent other area to be ulcerate. So this is my side today's presentation. We have the good offloading footwear. So as Dr. Aloke sir already told that lightweight and not bulky footwear, that should be the target, because neuropathy is there. And if we are using very limitation for TCC and nowadays, because neuropathy is there, neuropathy is advanced developing in near future also, within a 1 or 2 years, patient is developing neuropathy changes. So we have to consider all the points during offloading, and the main aim to walking and running, or even any sort of activity from the patient side has to be normal. This is from my side. Thank you very much.
Dr. Sonika.
Thank you, Dr. Shailesh.
Yeah.
For a very wonderful overview of the subject.
Very nice, Dr. Arun Maya and Dr. Animesh. Very nice presentations you have. There's a question in the chat box that looking at the Indian scenario.
Good morning, sir. Actually, Dr. Sampath's presentation is there. Dr. Sampath.
Yes. Dr. Sampath. Dr. Sonika, please invite Dr. Sampath Kumar.
Yes, sir.
We'll take the questions after this session.
Right. So can I have the screen for the same, please?
Avinash, Dr. Sampath Kumar slides.
Yes. Hello, sir. Dr. Sampath
slide.
Yes. So after the 3 interesting talks, we have another speaker now with us. Sir, I welcome Dr. Sampath. Dr. Sampath is Senior Diabetic Foot Care Specialist. He is practicing in Dubai. So welcome, sir, on the board.
Good morning, ma'am. Yes, my screen is visible.
Yes, sir.
Okay.
Dr. Sampath would be discussing upon the diabetic foot care guidelines.
Very good morning to one and all. At this outset, I would like to thank Dr. APS Suri sir and Dr. Arun Maya sir and the entire organizing team for giving me this opportunity. So today I will be talking on the topic, the diabetic foot care guidelines, an overview of the existing guidelines. So without much delay, I will go into an introduction. As we all know, the World Health Organization estimates that more than 422 million individuals are having the diabetes globally. Out of this, the peripheral neuropathy, which is very highly prevalent in people with diabetes, with a lifetime prevalence of the 50%. So approximately 19% to the 34% of the persons with diabetes are expected to develop a diabetic foot ulcer within their lifetimes. As we all know, the diabetic mellitus has a complications, that is the acute complications and the long-term complications. And in the long-term complications, again, we have the microvascular changes and the microvascular changes, which ultimately leading to the infection and ulcerations and leading to the gangrene and amputations. So as according to the American Diabetic Association, the diabetic foot is the anatomical area below the malleoli in a person with diabetes mellitus. This diabetic foot, usually the syndrome, which is a clinical triad of the neuropathy, ischemia, and infection, which will lead to the development of the tissue breakdown, resulting in the morbidity and also the possible amputation. So this diabetic foot further stratified into the various categories, the risk categories, that is the risk category 0 or low risk foot, risk category 1 or increased risk foot, risk category 2 or the high risk foot, risk category 3 or the ulcerated foot. So we have the various pathologies leading to this diabetic foot problems, mainly the peripheral vascular disease, the diabetic peripheral neuropathy, and the biomechanical aspects, as already discussed by the earlier speakers, the recurrence of the previous foot ulcers, the duration of the diabetes and the control of the diabetes levels, and the wound healing. So today I'll be talking about the certain guidelines that is given by the International Working Group on the Diabetic Foot Guidelines. These are the 5 principal cornerstones of the foot ulcer prevention. First one is the identifying the at-risk foot. Second one is the regularly inspecting and examining the at-risk foot, educating the patient, family, and healthcare providers, ensuring the routine wearing of appropriate footwear, treating the risk factors for ulceration. All these 5 cornerstones are considered as integrated foot care, which is a combination of all these elements. So the first one, the person who is identifying at-risk foot, mainly we have to examine a person with the diabetes at very low risk of foot ulcer prevention. We have to check for presence of annually for signs and symptoms of loss of protective sensation and peripheral artery disease. So mainly to determine whether this person with the diabetes having a risk for foot ulceration or not. Second one is regularly inspecting and examining the at-risk foot. We will be screening the person with diabetes at risk for the development of this foot ulceration. In this, we will be focusing on the history of the foot ulceration or any presence of previous lower extremity amputations and diagnosis of any end-stage renal disease, presence of progression of the foot deformities, limited joint mobilities, abandoned callus, and any pre-ulcerative signs of the foot. So this table depicts about the risk stratification system given by the International Working Group on Diabetic Foot 2019. Mainly in this, we have to repeat the screening once in every 6 to 12 months for those who are classified as a risk 1 category, once in every 3 to 6 months for the risk 2 category, and once in every 1 to 3 months the person who are at the high risk category. So mainly the characteristics will be included the loss of protective sensation, the peripheral artery disease, along with other foot deformities. And if you see this picture, these are the key areas of the foot where developing at high risk for ulcerations, mainly the toe deformities, and then on the plantar aspect, the callus formations and all. The third one, the cornerstone principle, is educating the patient, family, and healthcare providers. It is subdivided into the 3 categories. Mainly, first one will be focusing on the instructions to the patient on the foot self-care. So in this, the person will be asked not to walk on the barefoot and socks without shoes or any in thin sole slippers, whether indoors or outdoor walking. And also, as a healthcare professional, we have to encourage the patient and remind with the risk of developing ulceration, mainly to inspect the entire surface of the both feet and the inside of the shoes that will be the patient worn, and wash the feet daily with careful drying, particularly in between the toes. Use emoluments to lubricate dry skin, cut toenails straight across, and also avoid the using chemical agents or plasters or any other techniques, self techniques to remove the callus or corns. The next one is providing the structural education about self-care. For these people with diabetes, we have to provided structural foot education who are developing the risk for foot ulcerations. A proper foot care, self-care should be discussed with the patient. And the third one is instructions about the foot self-management. So we have to consider the person with diabetes who is at moderate or high risk of foot ulceration to self-monitor the foot skin temperatures once per day to identify for presence of any early signs of foot inflammation, and which further helps in preventing the first or the recurrent plantar foot ulcers. So in these cases, the person's temperature difference is above the threshold limit between the similar regions in the 2 feet on 2 consecutive days. Ask the patient to immediately to consult to the physician. The next one is ensuring the routine wearing of the footwear. We have to mainly insist the patient to wear the therapeutic footwear, which accommodates the shape of the feet and that fits properly, mainly to reduce the plantar pressure and helps the preventing the foot ulcers. So if at all, if a person is developing any symptom or the pre-ulceration sign is present, consider prescribing the customized insoles or the toe or the foot orthosis to the patients. Mainly orthotic interventions such as the toe silicone or the semi-rigid orthotic devices, mainly which will help in reducing the abandoned callus. In a person with diabetes who has had already the healed plantar foot ulcer, prescribe a therapeutic footwear which has demonstrated the plantar pressure relieving effect during the walking. Next one is treating the risk factors. Mainly, or it is on the pre-ulcerative signs of the food. We have to ask the patient to further look into the problem and provide the appropriate treatment for any pre-ulcerative signs or abundant callus which are present on the foot, especially for the ingrown toenails or any further presence of fungal infections in between the toes, mainly to avoid the prevent or the foot ulcers. Next one is the foot related exercises and weight bearing activity. Consider advising a person with diabetes who is at a low or the moderate risk of foot ulceration, mainly to perform the foot and mobility related exercises with the aim of reducing the risk factors for ulceration. Mainly we have to focus on the intensive muscles of the foot and strengthen the muscles. And also we have to consider the patient communicating to the person with diabetes who is at the low or the moderate risk for foot ulceration. A moderate increase in the level of walking related weight bearing daily activity, that is an extra 1,000 steps per day, is likely to be a safe range. All these 5 elements are the integrated foot care, mainly focusing on to provide the integrated foot care for a person with diabetes who is at high risk of developing the foot ulceration, mainly to help in preventing the recurrent foot ulcers. So this integrated foot care includes a professional foot care, adequate footwear, and structured education about the self foot care. Repeat this foot care and reevaluate the patient if it needed once every 1 to 3 months as necessary, depending upon the patient's condition. So the current evidence, mainly we have a certain guidelines which was given by the Diabetic Foot Australia guidelines, recent guidelines, this is on 2018. Mainly the more or less this also the classification of this recommendations are given on the person with the at risk for developing the foot ulceration, a person with intermediate or high risk of foot ulceration, and a person with the diabetic foot ulceration. And also we have one more practical guidelines for the prevention and management of this diabetic foot disease by the International Working Group Diabetic Foot 2019 guidelines. Across the globe, on all the healthcare professionals, especially who are practicing into this diabetic foot should fall into this at least one of these levels, which is categorized into the level 1, level 2, and level 3 categories. Level 1 falls the general practitioner, podiatrist, and diabetic nurse, whereas in the level 2, a diabetologist, surgeon, vascular specialist, infectious disease specialist, or clinical microbiologist, podiatrist, and diabetes nurse in collaboration with the shoe technician, that is orthotist and prosthetist. Whereas in the level 3, a level 2 foot center is specialized in the diabetic foot care with multiple experts from several disciplines are specialized in this area, can be categorized into the level 3. And this is a checklist which has been given by this International Working Group on Diabetic. If a person walks into your clinic, we have to focus on this, the key areas with a thorough detailed assessment. And we have the idea of clinical practice recommendations on the diabetic foot, International Diabetes Federation, on focusing on the diabetic foot ulcers. And also we have the Canadian guidelines, which are focusing on the same areas. So to summarize the study, as a healthcare professional, we have to do a comprehensive, thorough foot screening evaluation along with other diabetes evaluation. And the person, once identified with the risk of developing the foot, we have to give the therapeutic footwears, and also, if possible, to be given the any offloading devices to further prevent the recurrence of the infection and to avoid the amputations. So these are the therapeutic offloading footwears. And these are the footwears to be avoided, especially to the patients with the diabetic mellitus. I would like to acknowledge at this point the Center for Diabetic Foot Care and Research Center, Manipal, Indian Podiatry Association, Indian Podiatry Physiotherapy Association for giving me this opportunity. Thank you.
Thank you, sir. Thank you for a wonderful overview of the subject. So can we have the questions now?
Yes, Dr. C. Yes, a very nice presentation, Dr. Sampath Kumar. It's very important that offloading, as Dr. Alok Gupta sir has also implied, that this is one of the very important part and parcel of a diabetic foot management. Until and unless we offload the plantar ulcers, we all know that these ulcers won't heal. Sometimes we are doing some pity things. Sometimes we advise patient for these offloading shoes. But when the patient go back home, their family says that they are not wearing those offloading shoes or offloading modalities, whatever we do. There's a lot been research done and seen between reversible versus irreversible offloading mechanisms. So we have an international faculty also, we can discuss during that session also into this. And we have always seen the data that our wound healing is better if we go for the irreversible or irremovable, I will say irremovable offloading mechanisms. That's a very important question, that what would be a question to you, and then over to Dr. Arun Maya sir also, as it's a workshop. What could be the best or cost-effective offloading mechanism for our diabetic patient in Indian scenario, where we have to see the cost also, mainly for the neuropathic ulcers. We all know that infected ulcers or very ischemic ulcers, the different modality we have to admit patient and then, but what could be the best for the plantar neuropathic ulcers, non-infective or infective? Your comments on that, Dr. Sampath.
Yes, sir. As a part of in our routine clinical practice, depending upon the patient's neuropathy level and depending upon the foot ulcer level, we have been prescribed with the MCP footwear.
Good.
With the customized insole.
Yeah. Dr. Arun Maya sir, there's a question in the chat box, like there's a patient with a mid-foot, Charcot's foot ulcer, rocker bottom deformity, and a non-infective, but that's a long-term, about 2 years Charcot's ulcer. How best we can offload that?
Suppose if the patient is having a Charcot, then maybe you have to rule out the structural changes. In case if there is an already there is the bony changes have developed or the irregularities have developed, then we need to go for a rigid bottom, especially we go with the crow. Crow is the best choice, sir. Otherwise, we have to go with then rigid offloading to the midfoot area. Thereby, we can able to prevent the further deterioration of the Charcot changes.
Yes. There's a very nice presentation by Dr. Jonathan Lebowitz on Charcot's foot after the launch of the fellowship program. So Dr. Lebowitz can comment on that also. But I think the take-home message could be that the best way, if any doctor or any patient comes to the clinic with a hot swollen foot, a unilateral hot swollen foot without an ulcer, please try to offload that. Offloading is the best mechanism until unless you go for your diagnosis by the DD, either you get an X-ray or MRI or whatever you think of cellulitis, you think of gout, you think of DVT. But first diagnosis or first DD should be Charcot's foot, because that is the one we can prevent the further destruction of the foot if we can offload that foot at the same time in your clinic. Best way would be to put in a TCC cast, even not a TCC cast, a posterior slab, take a Scotch guard and put in a posterior slab until unless you go for your DD and diagnosis for that. At least the pressure will be offloaded on the midfoot area. Tell that patient not to walk more until unless you get X-rays and MRI or radiological investigation. Because if the patient, lot of time what we see in our practices is that diabetic patient, they keep on walking on that foot. They say that for glycemic control, that diabetologist or physician has told them to walk. That's correct. But he doesn't know because of the neuroarthropathy. Charcot foot is a total neuroarthropathic foot. He will not have pain. You and me will have pain. We will not be able to put the foot down on the foot. Lot of time we see the whole metatarsal, tarsal construction has been destroyed. The whole total collapse of the medial arch is there. It's a rocker bottom deformity. But the patients are walking barefoot in the house or walking on a normal footwear, because that is the destruction of the foot. So as a IPA member or as a diabetic foot surgeon or a clinician, the first goal should be offloading. Because if you can offload that on your first visit, that's the best criteria. You might be able to save that foot from further destruction. Further amputation can be prevented, and then you can go in for your surgical corrections or whatever it is. Even I see a lot of time these patients are there for midfoot ulceration or hindfoot ulceration. Best way is with your debridement, you take them in the OT or in your clinic as a daycare procedures. But offloading should be part and parcel of your clinical management of any wound care, any wound, either on the dorsum of the foot or on the plantar surface of the foot. Over to Dr. Arun Maya, sir.
Thank you, sir. Actually, sir, one point I just wanted to mention here also, like since I focused on a preventive strategy, based on our findings, even with the patients with the more than 1 year of type 2 diabetes, what we observed, they may not clinically, they may not have detected the neuropathy, but when we did the foot analysis or the pressure analysis, what we observed is there is almost a 10 to 15% significant weight distributions have been shifted to the forefoot before they clinically manifested with the neuropathy. Therefore, as a preventive strategy, even with the 1 year of type 2 diabetes or with the type 1 diabetes with the more than 4 to 5 years as per the IDF guidelines, as a preventive strategy, it is important for us to go for a customized footwear. Thereby, we can able to prevent the development of the callus or the subsequent neuropathic ulcer. This is the one point I would like to stress here, sir.
That's what I said, sir. Yes.
Absolutely,
Within
absolutely.
1 or 2 years, yeah, they are developing.
This is very nice. We have some questions in the chat box. I think we will be sending them by email to the delegates. There's a question for Dr. Maya for heel ulcers. When do you decide to use a hide rocker? There's another question from Dr. Anupama Dubey, our IPA member, that what is the cheapest way to offloading ulcer in a poor patient? And I think Dr. Sampath has already answered that. Madam, the best way would be to use any, you have to offload that with whatever type of sheets, the Evazort or Plastazort or MCR rubber, whatever are available. But we can answer that on an email because we are short of time and we are just going for the launch, very important presentation of IPA, launch of the fellowship of International Fellowship of Diabetic Foot Management. Thank you so much for Dr. Arun Maya sir, Dr. Animesh Hazare, Dr. Sampath Kumar, Dr. Shailesh, and our chairpersons, Dr. Alok Kumar and Dr. Sonalika Lamba, for chairing this session, taking this thing forward. Offloading is a very important part, as we all know, and that's the best you have done today, and make the ball rolling for today on a Sunday morning for Indian Podiatry Association, second day of this conference of IPACON 2021. Thank you so much for all the panelists and speakers, and we allow the session to close. Thank you.
Thank you.
Thank you, sir,
Dr.
and thank you all of
for
you.
giving an opportunity to chair the session. And being a physician, I just want to give one take-home message that for all the diabetics, we must keep a good control of sugars. We must assess the neuropathy status, I mean their sensations. And if the patient has neuropathy, before getting into all the complications, we can advise them timely, take care of footwears, keep your sugars under control, keep your blood pressures under control.
Thank you so much, ma'am. Thank you.
Thank you,
Thank
sir.
you. Thank you, Dr. Suri. Only one last word, that this conference of yours is going to leave a foot imprint akin to that of Angad.
Thank you, sir.
Of diabetic podiatry. Yeah.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you all. Thank you.
Thank you to all the chairpersons and the speakers. Thank you for such invaluable information. Unless you try to do something beyond what you have already mastered, you never grow. And when it comes to medicine, knowledge is of no value unless you put it to practice. To fulfill our hunger for knowledge, I welcome you to the launch of online fellowship course in diabetic foot care. This course is brought to you by Western University of Health Sciences along with Indian Podiatry Association. Western University of Health Sciences, situated in California, and provide medical fields like podiatric medicine, osteopathic medicine, dental medicine, and other numerous fields. The Association of Indian Podiatry Association, along with Western University of Health Sciences, California, makes a great event in the history of Indian medicine. We all have heard of podiatry throughout the conference. Podiatric medicine is a branch of medical science devoted to the prevention, diagnosis, and treatment of foot disorders resulting from injury or disease. So for this very important event, I would like to call on stage Dr. Daniel Wilson, President, Western University of Health Sciences, Dr. Jonathan Labowitz, Dr. Jarrod Shapiro, Dr. Valerie Marmolejo, Dr. Kathleen TJ Bering sir, Dr. Ravi K. Kamapalli sir, Dr. APS Suri sir, National President IPA, Dr. Rajni Saxena sir, Secretary IPA, Dr. Sanjay Kala sir, Treasurer IPA, Dr. Naresh Dua sir, Joint Secretary IPA. For the further information over the program, I would like to hand over the podium to Dr. APS Suri sir. Over to you, sir.
Thank you, Dr. Shrishti, for the nice words. This is one of the very important launch programs in the history of Indian Podiatry Association. I welcome all the delegates, international faculty for this launch program. We have been working on this for last 2 to 3 years of time. Mr. TJ Baring, who has been the pioneer in this, has been taking the things forward. Indian Podiatry Association is already running a fellowship in diabetic foot management for our delegates in India since last 3 years, or in fact 2.5 to 3 years, going to be 3 years now. And we are proud to say that we have done 3 batches for this fellowship program. As we all know that no university or college in India has got a podiatry school or podiatry college. And if you look at podiatry, when I came back from US in 2002, we saw that there were no podiatry clinics or no dedicated wound care centers. But it's not that diabetic foot patients were not being treated. Every nook and corner of the country, every hospital, every clinic, our orthopedic surgeons, general surgeons, physicians, plastic surgeons, they were all treating diabetic foot ulcers in the country, but no dedicated podiatry care was there for the patients. So we joined together and then we developed Indian Podiatry Association. And this fellowship program we specially designed. It's an online course which we are already running, but we wanted to have an international affiliation to that. And we are thanking mainly to Dr. Jonathan Lebowitz, who's the Assistant Dean of the Western University and Chairman of this fellowship program, with Mr. Baring, that we joined together and launched this program and did the official announcement about 2 years back before the epidemic spread, when Mr. Wilson visited my center in India in 2019, and we signed the agreement for that. And by God's grace, we all know that every day has to be counted in history. And 25th of July, Sunday morning, is a day when IPA and Western University of Health Sciences College of Podiatry Medicine, California, USA, is joining together and launching this program for Indian doctors who wants to do this degree and take the thing forward, knowledge sharing, and they can enhance that. It's not that they are not treating diabetic foot. It's the enhancement of the knowledge in diabetic foot care, which we are trying to give to all the doctors in all these South Asian countries. We have IPA members in Nepal, Bangladesh, Sri Lanka, and all the surrounding countries. So this fellowship will really benefit all the doctors dealing in this foot care practice in these South Asian countries. With these words, I first like to invite Dr. Wilson, Daniel Wilson, who's the president of the Western University. By God's grace, he's not able to join, but we have a recorded message for him. So, President of Western University, California, chairperson of the fellowship program in diabetic foot care. Please, Dr. Wilson.
Please play video.
Yes. We have a recorded message for that.
Hello, I'm Dr. Dan Wilson, President Emeritus of Western University of Health Sciences in California and Chairman of Western U Global, our new global outreach enterprise. I want to welcome all of our international colleagues to the launch of this special joint fellowship, which will benefit Indian doctors and ultimately many of the millions in the subcontinent who suffer diabetic foot syndrome and its awful consequences. I offer special greetings to Dr. Siri, Dr. Rajneesh, and Dr. Kanapali for their leadership and collegiality. We also all can share much gratitude for Dr. Kathy Satterfield, Dean of the College of Podiatric Medicine at Western U, and Jonathan Labovitz, Associate Dean. Without their prodigious efforts, this fellowship would not have been possible. They've really gone above and beyond. Finally, and again, I thank all of the participants in this happy event and look forward to joining you in person at a future gathering. Thank you, thank you, thank you.
Thank you, Dr. Daniel, for the nice words and the taking the things forward. I would like to invite Dr. Kathleen Satterfield. She is the Dean of the College of Podiatry Medicine from California, USA. If she's joined, she can open the video. We welcome you, ma'am, and it is the great efforts from your office which have taken this thing forward for the Association of Indian Podiatry Association with Western University. And we assure you that this knowledge sharing will really benefit the doctors dealing in this program. And the main theme of this conference is also I prevent amputation. And we will try our best that we have good numbers of doctors who can just benefit from your faculty and add on to their knowledge sharing and help in healing the patients who are suffering with this disease. So I welcome you, madam, for this, and thank you, IPA, the whole core committee. Thanks you for the Association of Indian Podiatry Association with the Western University. To take forward, I invite Dr. Jonathan Lebowitz, who is the main force behind this fellowship program. And we have been discussing for last more than 2 years now. We have met in India, in Korea, in South Korea for our conferences, and multiple times. And he's an excellent person to communicate with that. And he's the DPM, FAC, FAS, CHC, QM, Associate Dean of Clinical Education and Graduate Placement and Professor, College of Podiatry Medicine, Healthcare Quality and Management, American Board of Quality Assurance and Utilization Review Physicians. He is, I think, one of the best foot and ankle surgeons in the western part of USA, an American Board of Foot and Ankle Surgery certified foot surgeon. Dr. Lebowitz is the chair of the Western Foot and Ankle Conference, which is one of the largest continuing education seminars in the country. And during lockdown, also in the epidemic, they had a very successful clinical program, which was on the virtual platform. So I welcome you, Dr. Jonathan Lebowitz, for this conference. We have a session for you just after this fellowship program, but I welcome you, IPACON, into IPACON and the launch program of this fellowship program. To take forward, I welcome Dr. Jared Shapiro. He is also one of the very famous foot and ankle surgeon in the western part of the US in California. He's a medical director of Western U Health Pomona Foot and Ankle Center, College of Podiatric Medicine. He's a program director in Chino Valley Medical Center, Podiatric Medicine and Surgery Residency with Rear Foot Reconstruction and Ankle Certification in August 2013. And I assure you that all the DPMs in US, when they pass out, they go through Dr. Shapiro's online courses, fellowship programs, and residency programs, which are very famous in the whole of USA. So I welcome you, sir, for this launch program of Indian Podiatry Association. To take it forward, we have our main force behind this fellowship program for this association of IPA with Western University, TJ Baring. He's a senior advisor to IPA consultant, Western University College of Podiatry, California, USA. Welcome, Baring, to this launch program. And we are really thankful to you for joining the forces behind with the main aim of I prevent amputation. And I think any doctor working in any part of the country into podiatry or foot and ankle surgery, the main goal is I prevent amputation. And I think this fellowship will really help Indian doctors, as it has been your dream also to make Indian doctors know this and enhancement of the foot and ankle surgeries so that we can really help our patients. With this, we have our main Vice President of Indian Podiatry Association, Dr. Ravi Kamipalli. He's infectious disease and certified wound specialist practicing in, he's at present in Georgia, Atlanta, Georgia. Residency at Wyckoff Health Medical Center in Wyckoff, Brooklyn, New York. And he's a infectious disease fellowship at St. Vincent Catholic Medical Center, New York, and infectious disease fellowship at St. Vincent Catholic Medical Center, New York. And I think we have been associated since last 2 decades. And every time we meet either in US or in India, we have been discussing how we have to take Indian Podiatry Association far ahead. Each step of the rise of Indian Podiatry Association in 2 decades has been with Ravi Kamipalli. And I think if I would have not met Ravi, or Ravi would not be affiliated with Indian Podiatry Association, I assure you that I or Indian Podiatry Association would not be at this level. So really, Ravi, we are thankful to you for this joining. And this fellowship program is also one of your babies. We have been thinking, talking for last 10 to 15 years, and see, it's today we are joining here together. I welcome Dr. Rajneesh, Dr. Sanjay Kale, and Dr. Naresh Dua into this fellowship program launch. And all my core committee members, we have 15 chapters of Indian Podiatry Association, all the presidents, secretaries, office bearers of Indian Podiatry Association. Welcome you all, Dr. Jonathan, Dr. Wilson, Dr. Kathleen, Dr. Jarrod Shapiro, and we have one more member, Dr. Valerio, from USA. She's in the next session. So we welcome you all for this launch of the fellowship program. Thank you so much. We'll start with the video. Thank you so much. Now I invite Dr. Jonathan Lebowitz to unmute himself, and we can have your blessings and good words about the fellowship program.
Thank you, Dr. Suri. Dr. Satterfield, I think, is here. If she'd like to say a few words first.
Yes.
Oh, thank you, Dr. Lebowitz and Dr. Suri. It is such an honor to be here today. I've given this much thought. We have been building this, and I say when we, Dr. Suri and Dr. Lebowitz and Mr. Baring, have been building this for the last year or more, and I could not be more excited. I'm the dean of the College of Podiatric Medicine at Western University, and my whole clinical life has been dedicated to the limb salvage and diabetic foot care. And so, you know, my heart is in this. When I thought about what to say today, I didn't want to script anything because I realized that all of you across the world here today who are signed on are committed to the diabetic foot and the patient who suffers from that malady. So I am just so proud of you, not myself, but you, that you are trying to increase the mortality of these people who suffer from this malady. So any small part that Western University can provide, we are committed to that. And we are just so honored that you all have reached out to us to have this commitment. And as long as I'm here, you have my commitment, and I will help you. And I just give all the credit, though, to Dr. Lebowitz and Dr. Suri. You have done remarkable things with Mr. Banning, who I call our rainmaker, who made the introductions who are so powerful. It couldn't have happened any other way, right? So I stepped back and I let my star faculty, Dr. Lebowitz and Dr. Shapiro, and there are many more to come, to go forward and do great things across this world. So I turn it back to you. Thank you.
Welcome, ma'am. Thank you for such a nice words. It's heart touching, and we all know we are so thankful that it has all been your association and your commitment, but what we have been trying to get from you. And we are so thankful that Indian Podiatry Association doctors, in fact, last evening, I got 2 calls. There are multiple doctors waiting to be joining this association. I think just at the launch with Dr. Lebowitz, I think multiple doctors are just waiting to get affiliated with this fellowship program. And I assure you that this program will take the things of diabetic foot care, the management for diabetic wound management at a higher level, what we are doing at this present. And this will be for young doctors, young resident doctors in Department of Surgery, Department of Orthopedics, Plastic Surgery, Vascular Surgery, who wanted to know about and get affiliated with the foot and ankle surgery or this course on diabetic foot care. So I assure you that this program will really take the things at a very higher level for Indian doctors and all across South Asia. We have multiple doctors from South Asian countries, and where we know that this podiatric care is not at that level. And this is really commendable. And I think God will really bless you as we save people, because a single foot we save, this whole family blesses us, and all these blessings will go to you. Thank you, ma'am. Thank you. Thank you. Dr. Lebovitz.
Thank you. I'm just going to share my screen here.
Yes. I'll just interrupt. Can we do a ribbon cutting first and then get your screen sharing?
Absolutely.
Yes. Welcome, Dr. Kathleen, Dr. Lebovitz, Dr. Shapiro, and all the Western University people and Indian Podiatry Association. So we announced the fellowship program, fellowship of diabetic foot management open. Dr. Lebovitz.
Okay. Well, thank you. It's really exciting to be finally seeing this come to fruition after nearly 2 years of working on this. And I think I've shared the wrong one. So
yes.
So after 2 years of working on this, it's been exciting to see the passion from everybody that I've met when I was in India, and then also continuing to work on this, meeting with Dr. Suri multiple times, and other board members also being at one of your conferences a few years ago. And through all that, it really keeps you motivated to help develop something like this, and hopefully train many people to improve their skills, enhance what they're doing, so we can save more limbs. And like I said, our goal here is to expand the knowledge of physicians internationally to improve the quality of care for diabetics. You know, around the world, we're doing this work now, but if we can enhance something, improve some knowledge somewhere, help you in some way to help your communities, then that's a success. We want to improve preventive care to reduce complications, reduce amputations, and overall improve the quality of life for those around the world. And if we can, like I said, if we can assist in that, then that's really just speaks to the passion you already have. And it's nice to be a part of that in some way. This is our first affiliation. So it's nice to say IPA is our first global partner in this effort. And we'll be kicking it off with you now. The online fellowship course is all managed through Western University's learning management system. That includes all the didactic materials, tracking your clinical experiences, and also any assessments as we go through that, as you go through the course. The first 2 months of the course are primarily didactic. It begins with a pre-test, so we can get a baseline assessment of where people are at and what their strengths and weaknesses are. Then each unit you go through and complete with a quiz at the end of each unit, and then you must pass the post-test so we can track any gains that you've had, where they are, and before you proceed to your clinical experiences. The didactic materials themselves is based on evidence-based literature, videos, and e-text that the College of Podiatric Medicine is developing, some videos from IPA that you've contributed to the didactic material. and also our virtual doctor's office simulator that we've recently created. So that simulator was just developed this past year in collaboration with our Western U online education team. It provides a user-friendly platform to experience real cases. So every case that's in this simulator are real cases that we are, as faculty have experienced, manage these patients. And it's a way to assess your clinical decision-making, compare it to evidence-based medicine and best practices.
Learning from reading and writing, or just listening to someone lecture, is something we have all done for years. During COVID, we just sat there in front of a computer, reading, typing, and listening. The problem is that's boring, and it's hard to learn when you're bored. Lessons aren't as engaging, and experiences are often less meaningful. And in medical education, you don't get to practice applying clinical reasoning skills or train in a safe environment before engaging with the complexities of high-risk scenarios involving real patients. Now, there's a new, dynamic way to learn. The Western U College of Podiatric Medicine is advancing how podiatric medicine and surgery are taught using innovative software platforms. The CPM faculty created interactive learning tools where you can experience patient care in your home at your convenience. You get to enjoy a simulated clinical experience online with the freedom to move through patient visits as you would in your office, not in some prescribed order dictated by software developers.
Virtual Doctor's Office is a dynamic and engaging learning tool that allows you to test your clinical skills and knowledge by making available all of the tests that you would normally see in day-to-day practice in the real world. By doing this, you are able to strengthen your decision-making skills and provide better care for your future patients.
Using the CPM Virtual Doctor's Office, you experience a standardized method of learning evidence-based medical practice, and you get the opportunity to apply your knowledge. Your medical decision-making will be put to the test. In the CPM Virtual Doctor's Office, you get a user-friendly platform to meet your patients, learn the reason for their visit, choose how to perform the clinical exam, order the appropriate diagnostic testing and interpret them, diagnose their condition, and treat them according to their medical and social needs. At the end of each case, you'll get a report comparing your performance to the most up-to-date evidence-based practices. The explanations also help you achieve the necessary competencies by providing additional opportunities to learn the content.
What I really liked when using the video modules was that the format was super user-friendly. It took place in a clinical office, which allowed me to stay engaged and use real-life patient examples.
The CPM Virtual Doctor's Office offers an exciting and engaging way to learn podiatric medicine and surgery in a safe environment. Learn to provide your patients with the highest quality of care with the Western U CPM Interactive VDO.
I hope you can come check it out.
Howshi?
So for the clinical experience, after the first 2 months, you begin these clinical experiences with hands-on care with diabetic foot specialists from IPA. Western U still maintains some oversight. We're looking through the assessments, being the clinical evaluations by the preceptor. You're working with the IPA preceptor. Your case logs to ensure that you're getting diversity in your diabetic cases and the experience you're getting. And then also some case submissions that you would submit. Then the faculty in California will be reviewing the care and treatment, the diagnostic workup, and providing feedback on your performance. So that would be the next 4 months. And it's competency-based, so it's not just pass-fail. It's looking at your level of ability and seeing how you can advance over the 4-month period. So we hope that you are interested and would like to register so we can all stop amputations around in all of our communities. Thank you.
Thank you, Dr. Labovitz, for the nice presentation and making the ball rolling. We announced the Indian FDFM, the online fellowship program, open. So now all Indian doctors, I think 2 or 3 of them wanted to register during this conference. We have a special offer for them. You can coordinate with Dr. Rajneesh and Dr. Manish for them. You can just go online. The form is available on IPA website, www.ipafootcare.org, and just you can register over there. We would like to invite Dr. Jarrod Shapiro, one of the other limelights from Western University, to have his opinion and some welcome address for the Indian doctors. Dr. Shapiro.
Thank you, everybody, for having me. I very much appreciate it. Thank you, Dr. Suri, Dr. Leibovitz, Dr. Satterfield, and the organizers of the IPA. I just want to offer my congratulations on the start of the fellowship. I think this is a wonderful collaboration between 2 countries who are very much affected by a very serious problem. And what a great way to help fight this problem. Hold hands together and work our way through this wonderful problem. So congratulations, and I'm sure we're going to see wonderful things come from it. Thank you.
Thank you, Dr. Shapiro, and we'll take the things at a higher level with this fellowship. And yes, diabetes is one of the main diseases which is suffering. USA and India both are suffering with this disease. We have as many maximum people of suffering with the disease, and as such, we have same number of diabetic foot problems. So it will really benefit both the populations with this fellowship program. We would like to invite Mr. Baring, who has been the main torchbearer, and we have been talking through emails, through WhatsApp, and through personal messages. So we would like to have Mr. Baring. We would also like to have, I can have Mr. Baring later on, but we'd like to invite Dr. Valerio Marmolejo, again from USA. She's a podiatrist with a foot surgeon. She has worked for 10 years as a podiatrist at military treatment facility, service, active duty, and retired military and their dependents. She has been working in US, and she has a presentation today also on extracellular matrix. So we welcome you, Dr. Valerio. Yes, can we have some kind words from you?
Yes, thank you.
Unmute yourself. Yes.
Are you able to hear me?
Yes, yes.
Thank you. I am greatly appreciated and honored to be able to present today, and congratulations on the fellowship. It's always been my passion of education and teaching others, because that's just going to help. The more people you can help, the more limbs you can save, the more lives you can save. So I am honored to be able to speak today, and I look forward to some exciting questions and engagement as well.
Yes, thank you. Thank you, Dr. Valerio. I would like to also invite our main pillars of IPA, who is the Vice President of Indian Podiatry Association, founder member, and since 2009 when we founded, we have been affiliated from 2002 onwards for 2 decades now, Dr. Ravi Kamipalli from USA.
Yeah,
Dr.
hi.
Ravi.
Amar, thank you very much, Dr. Labovitz and Dr. Shapiro. Thank you very much for starting this association with Indian Podiatry Association. And basically, I think my focus as an infectious disease doctor and a wound care doctor started out with the journey of working towards removing barriers to healing to those problems. But of late, what I've understood is nutrition has a huge role, and I would look forward to creating some clinical research programs wherein we can advance the nutritional podiatry also. So we would like to discuss that at a later time. If you guys think about some clinical research for podiatrists who are going to go through this, and I have some certain ideas and solutions that we might want to work on. And in this auspicious time, I would like to again thank all of the people who are involved, including the team at IPA and all the stalwarts who are making this happen. And thank you very much, and God bless all. And hopefully we'll all work towards preventing amputation and removing barriers to healing, which could be multiple. Cost is a huge problem, but there is other problems, including communication, personalization, realization, and implementation. And there are certain solutions that we are working towards that, and hoping that this organization and this association will help us push the care to the a better level so that we can work together. Thank you very much.
Thank you, Ravi. Thank you so much for the nice words. I would like to invite Mr. T.J. Baring, advisor to Indian Podiatry Association. Please unmute yourself, and can we have your kind words, please?
Well, at the outset, I would like to congratulate Western University of Health Sciences, College of Podiatry Medicine, and Indian Podiatry Association. I think it's by virtue of the great minds coming together and great partnership that has been created. I'm really pleasantly surprised that the kind of response that we got to whatever we have been creating has been phenomenal. And I think the biggest benefit that I see in today's world is essentially to the society at large. And as you said it, Dr. Suri, the keyword is I prevent amputation, which interesting synonym also for IPA. I think that mission is something that we've all been focused on. And when I say we, means everybody on our panel and everybody who's joined together. We've all focused on reducing those or preventing those amputations. And I think that is where we will see the final benefit going to the society. And I thank everybody for making it happen. And once again, I also thank the management of IPA, the College of Podiatry Medicine, Dr. Lebovitz has been done. He's done all the heavy lifting, of course, and this was under guidance of Dean, Dr. Setterfield, and Dr. Shapiro, who's been absolutely excited about the prospects as well. And finally, last but not the least, Dr. Daniel Wilson, who's been at the help of making this happen, which included the travels to India that we've had. Once again, congratulations to everybody. We look forward to expanding this and obviously adding more and more as we move forward. Thank you, everybody. Have a great day.
Thank you, Mr. Baring, for these nice words. And thank you so much to all the Western University, Dr. Daniel Wilson, President of the University, Dr. Kathleen Setterfield, Dean of College of Podiatry Medicine, Dr. Jonathan, Dr. Shapiro, Dr. Valerio, Baring, Ravi, and all the office bearers of Indian Podiatry Association and all the delegates. We welcome to join this program on Sunday morning. And I announce, and we all announce, the Indian Podiatry Association, the core committee announces the online fellowship course, Fellowship in Diabetic Foot Management between IPA and Western University of Health Sciences, California, USA open. Thank you so much. Over to Shristi, and we close this session. And we take you to a very important international session now, where Dr. Shristi, as a session coordinator, will advise you. Thank you so much, all the delegates and invited guests, for coming in on Sunday morning. And we all thank from our heart the launch of this program. Thank you.
Thank you to all the delegates, hoping for a grand success of this program. Let's move on to the session of International Diabetic Foot Symposium. What is the role of diabetic foot specialist in a critical patient's life? Let me put the feelings to words. The perspective says, when I felt my feet slipping, you came with your love and kept me steady. For this grand session, I welcome the rapporteur, Dr. Bala Ganesh sir. Sir is a consultant surgeon at KIMS Hospital, Sikandarabad. Sir is a proctology and podiatric surgeon. We are pleased to have you, sir. I hand over the podium to you, sir.
Thank you. Thank you. Good morning to everyone on this pleasant day. And thanks for giving me an opportunity to take this session forward. Am I audible?
Yes, very much.
Yeah. Today, it's my glad to introduce the chairperson for today's session. He is Dr. Manish Kumar Janda. Hello.
Yes, sir. Please continue.
Today's chairperson for this session, we have Dr. Manish Kumar Jangam sir, who is a renowned cardiologist and podiatrist from Maharashtra, Satara. And we are extremely grateful for Dr. Manish Kumar Jangam sir for his support in organizing this IPACON along with his daughter, Dr. Sisti Madam. Without his support and guidance, conference would not be successful. And sir has done the PG post-graduation course in advanced diabetic from Harvard Medical School and post-graduation course in advanced cardiology from Harvard School, fellowship programs. And sir has traveled all the way around the world to pursue knowledge on diabetic foot care and also in the cardiology. And the next chairperson for the session is Dr. Ravinder Kumar sir. Sir is a renowned the physician from Patna, Bihar. Sir is a member of API and RSSDI and member of Indian Podiatric Association Bihar chapter. Sir is a core committee member who is the key person for organizing this successful conference, IPACON 2021. And my next chairperson for this session is Dr. Manoj Gupta sir. Sir is a practitioner from Mumbai. Sir has done MBBS, MD, DNB, LLB, and PG, DHA. Sir has got training in hyperbaric medicine from Carolina, USA, and he is a certified hyperbaric medicine qualification from USA. Sir is a BSc honors, and he is an associate of the American Professional Wound Care Association, India. And it is my real pleasure to introduce Dr. Amarpal Singh Suri sir, the king of podiatry of India and a world-renowned podiatrist. And sir is a founder president of Indian Podiatric Association in India, which is the motto of I Prevent Amputation, and American board certified hyperbaric oxygen therapy specialist. With his leadership quality, he has connected thousands of doctors all around the world, organized and participated in several conferences, workshops, and many more. And his guidance and coaches doctors in diabetic foot care management. He offers fellowship programs too. Dr. Amarpal Singh Suri sir has vast experience and exposure from around the globe. To name a few, he has done residential from Harvard University, USA, fellowship from Temple School, USA, and he is a practicing podiatrist from 20 years in India, and he is the director for Diabetic Foot Care Center, Narayan Vihar, Delhi. His belief and motto of IPOA conference is I Prevent Amputation. With his belief, he has treated thousands of patients and prevented amputation more than 90% of the more than 90% of the patients by introducing new guidelines and advanced techniques. I'm honored to invite Dr. Amarpal Singh Suri sir as a moderator for today's session. Thank you. And my next moderator for today's session is Dr. KK Arora sir. Sir is one of the renowned plastic surgeon from Ludhiana, Punjab. And sir has done, is a pioneer, founder, member of IPA, practicing diabetic foot care since 2002 in Ludhiana. Thank you, and I'm handing this podium to the moderators and my chairpersons. Thank you. Thank you.
Good morning.
Good morning.
Next slide, please. At the outset, I congratulate Indian Podiatry Association as well as Western University, and I thank Dr. Jonathan Leibowitz, Madam Satterfield, as well as Dr. Gerald Shapiro, and all faculties from USA, as well as all faculties, Dr. Rajni Saxena, Dr. Ravika Mepalli sir, Dr. APS Suri sir, all our delegates and all the faculties and core committee members for giving me an opportunity to chair this International Diabetic Foot Symposium. It's really pleasure to announce a Diabetic Foot Fellowship, which is online and for all kind of practitioners busy with their schedule. It's really a great moment in the podiatry history of India. It will be really a golden moment for all of us. So it's my pleasure to introduce Dr. Jonathan Leibowitz. He's Associate Dean of Clinical Education and Graduate Placement Professor in the College of Podiatric Medicine in Western University. We have introduced him in a previous session. I don't want to spare more time. I will just hand over my podium to Dr. Jonathan sir. Over to you, sir.
Thank you. Thank you for having me lecture today. So we're going to be talking about new technologies to improve Charcot foot outcomes. And this was an interesting topic because we wanted to look back and see what direction things are going for Charcot and how can we improve. It's been such a complex and challenging problem that first I want to go over kind of what leads to these complications, because I think that really sets the table for how to evaluate the current evidence and going forward, what advancements can be made and in what areas. So what complications are happening? Well, we know we have, a number of them, deformities and ulcerations, and obviously it leads to amputations. But depressed and poor quality of life, depression and mortality are generally considered the end result from some of this, as some of these complications can proceed and become out of hand. So the etiology of this is really twofold. Patients have delayed diagnosis or delay in treatment, but that can also happen on the doctor's end too. We may delay that depending on our expertise or knowledge, awareness of this not common pathology that if we don't see it often, we would consider it something other than Charcot foot. Infection is a common one, especially when there's an ulcer. Poor clinical decision-making or poor treatment to adherence of the treatment plan and comorbidities all kind of line up and lead to these deformities, the collapse of the arch, ulcerations, and so on. So when the patient delays diagnosis, it could be a doctor factor as well. We may, like I said, we may delay that, but with that delayed diagnosis, there's often up to a 5 times increase in complications, including lower extremity amputation and mortality. We did a study at Western U and found that delayed diagnosis, increased the incidence of amputations, mainly major amputations, by over 3%. That was significantly different than a timely diagnosis. Poor treatment adherence. Offloading the Charcot foot in the acute phase is critical, and it's really the foundation to our treatment. But there were studies done in diabetic foot ulcers, not necessarily in Charcot foot, but found that the patients wear an offloading device if it's removable less than 30% of the time. And in a future study done in 2016 found a direct association between adherence to a removable offloading device and healing time. But patients are not alone here. The doctors, with our poor decision-making, potentially may transition someone to weight bearing too soon, may do surgery on someone who's really not a surgical patient, choose an inappropriate procedure, or fail to correct the deformity when doing the procedure. But I'm only going to focus on areas that have these advancements, which I highlighted there. So let's look at comorbidities, and not all patients should have surgery. In a recent article in 2021 by Lyons, they wrote that high rate of perioperative complications due to the high rate of associated impaired immunity, multiple organ system disease, obesity, and osteopenia. These complications are everything we've been talking about. And we found almost a 7% more comorbidities in the Charcot patient compared to the peripheral neuropathy patient. So just looking at renal disease, a slew of things happen with chronic renal disease that this comorbidity alone can significantly increase the perioperative mortality or complications. Vitamin D deficiency, it's not really a new advancement, but it is something newer that we're looking at more frequently now because it has so many different roles that we've learned more and more over time. With poor glycemic control, insulin receptors increase their function. It's required for function. So with deficiency, we have increased insulin resistance, increased immunosuppression, greater arterial disease, and obviously chronic inflammation. Let alone, it goes without saying, the homeostasis and the bone metabolism is skewed with the vitamin D deficiency. And you can see the complications as they line up here. The glycemic control can cause all of the complications we're talking about. Inflammation can certainly lead to delayed healing, recurrent ulcers, and so on. But all of these complications can happen, and supplementation is something we should be looking at if necessary. And then again, mortality. We talked about the comorbidities, but this study here done in Chandigarh by Rastogi and his colleagues, higher prevalence of microvascular disease, even though Charcot patients are of a younger age than your standard diabetic without neuropathy and Charcot. But there's a lower prevalence of cardiovascular disease, but the same number of cardiovascular events. So they hypothesize that autonomic neuropathy may be the cause. So there are other factors here, not just microvascular disease or other things that are obvious and we need to consider. So what advancements can we look at and get some help from? So initially, this pathway is kind of where everything starts on a cellular and biochemical level. We have the increased cytokines, the strong inflammatory cytokines, and the tumor necrosis superfamily, alpha, IL-1B, and or beta, and IL-6 mainly. Advanced glycosylated end products. We have a decrease in neuropeptides, CGRP, calcitonin gene-related protein, and a decrease in nitric oxide. And all of those can increase the osteoclastic bone resorption side of that bone metabolism equation here and decrease the osteoblasts. We also have OPG or osteopterygirin polymorphisms, 2 in particular that have decreased the available OPG, which allows the rank ligand to bind and increase the osteoclasts. So we focused for a long time on anti-resorptive technologies and bisphosphonates in particular, but they really failed to decrease time in clinical resolution. So looking at this now, there's some newer ways that we're evaluating this. And one of the biggest things is we're looking on the anabolic side, looking at how do we boost osteoblasts or block the osteoclasts by different mechanisms. The other was methylprednisolone. If we can stop those powerful cytokines and the inflammatory cytokines, then maybe we can decrease or shift this back to stopping the bone degradation. But first we'll look at offloading because that is really the key in the acute phase. And we said that non-removable offloading devices, regardless of what type of non-removable you use, if as long as it's knee high, that increased compliance is facilitated so we get better results. So this one is a newer one that uses remote monitoring. And when we use the remote monitoring, it's actually a removable brace, not irremovable. But if we find that the patient's not doing it appropriately, we can use it we can convert it to irremovable. It coaches the patient, gives them behavioral modification messaging. The app also will send reporting to the doctor so you can see it and get updates on your patient and understand how they're doing with their offloading. So methylprednisolone, targeting those inflammatory cytokines. And this study was done, 36 patients were randomized into 3 groups. And interestingly enough, the methylprednisolone time to clinical resolution was significantly prolonged, more than the bisphosphonates, zolendronic acid, but just the total contact CAS was the best and significantly the best with time to clinical resolution. The methylprednisolone did what we expected. It did significantly decrease the cytokines, but it also increased bone resorption through the measurement of different biomarkers. We saw a decrease in procollagen, so bone growth, and in bone degradation with telopeptides, we found an increase. And it was the only one to increase that. It also significantly decreased bone mineral density. So when we look at this, this clearly is not going to be something we want to rely on here. It's got to be something more regulating this than just the inflammatory cytokines. So the next was recombinant parathyroid hormone. So this now is looking at the anabolic side of the equation here. It's shown significant value in fracture healing in non-Charcot patients. Its anabolic effect is really with intermittent administration of it and accelerates fracture healing. So this recent study here had 48 patients randomized. Clinical resolution was actually slightly greater in the control group. The time to achieve clinical resolution was 5 months in the intermittent parathyroid group versus the control group, which was 6 months. But there was no significant difference in time to resolution or in predicting the likelihood of clinical resolution in less than 12 months. So they determined here, this study was done in 2021 in Petrova out of the UK, and they concluded that it did not significantly reduce time to resolution or enhance healing. So there was no really added benefit to the intervention with parathyroid hormone. But I think these results may be a little misleading. If we look into the study a little deeper, they, compared to other studies, they evaluated the parathyroid 184 molecule, not the bioactive fragment of 134. Now, both have been shown to be useful in clinical healing and accelerating fracture healing in non-Charcot patients. So in theory, it should still work. But also, they said that in both groups, they used irremovable casts, but the adherence with that was only 73% in control and even less in the parathyroid group. So these results may not be as reliable as we think. So looking at 2 other studies on recombinant parathyroid, they used the active biofragment. One was only 5 patients. It's really not of much value, but they did find the clinical benefit. The other was done in 2019 with 20 patients receiving parathyroid hormone, 1 dose or daily dose of 20 micrograms sub-Q. And they've, using the labeled fluoride PET CT scans, they found tracer uptake showing osteoblastic function secondary to the parathyroid hormone, but with a decrease in the uptake in the placebo group. So if the placebo group also increased, we would suspect that maybe the natural history is over time, we would naturally see that increase, but we don't. And significant differences in the changes in the tracer uptake at 3 months and at 12 months. The bone markers showed an increase for the procollagen and a decrease for the bone degradation or the telopeptide in the parathyroid group. Initially, parathyroid had an increase in degradation and then decrease, whereas the placebo only increased. Bone density increased in the parathyroid versus decreased in the placebo. And they measured the X-ray angles to see if the deformity changed at all, and that was unchanged in both groups. But basically, when the bone formation increases with subsequent resorption decreasing, we have an anabolic period and that bone growth is beneficial. We're getting a net gain of bone, whereas the placebo was only catabolic. So they concluded the opposite of the last study of Petrova, that it did increase osteoblast activity and remodeling in the chronic foot. The main difference being that was in the chronic foot, and the other study with the full fragment 184 PTH was in the acute Charcot. So we're not really sure if this is an advancement yet. These are real early studies, and additional studies and larger studies need to be performed. It is looking good. So here's a monoclonal antibody that is being used for anti-rankle, and it mimics OPG, it mimics the osteopterygium by blocking the ligand, allowing a greater effective concentration of the OPG to decrease the osteoclasts, and by causing decreasing the maturation and also increasing cell death. Again, this has been shown to be beneficial in fracture risk in osteoporotic patients. Schaffler out of Western U, we did this study on our campus, 7 consecutive patients with 1 injection, found decrease in skin temperature over time. And only 1 of 7 patients had any difficulty with this, of injection site pain. And in 52 days on average, or just over 7 weeks, normalization of the skin temperature. And it can be concerning that you see that increase, but other studies here, you can see the timetable of skin temperature changes, and we know that there's been an increase in skin temperature, but overall there's a significant decrease. And this pilot study here of 7 patients showed that this was an effective treatment. Two other studies have been done versus historical controls. Both showed benefit, significantly less time to resolution of acute midfoot Charcot, 7 weeks versus over 20 in the historical control with no adverse effects. And the other study was similar to that, longer time to clinical resolution in both groups than the last study of 7 weeks, but significantly less time. So that may be a benefit. And the last one I want to talk about really is clinical decision-making on the doctor's part, and predictive analytics being the next phase of where medicine is going. We can predict surgical outcomes, guide clinical decision-making, and using the different patient factors. So the American College of Surgeons developed a risk calculator using 20 different predictors, and it predicts up to 18 different complications that can happen within 30 days. You can see you put in a variety, you put in your procedure and a variety of these factors, and it'll produce for you this risk calculator and tell you the risk of different serious complications, any complications, and a number of other types that we can experience. So Lyons in 2021 did a study here looking at Charcot patients with 85 consecutive patients undergoing circular ring fixation. General anesthesia was only if required, if regional had failed. They had a complication rate, overall complication of 26%, 11% being serious complications. And the risk calculator was accurate to 74% and really found that anemia and, excuse me, and CHF were the most significant risk factors. And they determined that reconstructive surgery in this complex population can be done with reasonable exposure of risk, and that this is reliable. So here are two cases of mine: a 54-year-old Black male with chronic hindfoot Charcot versus a 66-year-old white male with chronic hindfoot and ankle Charcot. Nearly the same in their comorbidities. Case one, the 54-year-old was on hemodialysis, and he did have CHF, whereas the other did not. His ejection fraction was only 40%. And you can see his both deformities were significant. Both had ulcers, which we know is predictive of more complications, including amputation. They had virtually the same complaint when I was consulted for a surgical reconstruction on both of them. In the 54-year-old, I determined that because of his ejection fraction, despite cardiology clearing him, I put him in a crow walker and did not operate, whereas I operated on the other foot with pantalar arthrodesis. But 6 weeks after the arthrodesis, he got distal tibial osteomyelitis. So the first patient tolerated it very well. The second patient ended up with a below-knee amputation because of the osteomyelitis and had a fatal pulmonary embolism 2 weeks after that. The complication here, the risk was not much different. It was slightly higher in the patient that I did not operate on, but overall, it did not. Both of them predicted less than 1% chance of a pulmonary embolism. Here's a 42-year-old white female, comorbidities you can see here, pretty lengthy, recently diagnosed with lymphoma, has a history of a DVT, chronic osteomyelitis, had a previous ankle fusion, tobacco and substance abuse. So I can either IND this abscess in the back with her Charcot foot, or I can try and do a septic takedown of the arthrodesis, refuse her with the pantalar fusion and ring fixation. And we opted for the incision and drainage, and we did not use the risk calculator. This was actually, I learned more about this recently when putting this together. And you can see there's a significant change between the two, and the IND certainly is predicted to be the better choice. So this risk calculator is really an interesting thing we should be looking at to make better decisions and help us make those better decisions. And so I think overall we have some good opportunities on the horizon, and we have some advancements that have favorable outcomes. The offloading device to improve adherence and our risk calculator for surgery. I think we need to expand on the current research. We have some medications here that are anabolic and can help with bone growth, bone remodeling, and maybe can really change the paradigm that we have now. But we need to continue investigating this further because these technologies or advancements are still very young and can do a lot more for us. Thank you.
Thank you, sir. Thank you, sir, for a very nice presentation. And I think this is something which we really need in the clinical practices, how we can early diagnose and what are the treatment modalities or early diagnostic modalities for diagnosing a Charcot's foot. Because we all know that early we can diagnose this disease, early we can rectify that and patients will be benefited by that. Thank you so much. We'll take the question answer. There are some few questions for you, Dr. Labovitz, or we'll take at the end of the session. Over to chairpersons.
Well, our next speaker is Dr. Jarrod Shapiro from USA, and I'm really honored to introduce him. Dr. Jarrod Shapiro is a doctor of pediatric medicine and fellow of American College of Foot and Ankle Surgeons, as well as fellow of American College of Foot and Ankle Orthopedics and Medicine. He is a renowned podiatry specialist in Pomona, California, and is specialized in reconstructive rear foot and ankle surgery. Dr. Jarrod currently practices at Western University Foot and Ankle Center, and at present he is Program Director, Chino Valley Medical Center of Podiatric Medicine and Surgery. As an excellent teacher, Dr. Jarrod is a recipient of so many excellence awards in teaching, as well as Faculty of the Year awards from Western University of Health Sciences. With this fabulous background, today Dr. Jarrod is going to share his experiences and speak on surgical offloading of diabetic foot. Over to Dr. Jarrod Shapiro.
Thank you very much, Dr. Kumar. Again, thank you everybody for having me. I'm very excited to be here and participate today. So I'm going to get right to this. I am going to be talking today about surgically offloading the diabetic foot. So my question to start this out would be, how would you treat this? You know, this is a pretty common diabetic neuropathic ulcer in this. This is actually a 31-year-old diabetic type 1 male, very active. You can see uninfected, and this can become quite an issue if it becomes infected. You know, this leads down that road towards amputation, what we've been talking about. So I'll ask you how you would kind of look at that as far as treatment. And what I'd like to do is to maybe be a little confrontational or a little questioning today, and to make an argument to you that in many cases, not all of course, but in many cases, surgery is superior to non-surgical care always in the right patient population. So I'm going to make 3 arguments to you today, that this is a very challenging patient population with very high stakes, that when surgery is approached in a rational manner, it is oftentimes effective. And the idea of something being non-surgical being conservative is not necessarily true. Sometimes surgery, because it's more effective in many cases, it is the more conservative option. And then, of course, rational surgery is safe enough, and I'll get to what enough means shortly. So I think we've been talking about this quite a bit already today. We've been hearing about this pathway towards amputation, where you have neuropathy and deformity leading to increased plantar pressures that leads to local tissue trauma, ulceration, and then infection sets in. Amputation is oftentimes will occur. And we can really look at stopping each of these at different aspects, different time points. But really, the further we get down this pathway, the harder this gets. So it's really easier to, stop this at the beginning, where the deformity and the neuropathy really are. Of course, later down the line, we can still intervene in many cases, but it becomes a little bit more challenging. So if we can eliminate deformity, we'll really have a significant effect on neuropathy, on the diabetic foot outcomes. So let's start with this first argument. This is definitely a challenging patient population. They have a very high likelihood for ulceration. Pressure and shear are detrimental to these patients, and really non-compliance is the rule, as opposed to something that we might see with just a few patients. So very challenging population. I know we've heard quite a few statistics already. 15% of diabetic patients will develop an ulcer at some time. In some cases, this can be as high as 50%. 2 to 6% will develop an ulcer yearly. If you think about that, the estimation that in 2030, this will be 6.9 million people. I think that's probably even an underestimation of what we're anticipating. So very difficult, unhealthy population in the first place. This population is rife with pressure and callus. Murray in 1996 was the first to show the presence of a callus strongly predicts a future ulceration. So they had looked at 63 patients with diabetes and neuropathy over a 15-month period, and they found an increased relative risk of 4.7 if the patient had increased plantar pressures, but an increased relative risk of 11 times if the patient had a callus. So imagine, just that the callus is really that indicator to you that something is going on that is really an issue and a significant risk. Of course, if they've had a prior ulceration, that relative risk in this study increased almost 60 times. So just having had that prior ulcer is enough to almost guarantee that another one is going to happen. So we know a variety of deformities can affect the lower extremity, hammer toes with buckling of the digits, an abnormal metatarsal parabola, plantarflex metatarsals, Aquinas, a number of others. Charcot arthropathy creates, as Dr. Leibovitz mentioned, a number of really significant deformities. There are so many of these, bunions as well, Taylor's bunions, other bony prominences, all create increased pressures with neuropathy leading down that track eventually towards amputation. And I think has been mentioned very well by a couple of our speakers today, that non-compliance is very significant. So this study by Armstrong from 2003 looked at a longitudinal study of 20 diabetic patients. They placed a pedometer on their hip and in a removable cam walker. And as was mentioned previously, only 20% of the time that patients were walking at home, they were wearing the cam boot. And the highest utilizers in the study only wore their cam boot for 60% of the time. So considering how rapidly loss of the pressures and walking, how rapidly those deformities will lead to worsening complications, then we know that really patients are functioning in a very non-compliant fashion already. So again, in 2001, Armstrong also looked at patients who had a prior ulcer history. They wore a pedometer, and this was looking at shoes. And if patients wore their shoes, 85% of patients wore their prescribed shoes outside of home, and only 15% wore them inside the home. But interestingly, the patients took the majority of their steps per hour outside the home, but the greater number of total steps when in the home. So really, they're spending the majority of their time outside of the shoes that have been prescribed to them. I mean, the lectures previously at our prior session really talked about how effective these off-weighting modalities are. But if patients aren't wearing them, then it really doesn't matter how effective they are. So really, non-compliance is the rule and not the exception. Now, as mentioned, there's really a lot at stake. So the odds ratio from Adler's study in '99 showed a 5.7 times increased odds ratio for an amputation after an index ulceration. So having an amputation really significantly increases the risk for amputation. And we know this very well, this statistic that 84% of non-traumatic limb amputations in diabetics were preceded by an ulcer. So really, if we can prevent that ulcer in the first place or do something to mitigate this, then we can be very effective. But really, not doing something or allowing the situation to progress rapidly really will lead to unfortunate circumstances. Some more statistics here. So 34% of patients will develop an ulcer within 1 year of healing their index ulcer, and 70% at 5 years. So really, having had an ulcer essentially guarantees that next ulcer. A contralateral limb amputation has a 50% chance of occurring on the opposite limb if that occurs. This is just terrible numbers for a patient. And then these mortality rates are not great. So Malik in his study in 2003 saw 3-year 50% survival rates and 40% at 5 years. But what I find really interesting was the work that was done by Dr. Armstrong and his group. In 2007, they published this very interesting study that compared the mortality rates of patients who have diabetes with those with other types of diseases, so specifically cancers. And you can see that these mortality percentages are worse than certain kinds of cancers. Look at the limb amputation and colon cancer are almost identical. So really very bad. Then just recently in 2020, they updated this same work and they looked at all cancers and compared that with diabetic foot ulcers, major amputations, Charcot. You can see that these outcomes are really bad. The 5-year mortality percentages with even a minor amputation in the foot is somewhere near 50%, which is worse than all, kind of a grouped, pooled all cancer. They actually went a step further than they did with their first study and discussed the fact that a diabetic ulceration is actually an independent risk factor for early mortality. So not just that it is a sign of diabetic complications being worse and malignant in its comparison with cancer, but now it is even considered its own independent risk factor, really due to that lack of activity, kind of exacerbating their other disorders. So that was that first argument where we can see that this is a very high risk population at really significant risk of complications. Now, my second argument is really that rationally considered surgery is effective. And I'll talk about some head-to-head studies. This idea of poor compliance is a very poor potential for those non-surgical patients. And then we will discuss some specific examples of methods that remove the patient being more effective. So this study by PGC in '98 was a prospective randomized controlled trial that looked at surgical versus non-surgical care for forefoot and toe ulcers. They had a 6-month follow-up. They looked at 24 ulcers who received conservative care, and they saw that they had a 79% healing rate with a healing time of about 130 days, plus or minus. Then they also looked, the other group were 22 ulcers that received surgical care, and their healing rate was 95% with only about 46 days plus or minus for their healing time. So a really significant difference in the healing rate as well as the speed in which patients healed. These patients underwent things like arthroplasties for the toes and metatarsal head resections. So really, kind of looking at this type of thing, the greater number of ulcers healed, they were faster in the surgical group, and they also just had a larger healing rate. They found that there were no major complications in the study, and the patients indicated a higher satisfaction, which makes sense if they're not spending as much time undergoing their care. So Armstrong looked at a similar kind of situation where he looked specifically at fifth metatarsal ulcers, so plantar neuropathic ulcers under the fifth metatarsal head. This was a retrospective cohort study of 40 patients, and they had a non-surgical group of 18 patients that underwent typical moist wound care and debridement and off-weighting, and then surgical group of 22 patients who underwent a fifth metatarsal head resection. And you can see the difference between the two. The conservative versus the surgical time was much greater at about 8.5 versus about 6 weeks for the surgical time. And the recurrence rate in 6 months was significantly reduced. So 27%, more than 1 in 4 patients had a recurrence because, of course, you're not getting rid of the forces that created the ulcer in the first place. Whereas the surgical group had only a 4.5% recurrence, which really, kind of boils down to 1 to 2 patients. So this was, in their view, the surgical care was found to be superior to the non-surgical care with faster healing and a lower recurrence rate. Similarly, this is a non-surgical study that Armstrong looked at the effectiveness of total contact casts, removable boots, and half shoes to heal neuropathic ulcers. And this was a prospective randomized trial of 63 patients. And interestingly, if you just look at this, the total contact cast is the non-removable version, and then the boot, which was removable, and the shoe were, both of those had significantly reduced healing rates. So they interpreted this as something that forces compliance, essentially removing the patient from the decision-making process or the ulcer healing process would improve patients' healing. So if you took the patient away as a factor, then you would see more effective outcomes, even if it's non-surgical. So as an example, we know that equinus is significant, especially in this population. The glycosylation of the tendon will cause contracture, increasing that plantar forefoot pressure. The evidence really at how effective it is to remove equinus as a force was first looked at by Lin and colleagues, where they looked at 93 neuropathic patients that had total contact casting alone versus a tendo-Achilles lengthening and a total contact cast. Interesting and most important was that the mean time to healing was about 43 days, and 15% of patients with forefoot ulcers failed to heal in 47 days. So within those groups, they had no recurrences in the surgical and total contact cast group versus 4 ulcers in the total contact cast and non-surgical group. And the range of motion of the ankle improved significantly with the surgical side, which makes sense since the equinus is the really limiting factor. And they brought them back to essentially a normal dorsiflexion. So this was found to be, to show that this was a more effective way to take care of plantar forefoot ulcers rather than just total contact casting alone. So a similar study by Mueller in 2003 looked at basically the same type of thing, total contact casting versus total contact casting plus surgical Achilles lengthening. Their results, I think, are even more interesting or surprising, that with the total contact casting alone, their healing was 88%, which is good. It's not bad by any means. But with the total contact casting and the TAL, they had a higher healing rate with a lower 7-month and 2-year recurrence. So this is really saying that taking care of equinus surgically would really remove, to a great extent, the forces that were causing these ulcers in the first place. Very powerful studies, I think. So really, their ulcer risk was significantly less, and that their conclusion was that Achilles tendon lengthening should be considered an effective strategy to reduce the recurrence of neuropathic ulcerations. Now, here's an example of a patient who I took care of. You can see this patient has a very small left-sided plantar medial first metatarsal head ulceration. This is a diabetic neuropathic patient. You can see that there is a hallux valgus deformity on both sides. And what is interesting, I think, about this is that the ulcerated side is a pre-gastrocnemius recession surgical side, while the right side, I had previously performed a gastrocnemius recession for an identical ulceration that was exactly the same. So I did not repair the hallux valgus. I did not reconstruct the foot. I simply did a gastrocnemius recession, which I have found in my hands to be about as effective as a percutaneous Achilles tendon lengthening. Okay, so argument 3 here is that rational surgery is safe enough. And the real concern with taking care of these patients, of course, are their multiple comorbidities and the risks of perioperative care with the higher risk of complications, as Dr. Leibovitz very clearly pointed out. So if you perform these procedures under general anesthesia and you're concerned about the risks of that, we can mitigate those risks by using local and regional anesthesia. We can, of course, have better results when we prepare our surgical patients medically beforehand. And of course, if we pick appropriate procedures, these are oftentimes effective. So yes, general anesthesia is risky. There is an increased overall complication rate with patients with autonomic neuropathy, so we have to be very cautious of that. But another option for that is that local anesthesia is safe, and in many cases, we can take care of these patients under minimal sedation. And they have much lower risk of complications related to the anesthesia. In patients with larger surgical procedures, a popliteal or sciatic nerve block, and in some cases, an adductor canal or saphenous nerve block are very effective procedures to allow complete anesthesia while having the patient very slightly sedated and not worrying about the risks of general surgery. So a question that always comes up is, what hemoglobin A1C level is really effective or more of a risk for patients who are going to undergo surgery? And there are a number of studies that looked at this. So, there's a study that showed that TMA healing was improved at less than 8%. Another study, greater than 8%, was associated with increased skin and skin structure infections. A second one, similarly, a little bit lower at A1C of 7.3%, increased the risk of infection. This study by Hufers showed that for each 1% elevation in A1C, the odds of infection increased by about 1.5 times. Again, similar, this one slightly larger. This one increased the complication rate by about 5% for every 1% increase in A1C. And finally, really in 2017, they indicated a threshold of 7.5 as a concern for increased risk of infections after foot surgery. So if you kind of generally put these studies together, I think you could see that a higher A1C, of course, correlates with a greater risk of complications, and elective surgery is contraindicated in the hemoglobin A1C above 8%. So of course, we try to get as low an A1C as possible, but below 8%, these patients are relatively safe for surgery. We, of course, want to optimize the skin quality for this, whatever surgical procedure we're planning. I think a vascular examination is of course incredibly important, whether you're using toe pressures or pulse volume recordings, transcutaneous oxygen measurements, or skin perfusion pressures. These are very important to determine if the skin and tissues are able to heal. There's some new technology that we're utilizing at Western University that looks at near infrared imaging. And this provides you a sort of a percentage of oxygen and deoxygenated hemoglobin in the skin, and also allows us to sort of get a estimation of the tissue quality and oxygenation. We're currently undergoing some research to help identify the better use of this technology in these patients. So really, conclusion here, rational surgery is safe when you carefully choose the patient and the situation. We, of course, have to understand their history and the risk factors. We need to optimize their healing potential as much as possible. Consider that the general anesthesia does not have to be your primary method of anesthesia in these patients. And the use of preoperative and postoperative prophylactic antibiotics, careful monitoring of procedures, can allow you to have safe surgery. Of course, I only spoke about a few procedures, but there are many available percutaneous flexor tenotomies, metatarsal osteotomies that may be used to off weight, joint arthroplasties, removal of sesamoids are relatively successful procedures that have shown safety and efficacy. The one problem that we have is that the majority of the studies on these patients are retrospective in design. And of course, they're not going to be as well controlled as a study about medications. So we have to consider that there are some limitations to the research, but the overall overwhelming majority of these procedures appear to be reasonably safe, but very effective for patients. So bottom line here is this is a very high-risk patient population. It requires a maybe more rapid response to help take care of these patients. There is research that shows us that surgical treatments may be more effective than their non-surgical counterparts. If we plan our surgery, it can be very safe and effective in the correctly chosen patient. And we have to consider that diabetic complications are really as serious as many cancers and sometimes worse, and should really be treated as aggressively as we treat cancers. So with that, I thank you very much for your attention and your time today. Well, I think we'll take questions at the end of this session. Thank you very much.
Yes. Thank you, Dr. Shapiro, for the very nice illustrations on surgical offloading. And I think that is a very important part in any diabetic foot ulcer management, mainly on the forefoot ulcers. And really also, we have also seen by procedures like TAL and GR, really we are able to offload the pressure on the forefoot area. And all diabetic foot surgeons should use these technologies to heal these patients very quickly. Over to Dr. Ravinder Kumar, sir.
Thank you, Dr. Jarrod, for an excellent talk, and that really enlightened us so far, considering the offloading, surgical offloading of the diabetic foot patient.
Yes.
We
We'll
know that.
invite Dr. Manoj Gupta.
Yeah.
Dr. Manoj Gupta, sir.
Yeah. Am I audible?
Yes.
Yes, sir. Let me take this opportunity first to congratulate Dr. APS Suri and his team to arrange such a beautiful and excellent gathering of people all around the world. I, being a hyperbaric physician, I'm very passionate about this topic. Let me introduce Dr. Bob Bartlett from USA. He will be speaking on role of hyperbaric oxygen therapy in healing wounds. He is a chief medical officer from Swift Medical Restorix Health, USA. He is president of American Hyperbaric Society. It's a good thing. 360 Health Source USA and many more similar activities he does. He runs an excellent online HBOT course for many years. Sir, honored to be chairing your session and handing over the platform to you. You can take over the session, sir. Thank you very much.
Surgeons have sought for centuries ways to accelerate healing, but in the end, they have merely restored it to nature's normal period. Hello, I'm Dr. Bob Bartlett, and it is my pleasure to be on the faculty for the Indian Podiatry Association 2021 conference. In this session, we are going to review the role of hyperbaric oxygen, and specifically the science behind the therapy. If one reviews the typical cascade of events associated with wound healing, the hemostatic phase, inflammatory, proliferative, and remodeling, and views it from the perspective of oxygen, it is quite revealing. The hemostatic phase. This phase, characterized by platelets and fibrin, interferes with the flow and delivery of oxygen. The inflammatory phase, as neutrophils, macrophages populate the wound bed, they increase the demand for the consumption of oxygen. And finally, the proliferative phase requires oxygen for the formation of collagen, which is the foundation of angiogenesis. So it becomes readily apparent that oxygen
is indeed the rate-limiting step. In this session, we are going to take a very rapid-fire, concise review looking at the scientific evidence for hyperbaric oxygen therapy. And in my experience, what I have found is if individuals understand the scientific rationale, they can almost intuitively predict where HBO would be of benefit and correspondingly where it would not. In this session, we will look at the positive effects of HBO for granulocyte clearance of bacteria. And certainly bacteria interfere with the normal phases of healing. We will also look at oxygen as a powerful cell signal, the effects on fibroblast activity, collagen production, VEGF or vascular endothelial growth factor production, and the exciting new chapter on stem cell. The killing capacity of the granulocyte is normal only to the degree that oxygen is available. There have been numerous studies that underscore this, and here are a few of the more prominent ones. Hone, using CGD leukocytes, or chronic granulomatous disease of childhood, was able to illustrate the relative contribution of oxygen. Children that suffer from CGD have leukocytes that specifically lack the oxidase capacity to transform oxygen into superoxide radicals. And superoxide radicals really drive most of the killing capacity of the white cell. Here you see the kill capacity of a CGD leukocyte, and compare and contrast that to a normal leukocyte. In this study, what they did is they lowered the amount of oxygen to almost zero, and correspondingly and predictably, the normal leukocyte began to behave very much like a CGD leukocyte. Why is this significant? Children with CGD typically will not survive to adolescence without the routine use of antibiotics. So this 50% augmentation of oxidative killing is critical for survival itself. This work by Thomas Hunt out of the University of San Francisco underscores the importance of oxygen. What the authors did here is they utilized a rabbit wire mesh model, which is very well established. They looked at the performance of clearance of bacteria under three specific conditions. First is hypoxic conditions at 12 to 14%. Second, normoxic, 21% oxygen, and then in an oxygen-rich environment. And you'll notice that the oxygen-rich group by day 4 had a virtual 100% clearance of the bacteria, in this case, staph. Oxygen signaling is the second important concept. Today, we are beginning to understand oxygen in a whole new dimension. When I was in medical school, I was taught that oxygen basically is a metabolite. It's a source of energy, producing ATP, and it's a building block for a few important proteins, such as collagen. I'd like to share with you the pioneering work of T.K. Hunt at the University of San Francisco. And it was his work that really helped us to understand oxygen in a new dimension. In this study, what he did was to create a very clever rabbit ear chamber model to better understand the effects of oxygen gradients. Here in this first condition, we find that the central membrane is closed, the center of the wound is hypoxic, and this, of course, represents the normal state of affairs. They then looked at the healing curve for the normal condition and moved on to a second group of animals. Now, in this group, what they did is they opened up the central membrane, allowing the center of the wound to now become hyperoxic. Now, many of the investigators predicted that this would surely accelerate healing because now there is an abundance of oxygen. But strangely enough, what they found is when the membrane was opened, healing came to a halt. And you can see this here as you graph over time. Here in the green graph is the impermeable cover with the hypoxic center, and the yellow graph indicates what occurs when the membrane is opened. You see there is no migration of blood vessels or angiogenesis into the rabbit ear chamber where the wound is. They then moved on to a third group. Now, in this group, they left the central membrane closed and induced a state of peripheral hyperoxia. And this is exactly what occurs in HBO. We induce a state of peripheral hyperoxia, amplifying the oxygen gradient, in which case we find an acceleration in healing. So the conclusion here is not just molecular oxygen, but it is the gradient, the difference, the gradient that really drives angiogenesis. And whenever that gradient goes flat, the drive for healing is correspondingly flat. So the conclusions: oxygen gradients govern angiogenesis, and the higher the PO2 pressure, the larger the gradient. And of course, angiogenesis stops whenever the gradient becomes flat. Fibroblasts, of course, play an important role in the healing process. So what evidence do we have here on the matter of hyperbaric oxygen and fibroblast activity? Well, this study would be of interest because it uses biopsies taken from patients with normal skin and from patients who have diabetes with neuropathic foot ulcers. And what the authors did is they cultured these fibroblasts and then began to manipulate the oxygen pressures. And you can see that whether it is a diabetic fibroblast or a normal fibroblast, that the mitosis or cellular proliferation increases as we increase the oxygen levels. But you'll also notice here that at each stage that the diabetic fibroblast undergoes a greater amplification, or shall we say recovery, and it reaches a peak performance at about 200 kilopascals, or what we would say in hyperbaric therapy is 2 atmospheres absolute. And by the way, we dose hyperbaric therapy in atmospheres absolute. So the conclusion is that fibroblasts from chronic diabetic wounds proliferate at lower rates compared to normal tissue. However, this difference can be abolished by as little as 1 hour of HBO therapy, and the peak proliferation rate occurs at about 2.5 ATA for normal individuals, but 2 ATA for the diabetic. This, of course, helps to drive the therapy sessions, which for diabetic foot ulcers are typically given at 2 ATA. The production of collagen is fundamental for angiogenesis. In this study, the authors used a wire mesh model and varied the amount of oxygen, 14%, 20%, and 45%, essentially hypoxic, normoxic, and oxygen conditions. Your endpoint is collagen content and angiogenesis. As we move from hypoxic on the left to hyperoxic on the right, you can see that there's a progressive increase in hydroxyproline. Hydroxyproline is the surrogate marker for collagen content. But what's notable about this study is that when we increase the PO2 from 80 millimeters to 200 millimeters, we are only adding about 1% oxygen. However, there is a corresponding increase of 50%. So what is the data really telling us? It's telling us that it's not the content. It is not the content. Rather, it is the oxygen pressure, the pressure that drives the process of collagen production. The next topic is VEGF, vascular endothelial growth factor. Certainly, this is an important factor for angiogenesis. And the question is oftentimes raised, does HBO adversely affect VEGF? Traditional teaching would suggest that VEGF is only produced in response to hypoxia, and therefore adding supplemental oxygen may in fact reduce or decrease the amount of VEGF. But is that really the case? So you'll find this study published in the Archives of Surgery to be interesting. In this study, the authors are looking at the effects of HBO on VEGF productions. And the hypothesis is that HBO actually increases VEGF levels. The model, again, is the now familiar wire mesh model. The treatment group receives HBO at 2.1 ATA for 90 minutes. And by the way, if you're not familiar with hyperbaric therapy, the typical duration is usually 90 minutes. This is given on a BID basis over 7 days, and the authors are looking at wound VEGF levels and plasma VEGF levels. Here is what they found. When you compare the control group to the HBO group, you'll find that the levels are essentially similar on days 2 and 10, but on day 5, they are 42% higher. Now, the reason I share this study is one has to be careful in interpreting literature because healing is a dynamic process. And depending upon when you measure physiologic effects, you may in fact find very different results because the levels of regulators will change based on the phases of healing. So the point here is that at day 2, VEGF is not being expressed, therefore we would not expect to find any significant difference. However, on day 5, VEGF is being expressed and we find that there is augmentation or amplification of VEGF levels. And correspondingly at day 10, VEGF levels are coming down and other signals are now going up. In fact, when you look at the various growth factors that are produced, platelet-derived growth factors, vascular endothelial growth factor, transforming growth factor, and you map this over time, it oftentimes looks like a sheet of music with various notes that are coming and going in a specific rhythm or cadence, all of which ultimately drives healing and repair. So today we're really arriving at a whole new concept of oxygen, more than a metabolite. As I shared with you earlier, when I was in medical school, I was taught basically oxygen only does 2 things. It is a source of energy and it is a building block for a number of proteins, collagen being the most notable for wound healing. You know, it's only been 20 or so years since 2 American scientists were awarded the Nobel Prize for the discovery of nitric oxide. And what was so significant about that discovery was the understanding that a gas could be a cell signal. And today we are now understanding oxygen as a gas that also behaves like a cell signal. You may ask, what is the evidence to support this? Well, here is some work by Bonamo and colleagues looking at upregulation of platelet-derived growth factor receptors. There's nothing metabolic about receptors. Here's some work by Gibson looking at dose-dependent effects of oxygen on angiogenesis by VEGF. Work by Siddiqui looking at HBO increases in nitric oxide production. Other authors, such as Renstra, have noted that HBO facilitates the proliferation and expression of epidermal growth factor receptors and PDGF receptors. Tompac, single dose of HBO, 72 hours of fibroblast proliferation. Now, a metabolic model simply cannot explain this. Under a metabolic model, we understand that oxygen may continue in tissues at an elevated level for perhaps 1, 2, or maybe even 3 hours post-treatment. But it certainly does not continue to be elevated for 72 hours. So the question is raised, what is driving this proliferation of fibroblasts? It certainly is not a simple metabolic explanation. Something more profound is occurring at the genomic level with expression of fibroblast proliferation. And today we're really arriving at a very exciting chapter in our understanding of oxygen, and specifically hyperbaric oxygen. And that understanding is a recognition that HBO is actually stimulating stem cell production. And today, the modern concept of healing is that it is not just driven locally, but much of the repair process comes by way of stem cells. And the source of these stem cells is typically the bone marrow. From a distant land far, far away, it is the stem cells migrating from the bone marrow to the wound bed that drives much of the regenerative process. This work by Steve Thom underscores the profound effect of hyperbaric therapy as a signal transducer for stem cell production and migration. Now, the marker used is a CD34 marker, and this is simply a standard index for identifying those cells that are stem cells. And you'll notice here, with each HBO treatment, the post-treatment level of stem cells is higher than the pre-treatment level. But the second observation, which is to me really extraordinary, is that you'll notice that as the number of treatments accumulate, the total number of stem cells becomes larger and larger and larger. And this is what I refer to as a geometric effect or cumulative effect. So today we're really understanding oxygen in a whole new way. And of all the elements in the periodic table, oxygen is uniquely positioned to influence numerous biological processes because oxygen is so perfectly balanced. If you were to pick any element in the periodic table, I think most of you would pick oxygen, as nature has done, because of the beauty and symmetry of the orbital shell and its unique interactivity. You know, there's a reason that the noble gases are referred to as noble gases. And they were referred to noble gases because of their lack of reactivity. They simply would not combine with other elements in the table. And oxygen is unique in that capacity. Now, in terms of the typical indications for hyperbaric therapy, I'm sure many of you have heard of these before: gas embolism, carbon monoxide, decompression sickness, and so on. The ones that I would really like to focus on in the remaining time here are those that we specifically turn to for difficult wound healing situations. And specifically, they would be traumatic crush injuries, the infectious problems of gas gangrene and necrotizing infections. Those patients who have been treated with radiation therapy for cancer can go on to develop delayed radiation injury syndromes. And then there are the patients with arterial insufficiencies that cannot be adequately addressed using vascular angioplasties or bypasses, patients with difficult cases of osteomyelitis, compromised grafts and flaps, which are typically used to cover amputation sites.
Have we lost the connection?
Avinash?
No, sir, it's over.
Thank you so much, Dr. Bob Bartlett, for a very nice presentation. It's a really hyperbaric oxygen is something which in India also we are trying to promote that. Now there are many centers in India. Dr. Manoj Gupta is one of the pioneers in hyperbaric oxygen therapy. Fast comments from you, Dr. Manoj Gupta, and then we'll Over to Dr. Manish.
Thank you, Dr. Bob, for such a wonderful, hello.
Yes, yes.
Such a wonderful talk on hyperbaric oxygen therapy. India still lacks hyperbaric treatment, the number of machines in India, and I maybe in future, maybe we'll have a lot number of machines. One question what I had in my mind, somebody had also asked in our chat box, what is the difference between hyperbaric oxygen therapy and local oxygen therapy or topical oxygen therapy? Can you throw some light on this, Dr. Bob? Hello?
Unmute, sir, please. Please unmute.
Yeah, we can take your question just after Dr. next.
No problem. No problem. No problem.
Over
Thank
to
you
Dr.
very much. Thank you very much.
Yes. Welcome, sir. Welcome.
Yes. It's my privilege to introduce Dr. Valerie Marmalejo. She is a podiatrist and certified tissue bank specialist, and she has been worked with a military treatment facility, serving her active duty and for retired military and their dependents. It's one of the privileged work, and her final position was as a chief of limb preservation service, being the sole podiatrist working within the vascular and endovascular surgery services. She has academic interests like practicing focused and advanced surgical management of chronic wounds below the knee, including Charcot reconstruction, partial foot amputations, advanced tissue flap techniques for wound closure, and split thickness skin grafting. She has achieved a lot more things. She has published a lot more literatures. So over to you, ma'am.
Thank you so much. Much appreciated. Let me share my screen. Or am I good? There we go. All righty. So I am pleased today to speak to you about Dermacell, the best solution for complex wounds. I had a great introduction. I appreciate it so much. So I'm not going to recap any of that. I will add on that I am the clinical wound specialist for LifeNet Health, covering the Western region. So I provide education specifically on our advanced wound care products, Dermacell being one of those. So Dermacell is an acellular human dermal matrix. So this is dermis that is taken from our stringently screened donors. It then undergoes LifeNet Health's patented and validated matricell technology. So that is where we guarantee removal of a minimum of 97% donor DNA. So with that, what you're getting is healthy human dermis. We don't alter the structure or signaling. We just remove those components that the patient could potentially have a reaction to. So when you're putting it on a patient, they see it as human dermis and are able to grow rapidly in that. This is also very easy to use. So room temperature stored, it's already hydrated. So it's literally an open and apply graft. It can be used on a variety of wounds, head to toe. It doesn't matter the etiology or the location. And really the niche for this product are your full thickness wounds, whether or not you have exposed bone or tendon. So you can use Dermacell over exposed bone and tendon. So I really want to highlight the difference between Dermacell and split thickness skin grafting. When I practiced, I did a lot of split thickness skin grafting. My patients were not always too happy about that. And we'll talk about that in a couple of other slides. But optimal, especially in your diabetic foot ulceration population, is not only healing that initial wound, but ensuring we're maintaining a functional limb that is less likely to have any potential for recurrence. So for a split thickness skin graft to work, it's optimal that you have that granular base that is even with the skin surface. You need that. So if you're looking at your time period to heal in diabetic foot ulcerations, about an average of 5 weeks. That's been shown in a meta-analysis of over 750 diabetic foot ulcerations. Dermacell is unique in that you can use it from the start to the finish. So Dermacell can be used to rebuild that dermal bed as well as help the wound re-epithelialize. So we've shown that in multiple studies. I really want to get to the cases, so I'm not going to go too much into these next two slides, but our studies are very stringent in healing and showing both healing rates as well as average wound area reduction. And everything I always tell everyone in our studies is that we've never gone beyond 2 applications. So we really are a single application product, 1 application to complete resolution. So when to use Dermacell as opposed to split thickness skin graft. And really you can break this into 2 broad categories, which are patient and then wound specific. So number 1, patient, you're looking at a patient with comorbidities. It's been shown that patients with diabetes have a 5-time greater risk of complications when doing a split thickness skin graft on this patient. We've heard from multiple speakers, everything that puts these patients at risk for delayed healing. And with a split thickness skin graft, you're now not only dealing with the wound, that's the recipient site, but you're also creating a donor site for that split thickness skin graft. Patient apprehension. So the number 1 thing, if you look with patients, is their apprehension of having a second wound. So I'm already having difficulty healing one, and now you're telling me I'm going to have a secondary wound. Also, they're very painful. So in my patients, I actually attained my split thickness skin graft from the anterior thigh. And even in my diabetic patients, it's a very painful site and it's not very pleasant for them, which all goes into patient quality of life, healing, all those things. And then again, like I said, you're really not just looking at healing that initial wound, but we want to ensure we're minimizing any potential for recurrence. So this leads into our wound specifics, but one that I will talk about is post-operative complications with the donor site. So infection is a big one, delayed healing. I had a handful of patients myself where the recipient site for the split thickness skin graft healed. My donor site was still not healed. So now I'm working on, again, healing this secondary wound. Looking at the wound specifically, so exposed bone and tendon, you should not be doing a split thickness skin graft over. Split thickness skin graft does need that granular base. That's how it's getting fed and it will reside. You also want to be careful over areas where you're over a joint. We know that split thickness skin grafting is going to contract as it heals. So we don't want any potential of limiting motion of a joint that could lead to decreased function of that limb. Any significant size, so the bigger your wound is, the larger your donor site has to be. Depth, again, we want to minimize recurrence. So yes, you can put a split thickness skin graft on a wound with some depth, but that's not going to fill in. You really need to build up that base first and then cover over with a split thickness skin graft. And location on the foot, plantar foot, that's specialized skin, that skin that's made to weight bear. So long-term results of split thickness skin grafting on weight-bearing areas of the foot are not good. Again, we're looking at not just healing a wound, but minimizing any potential for recurrence. So just highlighting here with Dermacell. So exposed bone and tendon, I'd mentioned that. I'm going to show some cases of how that works where you're able to use Dermacell to help develop granulation tissue over those exposed structures. And then with our Matricell technology that Dermacell goes through, where we remove that minimum of 97% donor DNA, we reduce that inflammatory or immunogenic reaction. And it's that inflammatory reaction that leads to fibrosis and scarring. So we're able to minimize that scarring. Again, so we can use it to promote granulation tissue, promote wound contracture, and also reepithelialization and resolution of that wound. There is no donor site, so we're really the closest thing to a skin graft without making that donor site. And really the risk of infection has to do with having that secondary donor site. So high, around 17% reported in the literature of infection with donor sites. So this is the part that I love. I love to talk about these cases, so I'm excited to go over this. This one here is a great example of how we use Dermacell to promote granulation tissue over that exposed tendon, as well as wound resolution. So the big thing is that we have beautiful debridement, not only of the wound bed, but also those wound margins. So they have to be fresh. They cannot be rolled. We can't have a pibbly. We have to have great fresh wound margins where we can overlap Dermacell so it can help and act as a bridge for that cellular infiltration and vessel ingrowth to occur. This is what we should look at about 1 week. So we want to see that Dermacell is nicely adhered to the skin. You can see we obviously have great coverage of that tendon, which is critical. Tendons being avascular structures, that's usually where your infection will start to track up. So I used to tell my patient, that's like a freeway of infection up your leg. So if we can get that tendon covered, it's optimal. And here we see with Dermacell, as I mentioned before, with a skin graft, you need to build that granular bed first. You're not going to skin graft over a tendon, or should not be skin grafting over a tendon before you get resolution. Here, Dermacell was able to not only create that granulation tissue over the tendon, but also lead this wound to resolution here at 12 weeks. The other thing I will point out, this is anterior leg that was over extensor tendon. And you'll notice, so there is considered, we don't want any fibrosis or scarring or limitation of motion at the ankle joint. And we see minimal scarring and contracture here with this wound that is healed. The second one here is a patient that came in presenting with gangrene that necessitated great debridement, which this doc did, so that the entire, basically, dorsum of the foot and a few of the digits as well. So this provider actually did negative pressure wound therapy just to help clean that up and start to promote some granulation tissue, but still obviously had exposed tendon and bone at the dorsum of the foot. So here you see Dermacell was applied to cover those areas of exposed bone and tendon. That's where the surgeon was the most concerned to get adequate coverage. And then they reapplied negative pressure over Dermacell, which is great, because you need to bolster that into place, very similar to split thickness skin graft. So here's 1 week later, 3 weeks later, building up that nice beefy red granulation tissue, and then 6 weeks later. So now we have this beautiful granular bed, pretty much even with the skin surface. And the surgeon at that point in time decided, let's take this big wound, make it smaller. We'll do our split thickness skin grafting then. Studies have actually shown that if you use a product like Dermacell first to build that dermal base before skin grafting, you have less potential, significantly less potential for recurrence, because you don't get that contracture, the dells filled in, all of that, better texture and turgor of the skin as well to help prevent any recurrent ulceration. Very similar case, this patient again came in with infection necessitating removal of the 4th and 5th ray. I wanted to show this here because this is a beautiful example of a bolster dressing. Again, you treat Dermacell when you apply it, very similar to a skin graft. You got to bolster it not only to the wound bed, but to those freshly cleaned margins of the wound. And then this bolster dressing should stay on no less than 4 days. And here we see at 1 week. So again, this is not something you really want to skin graft at this point, because you still have some depth to this wound. It is a little bit moist, and the surgeon did, apologies, put that on the the silicone layer. That's what I'm looking for. The silicone layer he put on top. So he stopped use of that at that time. Here we are at 3 weeks. So again, starting to build up some of that dermal base. And then 6 weeks, and we can see, so again, at 6 weeks, beautiful red granulation tissue. At this point, the surgeon did decide to finish this with a split thickness skin graft. And so our last image here, he did the split thickness skin graft at 6 weeks after Dermacell application. So we're 5 weeks later, 11 weeks post Dermacell application. And you can see he did get some contracture with that skin graft, which again, we talked about, you had to think about the best time to put a skin graft on is once you got a really beautiful granular base that's even with the skin surface, just to help minimize that. This one here, this is a young lady who was in the ICU due to COVID. So on a ventilator, placed prone, and developed a pressure injury on the face. So you can see there the depth of this wound pre and also post debridement. not optimal for placement of a skin graft at this time, just because of the depth at that wound. This is a young lady, this is her face. We have to think not only about healing the wound, but long-term cosmesis. This is something someone's going to see every day in this young lady. So here we are 1 month out, and with this case, I like to show that even when they applied this, they used a meshed graft, did not stretch out the mesh significantly. They also did not bolster well into those dells that we saw in the wound. So she actually developed a hematoma beneath the graft that they needed to evacuate. But even with that, we still got adherence of dermacell. We're still making forward progression. And this is her wound at 2 months. So again, this is actually all dermacell. So remember, I told you the dermacell could take you to building that granular base and then reepithelialization. So she did not need a skin graft at all, which was optimal because she's already had enough medically going on in her life for the past 2 months. But she has this beautiful fill-in. She obviously will always have a scar, but that redness should also subside with some time. This case here is actually in the realm of patient apprehension. So our surgeon here typically does do split thickness skin grafting. He did not want to do that on this patient because he felt the patient just was not going to tolerate having that donor site, just the pain and having the upkeep and post management of that. So after he did the soft tissue sarcoma resection, he applied negative pressure for 5 days and then did this dermacell application. Put negative pressure on again for 8 days total. And this is what she looked like at the first visit post-operative 8 days later. So dermacell looks great. We're adhered to the wound bed. That's what we want. It's really not anything you want to touch or debride. You would just want to leave it because the patient is going to integrate into this graft. They're going to see this as dermis, acts as a bridge to help with that dermal regeneration. Here we are at 5 weeks. And I just point this out. Sometimes this gets mistaken as slough, typically around the 3-week time frame, but anywhere from 3 to 5 weeks. But you got to look at the wound. So this wound has filled in depth. This wound has reduced in size by 50%. There's no peri-wound erythema, no signs of infection. So all that are signs of healing occurring, which would not happen if there was that much slough or dead tissue in the wound bed. So this is the graft and the patient's integrating into that. So still I tell folks, don't touch it till around week 6. Week 6, then if there's anything that looks necrotic or loose, we can begin debriding, which is what the surgeon did here. So you can see this pre and post debridement 6 weeks after application of dermacell. Again, great. We filled in that depth totally. We definitely got wound contracture going on. This is all moving in the right direction. And this is 11 weeks. So she was last seen on May 6th of this year, and she should have a follow-up sometime this month. Surgeon very happy. So able to avoid a skin graft completely in this lady and a single application of dermacell here as well. Negative pressure used the first 8 days. After that, the patient was doing their own dressing changes daily. Xeroform, gauze, Curlex, very simple dressing change. Same here. So this is actually a 10-year-old girl that had a malignant tumor resected from her right buttock, essentially encompassing removal of her entire right buttock. Small young lady, so about 56 pounds at all, very petite. They used negative pressure. They were able to build up that granular bed, which is difficult. So this is an irradiated tissue plane. So she did receive radiation therapy prior to her tumor resection. So we know that that's going to delay healing as well. And they tried to do tissue expanders on her to actually be able to use her own tissue to cover this. And she actually dehisced where that was and extruded one of the tissue expanders. So they did a single application of dermacell, and their goal was to get this wound small enough that they could do a split thickness skin graft. So they were trying to minimize their donor site on this very petite young lady. So at 7 weeks post-application of dermacell, just one, and they did negative pressure for the first 3 days. And then the mother was just doing daily dressing changes, very basic daily dressing changes. They had this 40% reduction in wound size. So they actually were going to skin graft at this time, but then she had her mandatory COVID test, which did come up positive. She was asymptomatic, but her test was positive. So that delayed her skin graft surgery another 10 weeks. So here we are at 17 weeks after a single application of Dermacell, and she has 70% reduction in her wound size. That area at the superior aspect of the wound is actually where she had dehisced the incision for her tissue expander and extruded it, and it was the first part to heal. They skin grafted her at this point. She was doing well. She was almost healed, and they restarted her chemotherapy, and so her wound broke down. But the only part that she broke down in was where she had her skin graft applied. Everywhere that she healed with Dermacell remained healed. This is my last case here, which I love because it's a kind of a combination. So we got both our skin graft and our Dermacell application here. And they don't have a mesher, so they weren't able to mesh this skin graft. So we have skin graft applied to one side, Dermacell on the other. And you'll watch as the skin graft heals that it pretty much, where it was placed, that's where it healed. The rest of that epithelialization transition was coming from the Dermacell side. So we see at 5 weeks and then 9 weeks post-application. So Dermacell was able to help that epithelial creep to meet the area of that skin graft. And again, minimal scarring with that. And that's really our tissue processing technique to remove the donor DNA in the graft. So in summary, when do you use Dermacell? Essentially, it's anytime you want to facilitate rapid cellular infiltration, rapid blood vessel ingrowth to help promote not only granulation tissue formation, but reepithelialization. We got to take into account both patient and wound factors. So remember, our diabetic patients, 5 times greater risk of complications with skin grafting. Our patient apprehension, that secondary donor site, which is painful, can have delayed healing, potential for infection. And again, we can't skin graft over exposed bone and tendon. Any wound with significant size or depth or plantar foot, we would want to do something where we can have the patient grow in on their own. Again, I appreciate the ability to speak at this conference. My contact information is there if you all have any questions, and it's been a great pleasure. Thank you so much.
Thank you, Dr. Valerie, for a very nice presentation. In fact, we have been also using Dermacell for many of our patients. Yeah, similar to your last patient case of malignant melanoma, I'm going to share a case in the workshop session where similar case we have done on the plantar surface on the foot, on the heel. So nice to share these cases with you. And if you be joined in, or otherwise I will send you on email, I will send you these cases. Thank you so
I'd
much.
appreciate it.
Yeah, thank you so much for joining. And we will thank you all the speakers for this. So thankful for Dr. Jonathan, Dr. Shapiro, Dr. Bob Bartlett, who couldn't join, but he has sent us the hyperbaric oxygen on recording, and also Dr. Valerie. So over to Dr. Manoj and the chairpersons for the session.
Thank you very much for all the speakers. Let me take this opportunity again to thank Dr. APS Suri to have such a wonderful gathering of people from national and international level. It's an honor to be a chairperson for international faculty, and I would like to thank again all the delegates also for attending such a good conference and taking the knowledge back to your patient. Thanks a lot. Thanks a lot for everyone.
Take the question. There's a question in chat box for Dr. Bob Bartlett. You can.
I think he's not there.
Yes.
There's a question whether hyperbaric oxygen is better than topical oxygen therapy, or whether hyperbaric oxygen therapy is better than the topical oxygen therapy. Let me clear to you. Hyperbaric oxygen works under pressure. There is a pressure in the chamber which helps oxygen to reach the location wherever there is a wound. It stimulates the stem cell to get mobilized in the region wherever there is a wound. However, the topical oxygen therapy will not work at the same level. It may help in the local wound, which is small in size. But if there's a huge wound, it requires a lot of pressure to push oxygen into the blood circulation and to reach that area. So hyperbaric oxygen is always better than any topical oxygen therapy. There were some studies which were conducted in India in the past, but it did not work well. But however, there are some publications which shows that topical oxygen may help in smaller size ones compared to bigger size ones. That is my answer on this. I don't know what the opinion other people may have. Thank you very much.
Absolutely. I've also tried at my center also in few patients, and we have given hyperbaric oxygen therapy, and the similar patient we have got topical. Topical also works. We can't say that topical oxygen doesn't work, but if you look at the pressure, that is more in the chamber when the patient is inside the chamber. So if you have the assessment, because hyperbaric won't be available at all cities, smaller towns. So if you have the assessment of hyperbaric chamber in your city, near to your city, try to get that. Otherwise, topical oxygen is also good enough. There's another question for Dr. Valeri from one of the very experienced plastic surgeons. That is skin grafting needed in all cases after dermacell?
No, it is definitely not. So the one example of the young lady that had the wound on her face, that was only dermacell. So dermacell can be used to promote your granulation tissue and then take that wound to final resolution without the need of a split thickness skin graft.
Yes.
None of our studies, including in diabetic foot ulcerations with exposed bone and tendon, they have just been with dermacell only, no split thickness skin grafting.
Yeah, that's the beauty. That's the beauty or the glamour of this technology of dermacell, that it helps in the granulation tissue formation and also epithelialization, as compared to, if you have seen the slide which Dr. Valeri has showed, as compared to Apligraph or others, it has got the activity of granulation tissue with epithelialization. Similarly, in your case, which you have showed a sarcoma on the lower leg, you see, without grafting, the wound has decreased to about 80 to 90% of the surface area. So epithelialization also occurs, but the only thing is we have to wait. We have to go till 8 weeks, 9 weeks, 10 weeks. Don't be in a hurry. So if you allow the patient to epithelialization, it will epithelialize. So it's not needed. Very big wounds, you need to go for skin grafting. But if you can wait, skin grafting, you don't need it. Sometimes epithelialization can occur in these wounds. So that's the beauty of this. So over to chairpersons. Thank you so much, all the speakers, all the chairpersons, Dr. KK Arora, Dr. Mukesh Gupta, Dr. Manish, and everyone, Dr. Renu for being a rapporteur for this session, Dr. Ravinder Kumar, a senior physician from Patna. So we are thankful, IPACON whole core committee, for chairing this session and taking the things forward. Thank you so much.
Thank you very much. Yeah.
Dr. Shrishti.
Thank you to all the chairpersons, moderators, and the respected speakers, Dr. Jonathan Labovitz, sir, Dr. Gerard Shapiro, sir, Dr. Bob Bartlett, sir, Dr. Valerie Morgello, ma'am. Thank you very much. Moving on. Life without industry is guilt, and industry without art is brutality. Every industrial revolution brings along a learning revolution. So let's indulge in our next session, Industrial Symposium. I would like to call on stage our rapporteur for the session, Dr. Renu Chhabra, ma'am. Ma'am runs an independent pain clinic, Dr. Bhatia's Pain Relief Clinic, Hisar. She conducts awareness program for pain medicine. Your presence is very valuable, ma'am. Over to you.
Thank you, Dr. Srishti. Extending a very warm welcome to IPACON 2021 delegates. I would like to introduce chairpersons and moderators for session 9. Our respected chairmen are Dr. Girish Mathur from Kota. He is an senior consultant in internal medicine. He has been a vast... Am I audible?
Yes, you are.
He has been past vice dean ICP, past vice president API, and associate editor JEPI. He is a recipient of fellowships by FACP, FRCPG, FRCPE, and FRCP. Our next chairperson for the session is Dr. Prabhat Pandey. He is a professor in medicine at Sri Shankaracharya Institute of Medical Sciences, Bhilai. He is a fellow member of National API And the next chairperson is Dr. K.K. Parekh, sir. He is a senior patron, a guide for IPA, Indian Podiatry Association. He was president of National API, dean of ICP, president of Rajasthan Forum of ICPs. He has been honored by Honorable Minister of Health and Family Welfare, Government of Telangana, and by Home and Health Ministers of Rajasthan. His orations are Presidential Oration at National IPACON Kochi, Presidential Oration at Annual Conference RSSDI Rajasthan Chapter. And the moderators for this session are Dr. Jimit Vadagama. He is Consultant Endocrine Diabetes and Metabolic Disease at Swami Narayan Diabetes, Thyroid and Hormone Clinic, Surat. He is author for RSSDI Guidelines for Inpatient Management of Hyperglycemia.
Unmute.
Need to unmute, ma'am.
Please.
Please unmute.
I'm unmute.
Madam, unmute, madam.
Madam, Renu, madam, you are muted. Yes, sir. Yes, sir.
He got disconnected.
We need to continue.
Yes, Dr. Jimit Vadagama is a consultant endocrine and diabetes and metabolic physician from Gujarat. He is practicing at Swaminarayan Diabetes and Thyroid Hormone Clinic, Surat. He has been authorized a lot more chapters in RSSDI textbook also. He is executive editor and he is a renowned endocrinologist from Surat. In Gujarat. So just proceed the further session.
Dr. Robin.
Yes. There is a next moderator, Dr. Robin Musky from Nepal. He is our IPA member. We are proud to have you, sir. He is being a physician and he has done a fellowship in endocrinology. He is a fellow Royal College of Physicians in UK, fellow of American College of Physicians US. So welcome you, sir, on the podium. Over to chairpersons.
A very good morning to all. I'm grateful to Dr. APS Suri and Dr. Rajni Saxena for giving me the honor to chair the session this wonderful conference. And our first talk on this symposium, that is the industry symposium. There are actually this symposium, there are very distinguished speakers with us, Dr. A.H. Jargar, Dr. Shalini Jaggi, Dr. Dheeraj Kapoor, Dr. Anand Kumar Suri. So at the outset, I'll invite Dr. A.H. Jargar for his talk on osmo laser technology, what's there for me in diabetes clinical practice. Dr. Jargar is a renowned endocrinologist of the country. He is a senior endocrinologist, Center for Diabetes and Endocrine Center, Srinagar. He is an ex-director and ex-officio secretary to Government of Jammu and Kashmir. He is a past president, Endocrinological Society of India. I invite Dr. Jargar for his talk.
Are my slides visible?
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir, they are visible. You can make it full screen, please.
Yeah, just give me a second. Good morning, dear friends and colleagues. I take this opportunity to express my gratitude to Dr. Suri and his team for making it possible for me to be here today to make my debut on Food Society of India. And after looking at all the work that you guys do and these Valeries, how these feet are managed, I realized that you need to have a saint's patience to be a foot surgeon. A routine human being cannot do it. Now, in the next 20 minutes, what I want to tell you is some new technology that is being used as a drug delivery system in the field of endocrinology and diabetes. Now, many times, when you look at a molecule, the half-life of it might be short, you want to lengthen it. In certain form, it might have certain gastrointestinal side effects, you want to blunt them. So different technologies have evolved over a period of time to ensure that the same drug is delivered in a fashion so that we achieve a maximal, optimal clinical benefit out of that molecule. Now, if you just look at one simple technology, just look at metformin, which we used to use in a huge quantity, continue using it in a regular form 3 times a day. I still remember in 80s and 90s, how many people would abandon using that drug because there were gastrointestinal side effects. And in what percentage of people, we will have to de-escalate the dose of the drug because they would not tolerate it. So literally for decades, I would see that most of the people would not be benefited from a maximal dose of that drug. So different techniques evolved over a period of time. The way, this year we are celebrating 100 years of insulin discovery. When insulin initially was discovered, for 2 decades, it needed to be given like a regular insulin because that's all that was available. Till a new mechanism was found to alter the duration of action of this insulin, and in 40s, Lent insulin and NPH insulin came available. It took quite a few decades to realize that they are not optimal basal drugs. In fact, half a century later, 6 decades later, galargine came in, and then better drugs came in. So in a similar fashion, in different segments of endocrine care, modulation of molecules has happened that has changed the availability of that molecule within the intravascular compartment for different actions over an extended period. A classical example is metformin. So you look at the immediate release drug and then giving a controlled release drug delivery system. All of us have seen those when slow release formulations came in, when people started experimenting with these newer molecules. And what was found out that many times, I'm sure, we have very senior people here, Dr. Parekh is here, I know that. Then many people would complain that the tablet would come back with the stools. And then from that SR preparation came XR preparations because a different technique was used. So absorption was better, predictability of the release was better. But people have been continuously looking at newer innovations, how to make this art perfect. Because otherwise, if this art of or technique of drug delivery in a sustained fashion is not perfect, then there will be unpredictability in plasma concentrations. You also have to keep in mind that there should be no impact on this system, whatever you put in place, by the pH, by the diet. And this is what this new technology is, osmolaser technology, to overcome some of the difficulties that we have been facing with these technologies. And in the next 10 minutes, we're going to talk about what this technology is. This osmolaser technology, what does it offer? Drug release independent of motility, pH, or food. See, we know that people with diabetes might have motility disorders because of autonomic disorder. pH of the gastric contents can vary, so might impact, if the release is pH dependent, might alter it. And if is hampered by the food or needs food for that prolonged action. So that makes also a difficult. So delivery may be delayed or pulsed as we desire, and thereby achieve the target that we want to achieve. What this laser-based technology is, osmosis, all of us know. Fundamentally, it works on the basis of concept of osmosis. If we look at a semi-permeable membrane, imagine now, let's give an example of, let's say, glimepiride and metformin. Glimepiride has an innate long duration of action, 24 hours action. That's how the molecule in itself is shaped. But the metformin is not in the same shape. Now, look at this figure. You give an outer coat of glimepiride, and as it is exposed within the gastric fluid to gastric fluid, this glimepiride slowly, this outer layer gets shed, and the process of its absorption starts. Now, inside that is a semi-permeable layer. And this semi-permeable layer of different tissues is, you can create a smallish holes in this depending on your desire. what will give the, and this whole size is being created and determined as per our design by laser technology. And once this goes into the gastric content, by osmosis, some of the fluid goes within this semi-permeable membrane, which contains, let's say, metformin. And as this swells, it gives a push to the membrane, and slowly and steadily pushing metformin through these laser drill holes, so that metformin starts moving out in a very structured, controlled fashion. You can have one layer of this, you can have more than one layer of this, depending on what sort of a duration of the drug you want to achieve. All of us know, if you look back at the literature in the past, compliance with many drugs otherwise is poor. Compliance with metformin, when we used to give it 3 times a day. I have given hordes of people metformin in 80s, 850 milligrams thrice a day. Did not tolerate it 500 milligrams thrice a day. Did not tolerate it 500 milligrams BD. Did not tolerate it 500 grams once. But that scenario has changed in the last decade and a half. And that scenario is even becoming now better because the drug delivery is becoming better. If you look at the past literature, more than half the people would be hoodwinking with the drug therapy more than half the time. And understandably, if you look at this data, which is a huge data on 1.6 million guys, patients with type 2 diabetes mellitus on metformin were least likely to actually stick to the dose that we were giving them. But this again has changed ever since these new technologies have come in. Understandably, if you are prescribing a drug, if it is not being taken in a way that you and me want them to be, if there is poor compliance, the outcomes cannot be good. Inadequate glycemic control. So that inadequate glycemic control will have its own repercussions. Otherwise, also, if you remember back for the last 2-3 decades, we have been talking about less than 20% of people with diabetes in our country having an optimal HbA1c. After really, these new techniques, new educational processes, persistence, this figure has gone up to 1/3, but 2/3 still are not well controlled. And understandably, when glycemia is not well controlled, it would lead to complications. Today, we are seeing doubling of coronary artery disease in the last 2 decades. Fundamental reason, diabetes and dyslipidemia associated with it, hypertension associated with that. In our younger days, chronic glomerulonephritis is the commonest cause of kidney disease. Today, globally, commonest cause of end-stage kidney disease. 60% of renal replacement resources in our country today are consumed by diabetes-initiated CKD. So, in fact, a lot of data published on poor adherence and what it does to the compliance and what it does to the control of the diabetes. And every time we improve the acceptability of a molecule, every time and it's something like, we need to go, let's say, we used to go nifedipine twice a day, then came nifedipine retard, then came amlodipine, cilnidipine. So, in a similar fashion, things have happened in diabetic field also. And this laser technology has in a big way changed even small formulation that you and me have been writing for decades. But with many industrial houses today, with this new technology, the smoothness of the molecule getting into the intravascular system has become more predictable and better. And for metformin, it is being universally used. Combination of metformin is being used. And over a period of time, people are experimenting with more and more molecules to reduce, one, gastrointestinal side effects, and to improve the 24 hours availability of the drug within the intravascular compartment. There's some data that me and my colleagues published only a couple of months back on this particular technology and how we can use in diabetes. This paper is available in public domain now. And all of us know that for the last more than a decade, slowly and steadily, the diabetes market has shifting to gliptins and in the recent years to SGLT2 inhibitors. And gliptins have given a huge relief to diabetologists, endocrinologists, clinicians who take care of diabetes, because In our earlier practice, when sulfonylureas like glibenclamide, chloropropamide were the mainstay of treatment, and those relatively primitive insulin as lenti insulin, NPH insulins were available, hypoglycemia used to be a huge issue. Again, because of that unpredictability of half-life, unpredictability of the level of a molecule within the intravascular compartment. But ever since gliptins have come in, slowly and steadily, a big chunk of people for a long time are controlled on those gliptins, and use of those sulfonylureas has become lesser. And vildagliptin has become universally now available in our own country. And some industrial houses have used the same technique of laser technology for making the vildagliptin, which normally would need to be given twice a day, once a day. In fact, if you remember, Novartis, right from 2006, when they were experimenting it, when they were trying to market it, it used to be given twice a day and needed to be given twice a day. On an average, it will work, give a significant DPP-4 inhibition from 8 to 10 hours. Now, today, gliptins in general and vildagliptin in particular has a definite place in the management of diabetes. And all of us know it improves glycemic control in elderly people. You can use, verified trial shows that you can use it for intense therapy right from the beginning in new onset diabetic patients. And you might not need to escalate the drug for half a decade in half the people. And is very well tolerated because it has a low hypoglycemia. In fact, it was one of the first molecules it was shown to cause a reversible suppression of glucagon. It's a beautiful paper published in Journal of Clinical Endocrinology and Metabolism in 2009. How this suppresses glucagon, and once blood sugars go down, how that suppressive effect is gone, and this glucagon takes care of this hypoglycemia by causing glycogenolysis and gluconeogenesis. As I told you earlier on, in the normal circumstances, we do use this drug twice a day. But if we modify this molecule, and many of the companies in the subcontinent have already done so, all of my endocrine colleagues, all of my physician diabetologist colleagues know that first time globally, the Indian industry has made available a 50 milligram long-acting vildagliptin, 100 milligram long-acting gliptin, so that it could be given once. So all of us know the benefits of giving once, that obviously, compliance would be better, fluctuations in serum values would be lesser, and DPP-4 inhibition would be more predictable rather than episodic. The same. Now, as I told you now, 100 milligram molecule, 100 milligram vildagliptin is now available, like, the way we go sitagliptin 100 milligrams once a day, the way we go linagliptin 5 milligrams once a day, in a similar fashion, now vildagliptin 100 milligrams once a day. Not that the innate molecule's half-life was comparable. No, it is because of this technology, the release is being modified so that it is absorbed over a period of time and does that DPP-4 inhibition over a period of time. And you can just see that, look at that galvus molecule, vildagliptin being given twice a day, that red stuff, and look at vildagliptin being given once a day. Causes equal, both of them cause equal DPP-4 inhibition for more than 23 hours. So really showing that it is comparable if you actually use this technique and use this drug. Again, if you go immediate release like that metformin, you might have a huge DPP-4 inhibition ability, but it gets saturated even 1/3 of that, and then it comes down. But look at that sustained release molecule. The DPP inhibition is for a much longer time. Now, it's actually, just look at this. If you vildagliptin immediate release, you see, you just need 100 to 150 micrograms of this intravascular compartment to give sufficient suppression of DPP-4 inhibition. Now, acutely causes very high increase. This immediate release, if you go 100, doubles up. But this DPP-4 inhibition achieves a saturation at some level, which is 100 to 150. Look at the extreme right. This vildagliptin SR gives us sustained this thing which is maximal for giving maximal inhibition of DP4 inhibitor. So again, one more important thing, if you use this many times, let's say with renal dysfunction, you need a smaller amount of the drug because it has a longer half-life because of progressive renal dysfunction. You can give 50 milligram SR preparation and it will be working for the whole day in that particular patient and will give almost 23 hours, 22, 23 hours DP4 inhibition. Once this molecule is modified, the fashion we talked about. Again, the same thing, vildagliptin 50 milligrams in patients with a renal insufficiency, how they can continue to have that DP4 inhibition ability for the whole day. So in summary, if you look at it, this new technology is a huge add-on on that sustained release and XR release technologies, which are totally two different technologies. They have changed in a big way the way the drugs will be delivered, particularly in the field of diabetes. And I'm sure people will be continuing, the industry will be continuing to explore the possibility of giving these drugs using this other drugs given this technology. I talked about metformin and combination of glimepiride and metformin. We talked about vildagliptin and this thing. So exposure to the drug is less, but adequate for DP4 inhibition. Pill burden is less. And with reduced pill burden, you achieve the clinical target that you set out to do. Thank you so much. This is the road leading from Srinagar to my hometown, Baramulla. Over to the chairpersons.
Thank you, sir. Thank you so much for such an enlightening presentation, sir. Diabetes control is absolutely important in all diabetic food management. Until and unless we cannot control the sugars, we all know that diabetic food not be healed. I just take few seconds with the permission of chairperson. I was in Netherlands many years back. And that time they were the consensus group deciding whether podiatry clinic should be part of a diabetologist clinic or a general surgeon's center. So there were 19 people. I was one of them. And out of 19, I think 16 were of the view that it has to be under diabetologist clinic. Because if a diabetologist is head of the podiatry clinic, the results will be very good. Because we have to plan preventive podiatry. Because you can do prevention by early detection of neuropathy, checking of HB1AC, checking of peripheral vascular disease. Then whole role of all the surgeons will come later on. So that with that, I hand over to the chairpersons.
And Dr. Suri, I must tell you, in late 80s, within half a decade of my endocrine practice, I realized it is not my cup of tea or expertise to take care of a bad diabetic foot. So at that time only I ensured that I had the advantage of a pretty good brand new institute to work in, and that I'm getting in touch with our own plastic surgery department. And from that time till today, there is always a senior resident and a consultant of plastic surgery who is on call for a diabetic foot patient in endocrine ward. Yes. And I must tell you, in my 3.5, 4 decades of practice, I remember less than half a dozen cases where we needed some conservative surgery of the amputation. Those guys did such foot salvage, which was amazing. I one day in a governing body meeting was showing those figures to Omar Abdullah, who was then our chairman governing body. He couldn't believe it that such limbs could be salvaged. Yes. Incredible work. Over to the chairperson.
Thank you, sir. Dr. Prabhat Pandey, sir.
Yeah, good morning. Thank you very much at the outset for including me in this conclave. Thank you, Dr. Jargar, sir. You are always a towering figure in the field of diabetes and endocrinology. Now I invite the second speaker, Dr. Shalini Jaggi. She is a renowned person in the field of diabetology in country. She is a consultant diabetologist and director Life Care Diabetes Center, Delhi. She has been a fellow of Royal College of Physicians of London, Edinburgh and Glasgow, fellow of American College of Endocrinology, member governing council, recipient of National Fellowship Award of Diabetes India and RSSDI 2016, and recipient of the National Diabetes Awareness Initiative Award 2017. She will be speaking on the micro and the macrovascular complications of diabetes. Though this title seems to be very easy and probably have been heard many times at a different forum, but I believe that she will definitely give a newer insight to this title. I invite Dr. Shalini Jaggi for her talk. Dr. Shalini, please.
Thank you so much, Dr. Prabhat, for that warm introduction. And it's really a pleasure to be sharing screen space with the stalwarts of diabetes and podiatry. My greetings to all the senior faculties. Well, like Dr. Prabhat very nicely said, micro and macrovascular complications we would have heard many times, but I'm going to give it a twist. And what I'm going to do today is link both and tell you how it is not one following the other, but it is a continuum that we see in a patient with diabetes. So friends, we've always thought of diabetes as a metabolic disorder. But what we need to see is change our perspective, because diabetes is not only a metabolic disease, but also a vascular disease. So diabetes creates a state of prothrombosis in the body. We know hyperglycemia creates a state of chronic inflammation in the body. There's buildup of oxidative stress, which leads to vasoconstriction and growth promotion. So basically, it is the endothelium-mediated vascular health that gets imbalanced in diabetes, driving the complications of diabetes. So I'm going to allude to the chronic complications of diabetes, which means the micro and the macrovascular complications of diabetes. And we know when it is an insult to the large vessels, we have the macrovascular complications affecting the heart, brain, and the extremities. And when it is an insult to the small vessels, it is the triopathies or the microvascular complications, retinopathy, nephropathy, and neuropathy that the patient may present with. So we all know there is a huge burden of diabetes complications, and Dr. Zargar very nicely said that, we have to be very proactive and look at the patient as a whole rather than looking at just one complication that he's presenting with. And you can see the burden of diabetes, Dr. Mohan's work, which clearly tells us that the complications really can reduce the quality of life and can lead to a lot of morbidity and mortality. Now, generally, we have always considered that micro and macrovascular disease in diabetes have different pathogenic mechanisms, different times of onset related to a diagnosis of diabetes. We may think that they are coexistent partners in diabetes, but not necessarily because of the shared mechanisms of disease. And that is why when we look at the treatment strategies, they may not be aligned when it comes to these complications. So where is the link? Let's look at that. Now we know that the potential mechanism by which hyperglycemia induces oxidative stress, the mitochondrial superoxide overproduction, it causes all these microangiopathies by traversing either of these pathways, the polyol pathway, the hexosamine pathway, the PKC pathway, or the advanced glycation pathway. So what actually happens is hyperglycemia on a background of insulin resistance traversing through these pathways leads to a buildup of oxidative stress, which predisposes to endothelial dysfunction, which is the root cause of all these complications. So there's a reduction in nitric acid, there's a reduction in prostacyclin, increased angiotensin 2. So on the one side, there's vasoconstriction happening in the vessels. There's also a pro-inflammatory release in different cytokines, which leads to a state of inflammation and increased pi inhibitor, creating a state of thrombosis. All of these lead to rampant atherogenesis, atherosclerosis in all the vessels. So when it comes to the origin of CAD, we know hyperglycemia and insulin resistance leading to tissue injury through all these different mechanisms, aggravated by dyslipidemia, all of them eventually leading to a state of atherosclerosis when the patient presents with CAD. So the important question is, we've always thought that macrovascular complications come first, and then when a patient is diagnosed with some amount of dysglycemia, that is when the microvascular complications start, and they go proceed in a linear fashion as the diabetes duration increases. What we need to understand is there is an intersection of microangiopathy and macroangiopathy in accelerated atherosclerosis and myocardial disease. So on the one side, when we say the microvessels are causing microangiopathy, neovascularization, which predisposes to all the microvascular complications that we talk of, we also need to understand that the macrovessels, that means the coronaries and the peripheral vessels, also are undergoing accelerated atherosclerosis, predisposing to hypoxia, ischemia, and there is neovascularization even in the macrovessels, which forms an intersecting point between micro and macroangiopathies. So friends, when you talk of the heart and diabetes, it is not only a macrovascular disease, but there's an orchestra of contributing factors to the development of diabetic cardiomyopathy. So the failing diabetic heart faces complex structural macrovascular derangement such as hypertrophy and loss of function due to glycation, which we usually say is causing only microangiopathy. So it is not wrong when I say the heart in diabetes also has a microvascular origin to it based on the common soil hypothesis of diabetes complications. So on the one side, there's atherosclerosis in large arteries as well as cardiomyopathy in diabetes, which has a microvascular component. And there are changes in the small arteries and capillaries, which are not responsible for only the microvascular long-term complications that we recognize them with in terms of retinopathy, nephropathy, or neuropathy, but also for the other manifestations of heart disease. So friends, the ticking clock hypothesis that we've always been thought of, the origin of macrovascular disease first on a background of hypertension, dyslipidemia, obesity, inflammation, predisposing to dysglycemia. And once dysglycemia sets in, diabetes is diagnosed, there's progression of microvascular complications may not really be true. And there's a blurring and a mixing of the two. So this is a review article that we published on probably 2 decades of work on micro and macrovascular complications linking, which we published in IJM in 2016, and it has been quoted many a times nationally as well as internationally, where we've gone on to propose this hypothesis that probably micro and macrovascular complications of diabetes are not distinct. There's an intertwining, they occur in a continuum. Let me give you some evidence. Look at retinopathy. We know the risk of retinopathy increases in progression based on the severity of both hyperglycemia as well as hypertension. Different studies have now clearly linked retinopathy with macrovascular complications. And the reason for this, retinal microvasculature shares embryologic and anatomic characteristics with cerebral circulation. So that is why abnormalities in the retinal vessels may probably give us a clue to understand the pathophysiology of different cerebrovascular diseases. The ERIC study clearly showed a link between retinal microvascular abnormalities with stroke. Look at some of these studies that I'm going to show you. The VADT study clearly showing that as retinopathy worsens, you see an increase in the coronary artery calcium, which is linked to macroangiopathy. So you have a microvascular complication, which clearly shows a direct link to a macrovascular complication. Again, the ERIC study clearly showing that patients who did not have retinopathy versus patients with retinopathy, the CHD-free life comes down. So clearly a link between retinopathy and CHD. Again, the ERIC data clearly showing patients without retinopathy versus patients with retinopathy. Heart failure event-free proportion comes down if your patient gets retinopathy. So microcirculation is an important factor in diabetic cardiomyopathy is what we need to understand. The famous Blue Mountain Eye study showing clearly how retinopathy predicts coronary heart disease mortality. So compared to patients who did not have diabetes and no retinopathy, if you look at the proportion of patients who had diabetes and retinopathy, you see a much more proportionate deaths in terms of coronary heart disease compared to patients without retinopathy. Retinopathy predicts cardiovascular mortality in type 2 diabetes, and we see it happens in men as well as women, as you can see here. So friends, it's important to understand that retinopathy predicts cardiovascular death, suggesting a common background pathway for both diabetic micro and macrovascular complications. Now look at nephropathy. We know hyperglycemia is an important modifiable risk factor for nephropathy, and even a 10 millimeter reduction in systolic blood pressure can lead to a 13% reduction in microvascular complications. So hypertension, macroangiopathy, microvascular complications, you again see that link here. There's a strong association between retinopathy and nephropathy in patients with diabetes, and we all know that. So there's a direct association between microalbuminuria and the macrovascular complications, which is well established in many data. Increased incidence of cerebral infarction and cerebral hemorrhage in patients with severe diabetic retinopathy and advanced nephropathy has been established. So both nephropathy and severe retinopathy were found to be independently increasing the risk for subtypes of stroke. This is the famous Hoon study, clearly showing how if there is no microalbuminuria, the fraction of subjects alive is much more. And as microalbuminuria sets in, the mortality starts increasing. Look at neuropathy. Now, this is a study which there are a lot of studies which show that neuropathy again has a link to macroangiopathy. There are studies showing that diabetic patients with peripheral neuropathy presented with significantly higher rates of cardiac events and peripheral vascular disease than diabetic patients without neuropathy. We know microvascular damage, occlusion of vasa nervosum, which actually leads to all the demyelination, the damage to the nerve fibers causing neuropathy. Now, how does it get linked? We know PVD, CAD, again, the same mechanisms, endothelial damage, hypercoagulable state, stasis, thrombosis, predisposing to CVD and CAD. So one microvascular angiopathy eventually ultimately leading to a macroangiopathy. Now, this is our own data published in IDF. We showcased this in IDF way back in 2009. Patients with neuropathy, patients without neuropathy, you see in the control group, hardly any PVD, 3.3%. Patients who had neuropathy, simple neuropathy detection by VPTs, you pick up 26.7% patients having PVD diagnosed with ABI. So a large number of complications related to PVD in DM, we suggest that every patient with diabetes with significant neuropathy should definitely be screened for PVD, because we know PVD is an indirect marker for coronary artery disease as well. Again, another study that we published in ADA about a decade back, looking at how patients with neuropathy not only have a peripheral vascular disease, they also have sympathetic and parasympathetic dysfunction. So a direct correlation between distal peripheral neuropathy, cardiac autonomic neuropathy, and association with PVD in type 2 diabetic patients. So friends, all the micro and macro angiopathies that we think are different actually have shared mechanisms. There's a link between micro and macrovascular disease. Neovascularization in the retina, almost same as neovascularization in an atheroma. So neovascularization in both micro as well as macro vessels leads to delivery of adhesion molecules, cytokines, chemoattractant proteins, inflammatory cells, nutrients, LDL, both in the retina and the atheroma, clearly showing a distinct link. So this is some of the work that I'm just going to show you. We keep working on linking lipid abnormalities with microalbuminuria as a marker of optimal care. This is retinopathy linking. This is again a very important study that we just recently showcased in one of the in the ACE. Abnormal ABI in association with nephropathy as a risk factor for CAD in type 2 diabetes patients. Look at this. Patients with abnormal ABI having coronary artery disease. You look at 9.6% patients with coronary artery disease. When they are screened for ABI, you see 31% of them having abnormal ABIs. Again, the ABI abnormality being very high in patients with nephropathy, 32%, neuropathy, 28%, and an increase in ABI abnormality with age. So diabetes patients with abnormal ABI were predicted to have 27% increased odds of coronary artery disease outcome. And this was actually increased to 80% if nephropathy was also present. So friends, it's very important. That is part of comprehensive diabetes care. Screening for microangiopathy should be done right at the time of diagnosis and every year to enable an intervention so as to reduce macroangiopathy, cardiovascular disease risk as well. This is another of our published papers looking at the clustered metabolic approach using A1C, BP, and aortic augmentation index in type 2 diabetes as a tool for risk stratification. Carotid femoral pulse wave velocity actually looking at the hardening of the vessels and having a link with peripheral neuropathy. Another study that we published recently in primary care diabetes, this is just 2021 publication, looking at an association between diabetic retinopathy, microalbuminuria, and other modifiable risk factors. And you can clearly see peripheral neuropathy was observed in 24.2% of these patients, positively associated with retinopathy and linked to cardiovascular risk. So friends, when we talk of diabetes, it is always a continuum. On a background of increased risk for diabetes, complications keep coming in, and that is where you need to understand it is not one preceding the other, but it occurs in a continuum. So my take home, hyperglycemia is the principal cause of microvasculopathy, but also appears to play an important role in causing macrovasculopathy. There's thought to be an intersection between micro and macrovascular complications. The two disorders are strongly interconnected. Microvascular disease promotes atherosclerosis through processes such as hypoxia and changes in the vasa vasorum. Patients with microvascular complications are particularly prone to accelerated atherosclerosis and premature death. Neovascularization arising from the vasa vasorum may interconnect macro and microangiopathy. So friends, when we talk of micro and macrovascular complications of diabetes, I think it's time that we understand these are not two separate entities. They are not distinct, but we propose they are a continuum. And that is why it's mandatory that as podiatrists, as surgeons, as retina specialists, as cardio specialists, we all need to be physicians in the background, and we need to understand and screen each patient with diabetes as a whole, rather than focusing only on the part that the patient has presented to us with. So friends, I think I would have convinced you that diabetes is a vascular disease. There is multiple risk factor intervention in type 2 diabetes, giving us a window of opportunity not to be missed if we want to reduce the burden of diabetes complications. And with this, before I end, a warm welcome to all of you for the 15th annual conference of diabetes in pregnancy that we are going to organize very soon in August 7th and on the 7th and 8th. And I welcome all of you to join us there if you have an interest in pregnancy. So with that, I would like to conclude and end my talk. Thank you so much.
Thank you, Dr. Shalini Jaggi. Such a nice celebration. It's always a pleasure to listen to you. Always.
Thank you, sir. Thank you, sir.
We would now like to invite our patron, our godfather figure, gurus of, I think, most of the panelists over here, Dr. K.K. Parikh sir from Kota, Rajasthan, as one of the chairpersons. We are all delighted to have you, sir, here. Over to you, sir.
Good afternoon, everybody. First, let me congratulate Shalini for an excellent talk. I mean, she has talked so nicely, giving all evidences for micro and macro. They are so much connected with each other that they are continuum of one complication. So it's really been excellent review of the micro and macrovascular complications. We should take diabetes as a vascular problem. Thank you, Shalini. It's excellent. Congratulations.
Thank you.
So let me first thank Dr. A.P. Suri, Dr. Rajneesh Saxena, and the organizing team for giving me this opportunity to be a part of this very important and a great academic feast. And they have, I mean, so nicely managed. I have yet to see a conference so nicely managed and organized. So congratulations, Dr. Suri and Dr. Saxena and the organizing team for this great conference. Coming to the lecture by Dr. Dheeraj Kapoor. He is a very closely known to me, like my younger brother. He is a head in endocrinology, Artemis Hospital, Gurgaon, and he has got a lot of academic records to his credit, more than 60 publications. He is in the advisory board of India Journal of Endocrinology, Journal of Thyroid Research and Practice, International Journal of Atherosclerotic Diabetic Dyslipidemia, faculty of PHFI, and faculty at IPACON, RSSDI, SPCON, DIPSI, and he's a regular faculty in almost every conference related to diabetes and physicians. He'll be talking on clinical implications of role of basal insulin. We know that basal insulin is one of the most important therapeutic molecule for the treatment, whether it is type 1 diabetes, whether it is type 2 diabetes, or whether we want to start initially when the HbA1c is more than 7.5 or 8 to control the legacy effect of hyperglycemia. So it is a very, very important molecule which has to be initiated when there is a hyperglycemia to control immediately or on long-term basis. So we have got a wonderful speaker, Dr. Dheeraj Kapoor, who is an experienced endocrinologist. So welcome, Dr. Kapoor. I invite you for your lecture.
Thank you, sir. Are my slides visible?
Yes, so nicely. You can make it full screen.
I'll do that, sir. Thank you so much, organizers, for inviting me here. This is my first time in IPACON. But more than that, I would thank you for making me interact with Dr. K.K. Parikh, sir. Sir was the main encouragement behind my bringing my 2 monographs in ACP, and I'm indebted for life to him. Thank you so much, sir. Thank you so much again. So I have been asked to speak on the clinical implications of the role of basal insulins generation 2, but this being a foot conference, a couple of my slides would be there for the diabetic foot as well. Now, this is a strange yet an interesting slide, which actually shows that if the HbA1c is below 7 or 7, if you take those two categories, then possibly the sugar control does matter in healing. But the moment it goes above 7 or even above 12, it is not that important. Yes, they are crossing the midline in the forest plot. So numerically, it may be superior, but not otherwise. And this is where my previous speaker's lecture comes into being, that the ticking clock hypothesis, once diabetes sets in, there would be microvascular issues, macrovascular, there may be vascular calcifications, and because the wound blood supply might not be as adequate as we want it to be, healing may be delayed. I would not like anyone to take home the message that sugar control is irrelevant. But what I want to say is that there are many, many more factors apart from the glycemic control which are responsible for wound healing, blood supply, neuropathy just being the tip of the iceberg in that case. So when should insulin be used? Well, I use it in all my patients. However, it is mandatory in patients with life-threatening or limb-threatening foot ulcer. In patients who have a rather innocuous-looking ulcer but a poor glycemic control, osteomyelitis an obvious indication, and those who have poor overall health, metabolic decomposition, even if they are insulin naive. It may be considered in patients with non-threatening ulcers and good control, but risk factors of recurrence, for example, a neuropathy, which means hamartose or a Charcot's deformity, so on and so forth. So this is a rather busy slide, but what it shows is that if the patient needs hospitalization, he will have to be on insulin. If he's in ICU, which means he mandates intensive care, it's better off on intravenous insulin, and non-ICU, it should be basal bolus. In all hospitalized patients, I do not prefer a pre-mixed regimen, and this obviously is no exception. However, if there's no evidence of septicemia, it's a mild issue, you can continue the existing lowering therapy. That's what this suggests, but I would still prefer insulin. And of course, if the patient is on insulin, the therapy might need to be increased. For example, a basal may be shifted to basal bolus. If it's domiciliary, basal to premix, whatever, but you need to intensify the therapy. So when to use? First of all, ulcer phenotype is considered. Deep involvement, bone, joint, tendon, a large wound, crepitus, bully, gangrene, and of course, foreign body prior to surgery. Behavior of the ulcer, acute onset, progressing rapidly, not being treated adequately. Second, arterial insufficiency. So in this case, one may also require an arterial intervention. Systemic health, so a moribund patient, acidosis, azotemia, not taking orally, and of course, ulcer organisms being resistant to high antibiotics. So we had short-acting insulin, and then the quest went on, and we then got the NPH. NPH was touted to be the first basal insulin. However, I'm not too sure it was done because the effect doesn't last for 24 hours, and it has to be given at least 2 times a day. Some people use premix thrice a day. Again, I would not allude to that. But the fact of the matter is that NPH is not a true basal insulin. Besides, it has an evening peak, the midnight peak, that may cause hypoglycemia. Then, of course, came Detamir, Glargine. Now, the laughable matter is that every time a new analog comes, it comes as a plateau insulin, no peak, but the previous insulin develops a peak. So for example, when Glargine came, it was a plateau insulin, there was no peak, wonderful. Then came Detamir, and then there was this issue that Glargine had that mild peak. and when the later ones came, previous ones. So to my opinion, insulins are good. Generation 2 are better, and we'll come to that now. But the fact is that still they are comparing all the new insulins to Glargine 100. When these came in the market, we were told that Detamir and Glargine is once-a-day insulin, and the literature still claims that. But we've seen practically that these are not 24-hour insulin. At max, I find Glargine 100 lasts 17 to 18 hours, and Detamir probably lower. This is just the chart. We all know. The main point here is that NPH has a peak which no others have, and therefore there's a risk of hypoglycemia. And then Degludec and Glargine are the true basal insulins, because true once-a-day insulins, because they have duration of action more than 24 hours. So this NPH has a peak, controls fasting, I'm not denying that, but it does carry risk of hypoglycemia. Yes, it does have an economic benefit, but then if you have one episode of hypoglycemia, hospital admission, all that monetary benefit goes down the drain. Glargine, still the active competitor. Whichever insulin is launched in the market, they have to prove their non-inferiority to Glargine. Doesn't have a plateau. Then, of course, Detamir. The problem is usually required twice a day. And the benefit is that it is the only basal analog that is approved for use in pregnancy. That's besides the point, but taking a slight detour. And then, of course, the Glargine 300 and the Degludec, the newest insulins of the block. Hypoglycemias will come to later. The risk of hypoglycemia is reduced, but it is not zero even in the second generation insulin, and we need to understand that. So this is the guidelines on analogs, and I'm proud to be a part of these guidelines for the hypoglycemia chapter. So analog insulins may be used in preference to human insulins with possible lower risk of nocturnal and symptomatic hypoglycemia. However, as I said in the previous slide, economy should be considered. In fact, ADA also considers economy in its guidelines now. And of course, the RSSDI wheel was the first one to bring it. Now, newer acting analogs, 300 Glargine and Degludec, may cause least hypoglycemia, mind you, least, but not zero, and there is no tailing effect. So with that, coming to Degludec, well, they altered the amino acid and put on a spacer, and this is what happens. So in the cartridge, you have phenol, you have zinc, along with insulin, and once it goes into the circulation, the phenol is off and they form hexamers. So why was phenol added? Well, because if they form hexamers in the vial itself, it would be too heavy a molecule to come out of the needle. So that's why phenol was added. And then once inside the circulation, the zinc is off and the monomers go into circulation and are absorbed. The steady state is achieved in 2 to 3 days, both in type 1 and type 2 diabetes, and it is a flat action profile. So there's a basal insulin continuously, and therefore there may be least peaks and troughs, and this is what matters. And the column on the right lower side shows absolutely that there's a steady fasting state. Now, why is this important? And I'm taking a slight detour here. Glycemic variability. So we always study about fasting, postprandial, and HbA1c. But what about the variability? See, how does diabetes cause complication? Number one, hexosamine, protein kinase C, age products, so on and so forth. But how do they act? They form the reactive oxygen species. Glycemic variability causes generation of these species straight away. It bypasses all the pathways. So despite a seemingly normal sugar, which I mean a controlled HbA1c, you still have complications. So I would be happy enough with a flat HbA1c of 7.1 with minimal variations rather than 6.8 with hypos and hypers happening all the time. So this is the importance of glycemic variability. And this graph also shows that there's a lesser variability with glargine as compared to U100 as well as U300. The properties of degludec are not influenced by renal function, by the hepatic dysfunction, or even the age. In fact, hypoglycemia is much lesser. I'll come to that. So switch 1, which means type 1 diabetes, switch 2, and of course, devote. And all of them have shown that the incidence of hypoglycemia decreased as the patients were switched from other analogs to degludec. Majority of patients are in the elderly group, age group, and obviously longer duration, so more complications. So we need to be much wary of hypoglycemia and those issues. And this shows that both symptomatic and nocturnal hypoglycemia is lesser in patients above 65 as well as below 65. Any age group you talk about, complications are lesser. Now, why do we talk about nocturnal all the time? See, this is important. Non-pharmacologically, the patient is asleep, attendants are asleep, and the patient will not eat anything at night. So he might not be aware of hypoglycemia and he might not be able to call for help. And from the endocrine point of view, cortisol is at its lowest ebb, catecholamines as well. GH does peak at night, but it is not a very potent anti-insulin agent. So nocturnal is important. So time to first MACE, the DEVOTE trial, similar, severe hypoglycemia lesser than degludec, as is nocturnal severe. Now, flexibility. Degludec can be taken anytime between 8 to 40 hours. And this is therefore good for the patients who have a varying lifestyle, like the ones who fly out of Delhi into Mumbai and then return late night or day after. So whatever, it's good for them. However, I tell my patients to take insulin at the same time from the discipline point of view. Otherwise, obviously, given the drug kinetics and there is no stacking effect, they could theoretically take it at 9 hours or 39 hours. But I think discipline should be maintained and therefore we recommend that. However, even with this kind of flexibility, the HbA1c is similar and hypoglycemic events are not increased because of the stacking is not happening. So it is simple, it is convenient, and it is safe. Now its partner, glargine U300. So 100 is lesser concentrated. So this is used in patients who require higher units to obviate the need for higher volume. So these are the changes. The surface area is lesser. So from the principle of physics, we know that the absorption will be slower. Half-life is 12.1 hours, but duration is more than 36 hours. So again, it's a true once-a-day insulin as well. However, the requirement for unit-to-unit as compared to Lantus, 2Geo requires around 20 to 30% more units. However, it reduces hypoglycemia and it makes the number of units worthwhile. At the same time, it is non-inferior to Lantus. So the DELIVER study, now this has shown that despite achieving the similar glycemic control, hypoglycemia was much, much lesser in the patients. Now this is the BRIGHT study, and BRIGHT study was touted as one of the major landmark study as far as glargine 300 is concerned. A multi-center, open-label, 1:1 randomized active trial between glargine and degludec. Now, the glycemic control was similar in terms of fasting plasma glucose. And also, patients were doing the fasting SMPG, that is self-monitoring plasma glucose, and they were also similar. So the glycemic control was similar, and therefore this closes one chapter of the story. But what about hypoglycemia? So once we start insulin, the patient is reluctant for many points. I'll get used to it. It will cause pain. It will cause hypoglycemia. So patient is bewildered. And on top of that, if something like hypoglycemia happens, he will have an excuse to stop insulin, and that is what we don't want. So there are two phases. Number one, the titration phase, where you are actually increasing, and then is the maintenance phase. So titration phase should just pass like a hot knife to the butter. It should be as smooth as that. So titration phase, and this clearly showed that the risk of confirmed hypoglycemia was lesser with glargine. And this actually sets the ball rolling in its favor that this might be a good insulin to start. Maintenance phase, it was both similar. The next, so event rate, well, during the titration phase, the nocturnal hypoglycemia again was lesser. Now, why 70 and 54? Because Novo in its trials defines 54%. That's why they did 54 as well. But for us who consider 70, it was a major breakthrough. Time in range. So time in range is important. Sugar should be between 70 and 180 ideally. And this is what came from the offshoot of the BRIGHT study. Sugars were high at all points in time, but once either glargine or degludec was started, all the sugars are between 70 to 180, and that is what we've been looking at all the time, maybe fasting or post meals at any time. So this is what the second generation insulin analogs offer us. Just one line about conclude. So this trial, degludec and glargine, it was done 58 weeks, and then later they found out that the machines were faulty and the trial had to be done all over again. I will not go into the details because they are similar, but the fact of the matter is that the faulty glucometers in such a big trial, so these things also are not unknown. So to summarize my talk, glycemic control plays an important role in the management of diabetic foot. Insulins are important in therapeutics. In fact, IPACON is the most important. Generation 2 basal insulins are better than conventional in terms of variability, in terms of lower hypoglycemia, in terms of better HbA1c, better adherence, and better flexibility. Glycemic variability and time in range are seen with increased risk of hypoglycemia, complications, and compromised quality of life. Time in range is important, yet seldom used. It's time that we come to terms with it. And basal insulin can effectively address time in range and glycemic variability. Thank you so much for your patient listening.
Excellent lecture, Dr. Kapoor. Very well said that in diabetic foot, it is very important to keep blood sugar level within range, time in range, and to decrease the glycemic variability. It is very important to use basal insulin. And basal insulin, if we want a flat curve, we use either degludec or glargine 300 because it gives 24-hour flat profile of blood glucose level. So it is very important, and day by day, the basal insulin is becoming a very, very important part of diabetic management to keep the flat curve of blood glucose, time in range, and less glycemic variability. So it has been a very nice, you have told so nicely about the use of 24 hours insulin, like basal insulin, degludec, or U300 glargine. Thank you very much. It had been excellent. Yes, Dr. Suri, you want to comment something? And again, I will say that it had been a wonderful conference. It's a great, successful, and you have done a great job. Very hard work done by all the members of the organizing committee, and gave a wonderful profile of academic feast. Thank you so much for giving me this opportunity to be a part of this prestigious conference.
Thank you, sir. Thank you, sir, for showering your blessings to us, and keep your right hand on us. Thank you, sir.
Thank you very much, sir. Thank you very much, sir. Thank you very much.
Thank you. So we have last speaker for this, Dr. Anand Suri, Dr. Manish.
Yes. Apart from pathology, physiology, and treatment part, this is a different talk as a patient psychological counseling. It has been included just to handle the diabetic foot infections and the psychosocial aspect of diabetic foot. So the Dr. Anand Suri is a PhD in psychology and he is a director of Tan Smiles Life Sciences, Hyderabad. So over to you, Dr. Anand Suri, sir.
Good morning, everybody. This is Dr. Anand Kumar Suri. I'm a psychologist and a practicing patient counselor. In today's clinical practice, a clinician has many challenges in the treatment of a disease. A clinician has to not only treat the disease with his expertise, but also understand the mental agony of the patient. Here, the interference of a psychologist will come. A psychologist can understand and bring out few of the points which can help this clinician to take care of the treatment still further better.
Hello.
So I have listed off few of the points which is going to help in the treatment to be more successful. Thank you.
Over to Suri, sir.
Counseling the patient and attendance of the patient is a critical aspect and part of the holistic treatment. Before counseling the patient, the one who is counseling the patient has to review the patient's records thoroughly. Should take the feedback from the patient attendants about the physical and mental status of the patient. We should introduce ourselves to the patient in a friendly manner. The patient should always be addressed by his or her name, not by the word patient. Sometimes the patient needs to be counseled alone, not even in the front of the attendants or the family. We should explain the various treatment options, duration, possible outcomes, benefits, precautions, dietary and lifestyle modifications, etc. in advance so that the patient will be comfortable to undergo the treatment. Using the local language will make the patient more comfortable if possible. Use appropriate counseling aids or tools. Present facts and words in simple words and a logical manner. This will help the patient understand the seriousness of the disease and bring the required changes in his lifestyle. We should counsel attenders and the family members that they should always positively motivate the patient, bringing the good things that happen in the patient life. The patient should motivate himself positively. He should not go into mental agony so that he will recover from the disease fast. The patient should become an informed, efficient, active participant in the treatment and self-care management. The clinicians should motivate the patient that amputation is not the end of the life. They can quote examples like Kiran Kanoja, who restarted their life and became celebrities despite of wearing artificial legs, blade legs, and participated in many marathons and climbed mountains.
Thank you so much. Thank you so much, Dr. Anand, for this. This is also very important, patient counseling. Over to chairpersons for any questions you can take out from the chat box. Chairperson, sir. Dr. Jimit, sir, can we have your comments on diabetes care and foot care?
First of all, let me thank you, Dr. Suri sir, for inviting us for this wonderful conference, and it is going wonderfully. And I congratulate you and all your team members for this wonderful conference you have gathered. And I'm so happy to see so many national and international faculties here. Thank you so much. And we all know that diabetic foot remains a very, very, I would say, untouched topic. See the other fields of medicine still remains untouched in comparison to the other fields. Specifically, I would say cardiology and diabetology that has in focus right now. So since I would say last couple of years, but it still remains one of the main hurdle for patients' mobility part, even in mortality part. And I'm so grateful to see all of you here and gathering and spreading awareness about diabetic foot. And I'm so happy to learn all the speakers here. And diabetes management still remains, as you have, Dr. Surya has already mentioned, and Dr. Zargar sir has also mentioned, that diabetes management is still a very crucial thing. So nothing can touch your expertise that you are saving the limbs of the patients, but on our part also, prevention of this diabetic foot complication is also very, very important. So all clinicians who are practicing and listening to this, they must practice in preventing also, early detection also, and early treatment by referring to you also. That is the thing I would like to add.
Thank you, sir. Thank you so much. Dr. Rajneesh, unmute yourself. Unmute. Dr. Rajneesh.
Thank you very much, sir. Now I request Dr. Girish Mathur, sir, for giving his expert opinion regarding glycemic control in the management of diabetic foot.
A perfect glycemic control in diabetic foot is of crucial importance, I think, because if there is there is a chances of losing a limb even at the end of the treatment, because if we don't have a perfect glycemic control and lack of awareness about the foot care, and it's a paramount importance that a practicing physician have awareness about diabetic foot care. And this conference, I think, is doing a perfect job in making the awareness among the practicing physician about the perfect glycemic control and care of diabetic foot. I joined Dr. K.K. Parikh to congratulate the organizers, Dr. IPS Suri and Raji Saxena, for organizing this wonderful conference, meticulously planned and meticulously executed conference. Thank you so much for making part of this conference.
Thank you very much, sir. Thank you very much, Parikh, sir. I am really very much thankful from core of my heart for your precious presence in the conference and your blessing. Thank you, sir.
Whole IPACON committee is thankful to you for joining. Dr. Robin wants to make a comment. Dr. Robin, if you can.
Hi, sir. Namaste, everyone. I am from Nepal, and it's my first time in IPACON. And I would like to thank Dr. Suri, sir, and all the delegates and all the team here who has been here since the first day I'm listening. And the conference is going very well. And I'm very happy to see the amalgam of the topics. It is covering all the aspects of diabetic foot, especially all the respect from the basics to the prevention, to the complication, to the treatment, and everything. So I would like to congratulate AP Suri sir and everyone from India, all the delegates, and to see all the stalwarts and tycoon of the academicians of the diabetes here. And everything has been told and discussed by our other moderators and chairpersons. And Nepal also is we are also facing the similar problem of diabetes, what we are having a problem with our neighboring countries like India, Pakistan, and Bangladesh. The cost is the issue. The complication is similar in our part also. And neuropathy is not so common in Nepal, but it is coming up. And in peripheral neuropathy, I mean to say the diabetic foot is not so common, booming like that of India, like that of sarcoids and like. But other diabetic foot complication like neuropathy is more in Nepal. So, and cardiovascular complication also. Thank you very much, sir.
Thank you. Thank
you. Thank you, sir. All the best for the outgoing conference. Thank you, sir.
Thank you so much for all the chairperson, Dr. Zargar, Dr. Shalini, Dr. Dheeraj Kapoor, sir, for giving us an enlightenment on diabetes care and foot care. Over to Dr. Shrishti.
Thank you to all the moderators, chairpersons, and the speakers. Moving on. That wound is not your fault. but their healing is your responsibility. For the next session, I would like to call on the podium Dr. Neeru Bhandari ma'am. Ma'am is a fellow in diabetic foot. She is the assistant to Dr. Kamal Gupta sir in the Department of Surgery and Diabetic Foot and Advanced Wound Management Care. I welcome you, ma'am. Over to you.
Thank you, Dr. Srishti, for such a warm introduction. Good afternoon to all of you and a very warm welcome in IPACON 2021. Since yesterday, we are enjoying an excellent academic feast under the banner of IPACON 2021, headed by Suri sir. Thank you, sir, for bestowing us with knowledge and enlightening us by organizing such a feast. We are starting session number 10, and it's an honor and immense pleasure to invite Professor Dr. Ramakant as chairperson. Sir is a patron of IPA and is a role model for many. He himself is an institution. Sir is former professor and head Department of Surgery, KG's Medical University and Gandhi Memorial and Associated Hospitals, Lucknow. He is recipient World Health Organization, Director General's Award 2005. Sir is past president, Association of Surgeons of India, ASI. And also I would like to add, he is fatherly figure for my mentor, Dr. Kamal Gupta. We welcome you, sir. Next slide, please. I would like to invite Dr. S.S. Prasad as chairperson. He is professor and unit chief, Department of Surgery, Kasturba Medical College, Manipal. Welcome to you, sir. To moderate the session, we have Dr. Chaudhry R. Magani from Bangladesh, which gives us immense pleasure to know that IPA is spreading its glory throughout the globe. Sir is Senior Medical Officer, Surgical Emergency Department, BIRDEM General Hospital, Bangladesh. Welcome to you, sir. Along with him, I would like to invite Dr. Indika Karanmuni from Sri Lanka. Sir is MBBS Faculty of Medicine, MCGB Diploma and Diploma in Family Medicine. He holds a fellowship degree in Diabetic Foot Disease Management and Advanced Wound Care, Indian Podiatry Association. He is member of IPA and Royal College of General Practitioners. Now, I would like to hand over the podium to the moderators to continue the proceedings. Over to you, sir.
Next slide.
May I request the moderators to continue the proceedings?
Over to Dr. Ramakant, sir.
Please unmute again, sir.
Dr. Ramakant, unmute yourself.
Yes. Unmute karo, हाँ sir.
Hello.
हाँ sir.
Hello.
You are audible, sir.
Okay, thank you very much. Good morning, Dr. Suri and the whole team of experts. I'm already watching this program, which is full of academic contents. It is excellent. And honestly speaking, for the first time, learning so many things myself. And I appreciate the type of presentation, the punctuality, and the contents delivered in the proper manner. Dear friends, it is really a fortune for anybody who is attending and a misfortune who is not attending. Because this content, I'll request Dr. Suri to, after it gets recorded, then you should circulate, because it will be a really important encyclopedia for this. Total coverage is there. So I think our chairpersons, other chairpersons, my colleagues are there and moderators. So they should take over the job and straight away go to the program. Thank you very much for it.
Thank you, sir. Thank you, sir, for the nice words. I share my slides. Yeah. Thanks to the chairpersons and moderators for this session. The topic given to me for this session is a new chemical entity for diabetic wound healing. We all know that there are a lot of new treatment modalities, what we are talking during this conference. Offloading has already been done. There are videos on debridement. We have last evening, we have covered 10 videos on different modalities of this. Back therapy, we have covered a lot of growth factors, silver dressings, hydrogels, hydrochloride, collagens. We'll be covering in the workshop, which are going site to site now just after from 1:30 onwards. And we have a very nice session in the morning on hyperbaric oxygen therapy. Honey dressings we might be covering in the dressing session. There's a special workshop on biologics in diabetic wounds, and a new entity, chemical entity is there, which is known as Voxil. I think many of the delegates and panelists would have used during their clinical usage. Voxil solution, if we see, it's a new chemical entity. The generic name is diperoxochloric acid, DPOCl. It's a colorless, odorless solution, and it can be stored at a room temperature. Actually, DPOCl, what it happens when we use that on the wound, it breaks down into oxygen radicals and chloride radicals. So oxygen works as it helps in the granulation tissue healing process, healing of the wounds, and this chloride radicals help in the antimicrobial action, and it controls the infection on the wounds. So it's a biphasic modality by which healing occurs on the wound, and also it works as an antiseptic solution. The active ingredient diperoxochloric acid is a new entity, topical solution, as I said, antibacterial, and also how it helps, we'll show you in some of the slides that how it helps us is mainly the fibroblast proliferating action, which helps in the granulation tissue formation, fibroblast migration, deposition of fibroblast, and also we have the eradication of the biofilm. The biofilm eradication, so any solution, anything what we are using on the wound, if it is good in eradicating the biofilm, we all know that our wound healing or wound bed preparation or wound healing will be proper. So when we see into this, it's a fibroblast proliferative action was tested in MRC5 fibroblast cells. A significant growth stimulation was observed in the time course up to 4 days following the stimulation with this Voxil solution. So we all know that proliferation of fibroblasts, which helps in the wound bed preparation, and that is where the healing starts in the wound, and our wound bed is also, we see the granulation tissue also fills. It contains two bottles of this. We have to mix both of these as an activator, and before that we are using that on the wounds of the patient. So Voxil, it exhibits antibacterial action against most of the gram positives and gram negatives pathogen, and it's a potent antibacterial action is usually seen within 2 hours, and which has lasted about 24 hours. In some of our patients in our center, we are also using some type of films like Tagaderm or other films. We use it so that the wound doesn't, because we all know that we have to maintain moist environment. Because if a moisture, according to the time concept, if we maintain moisture on the wound, we all know that healing of the wound will be proper. So always try to maintain moisture on the wound by using some type of hydrogels, or even if we are using Voxil, we should use some type of film over this wound. These are from the case studies from the clinical phase 2 and phase 3 RCT trials. This was a wound on the posterior part of the heel, and something around for 4 to 8 weeks, the patient has been using this Voxil solution, and you can see complete epithelialization which has occurred over there. On the dorsum of the foot, lot of biofilm present over here, so better and extra granulation tissue. If you can see in this, the granulation tissue is excessively. So best course would be to, with the curettage, you have to remove the biofilm and the excessive granulation tissue, and then whatever solution or whatever dressings you have to use, and you can see a good epithelialization can occur in about 8 to 9 weeks of time. Similar patient on the dorsum of the foot, without any grafting or without anything, you can see 4 to 6 weeks of granulation tissue can be formed in this. This was one of the patient at our center which has got a tunnel wound from the plantar surface of the big toe going on the medial side on the foot. So after debridement of the dead tissues and a tendon, and after that we have offloaded that tissue, and Voxil was given. This was during the lockdown phase. So in lockdown or epidemic condition, when patients can't visit to the hospital, so what we gave them, that calcium alginate sheet, we told them to mix with Voxil, wet it with Voxil solution, and apply it daily over this wound. And during the period of 3 to 4 weeks of time, we saw very good granulation tissue was formed, and similarly epithelialization occurred and wound closed on its own. Here you can see the fascia over the medial side of the proximal tendon, and then also granulation tissue was formed. So Voxil was given along with the calcium alginate. Sometimes you have to mix 2 or 3 different modalities of wound care management. Sometimes we have to mix collagen sheets, what Dr. Ravi will be showing, and I'll be also showing some cases in the workshop session on the 4th workshop. So mixing of 1 or 2 modalities of wound care dressings is no harm to the patient. We have to see what can give us the best results. This is again one of the venous ulcers. This patient was suffering for something around 6 years with this ulcer. We got the venous Doppler done and thus done the curettage of the wound. Debridement was done. Very less granulation tissue, or you can see all necrotic wound. This is even after the first debridement was done. And similarly, we gave them calcium alginate sheet with moxil solution, and subsequently at 4 weeks of time, we can see we did PRP also in between, and we were happy to get a granulation tissue, and we put this patient on a compression bandage with neon sheet. Initially, Voxil was used, and then similarly, Voxil wet with gauze piece was put on the wound, put a foam sheet over this, and for 6 to 7 days, we have applied a compression bandage regularly, and this was the granulation tissue which formed, and later on, we grafted this wound. This is again another case of burn injury on the posterior part. This was from the heater injury on a lady who has a severe neuropathy. A scab tissue was formed. Debridement was done. All the necrotic, the scab tissue was removed. And here you can see the epithelialization occurring on the periphery of the wound. So Voxil dressing was only given with a gauze piece padding. No any antimicrobial or silver-based sheet was given to this patient. And we can see epithelialization also occurring from the periphery, and whole of the granulation tissue was filled. Necrotic tissue was debrided. Curettage was done to remove the biofilm. So I think the good point could be that it is a good eradicator of biofilm and also helps in the granulation tissue because of the oxygen radicals. That is what where the wound gets, and that is helps is in the fibroblast migration and helping in the granulation tissue formation. And subsequently, in next 3 to 4 weeks of time, this wound has totally epithelialized without any grafting or anything doing on this patient. This was another patient having a diffuse peripheral vascular disease. This was again during the epidemic time. 1 and 2, 5th and 4th and 4th and 5th toe were amputated at another hospital. This patient came to me. I did the 2nd and 3rd toe amputation because it was already going ischemic. I gave the choice to the patient to amputate the first toe also because biomechanically this is totally an unstable foot. But patient didn't give me the consent. He said that my toe is okay. Why you want to chalk it off? So I said, okay, let's go ahead with this. We did PRP and then we applied VAC on this patient. The first sitting of VAC didn't give me a very good results. So subsequently, I just put him on a Voxil dressing over this. And in 2 to 3 weeks of time, I can find out a good granulation tissue. And later on, I grafted this wound at about 8 weeks of time. So that shows that when we have to mix some modalities of treatment, we have to choose at what stage, what type of dressing or solution or these gels have to be used. You have to use hydrogels to make the wound moist. You have to use Voxil to make the granulation tissue formation. You have to use another ointment like papain and urea for the necrotic wound. Debridement is part and parcel of this. And even in this food, the patient was totally mobile. So offloading is a very important done. So it has to be a comprehensive wound care management in these type of patients when you have to protect it. Even biomechanically, if you see, the only good thing was the head of the first metatarsal, head of the 5th metatarsal were intact, and there was no osteomyelitis, and that made me that biomechanically this foot can be, I can make it mobile. So we gave him an offloading orthotic with a higher lateral arch so that we are shifting his pressure from the lateral side to the medial side so that the foot doesn't goes into a varus phase. And that was good enough. And even after the grafting, that orthotic was designed, customized orthotic, and that has been given inside the shoe of the patient. So these things, offloading, dressings, and management for sugar, antibiotic, that all has to go hand in hand. This is again one of the patients who was referred to me from one of the hospitals from Medanta in Delhi, where Dr. Tarun, he's a good friend of mine, and he's here in the next session. So hind foot amputation was done over there. Again, patients, even the patient, the first day this patient came to me, I told him that below knee amputation is a better choice. She told me that initial doctor also gave him that choice, but the patient didn't give the consent. They were of the view that patient will be able to be mobile on this. So it was very difficult to convince this patient. But again, this patient was an international patient and she didn't give me the consent to go for below knee amputation. I said, okay, let us try something. And you can see here, The lower end of the tibia is exposed. All the necrotic tissues are here. So we are going to talk that how we are difficult to heal this bone. So it took us, this photograph is about 6 weeks of time with multiple VAC dressings which were used on this patient. Still the bone is exposed over there. So we debrided this bone later on. I was trying to get a granulation tissue available on this. And this is how we put him patient on Voxil dressings for about 3 weeks of time. That gave us a good granulation base over here, and that initiated me to go ahead and now heal the wound on the posterior part of the wound, and so that we can flap it or we can go in for a graft on this patient. So I used a dermal matrix on this patient, for the bone was exposed. So we applied that, and about 8 weeks of time, we grafted this wound, and this is the photo, this is a photograph at about 16 weeks of time. So ultimately, this patient was living near to the Medanta hospital and coming daily to my center. And I have so many friends in that hospital, and told them that you can get the dressings done over there. But somehow this patient was regularly coming over. And this is the photograph at about 16 weeks of time. So that showed. Later on, little part post graft also, we had some part which was degranulated, and we used Amcoplast over there. So we gave multiple Amcoplast to this patient, wetted with Voxil solution, and that was applied. And subsequently, we just got the epithelialization here where the graft was not accepted. Reason being, this fat pad tissue on the posterior part of the heel gave me an insult that this patient might be able to, I can make this lady walkable. So we devised an AFO for her from 6 inches above the Achilles tendon, going here, giving her the very thicker Evazode and Poron. We mixed Evazode and Poron, gave her a shoe filler over this place, and then give her a shoe filler at this place. And subsequently, I'm now trying it for giving her a silicone forefoot into this patient, and she is totally mobile with this foot. So that gives us something that even patients who have gone for these type of Symes and Bogarts and other Chopard amputations, it's very difficult to heal these type of wounds. But yes, we can try, we can mix this solution. So we are happy to concentrate with our industry people that these modalities of wound care we need to use in our clinical practices. This is again a venous ulcer with diabetic foot, very bad ulcer. This ulcer is there again for 9 to 8 years of this patient. They think that these doing dressings is part of their dressing. They're like they wear pant and shirt, they have to do dressing every day. This will never heal. They all know this was from outside of Delhi. This patient came to me. Debridement was done. Compression bandage was given to this patient. He was sent to a vascular surgeon to get endovascular venous ablation, which was done from a very good friend of mine near in Gangaram Hospital. And then this patient, when after venous ablation, this patient came to me, and we put this patient on total Voxil dressings. So what we were trying over here, we mixed calcium alginate, wet it with Voxil, applied on the wound, and over the wound, we gave him a neon foam sheet, because we have to close this wound for about 6 to 7 days of time. So even if the discharge is there, peri-wound area, we need to protect over this area, and then compression bandage has to be given. Look at the other foot here. There's a small wound over here, excessive pigmentation. That indicates that this patient already had a venous insufficiency and a venous hypertension on the other foot also. It's bilateral. We all know about that. So we have to mix modalities, where at what stage we have to use this patient. This is the granulation tissue we got at 6 weeks of time, and later we grafted this wound with the compression bandage and then gave him a stocking after that, and this patient is doing very well. So this is how, with the patient healing, suffering for 8 years with a venous ulcer, and this gentleman thought that these ulcers will never heal. You think that we have to do something, we have to mix modalities of treatment, and we have to see how we can really save this patient. Again, a very difficult patient, malignant melanoma with diabetes. This patient came to us. This is the fourth, very few cases like this. We took him in the OT, did the debridement, sent it for biopsy, got his PET scan, and then consulted with an oncosurgeon. He was having lymph nodes over there. My very dear friend, Dr. Sanjay Gale, he was dealing with along with an oncosurgeon. So we put this patient on chemotherapy for this malignant melanoma. It has already metastasized, but luckily enough not to metastasize to the lungs or to the liver. So this was the wound when we are talking about this, and you can see the inferior part of the calcaneal bud. This is the cautery. We have to debride this wound over here. This is, now we used Voxil on this dressing. So it was a very difficult decision for me to use this Voxil and subsequently Hydroferra foam sheet. So we took Hydroferra, wet it with Voxil, put this on the wound. After daily dressings were done to this patient. VAC was applied later on when we have a small coverage over the lower part of the calcaneal bone. And this is a graft I took, and look at the granulation tissue. this table. And then after he was totally put on a POP cast, and flap was not done on this patient because we took the decision that we will do a skin grafting, and this patient is doing very well. This photograph, this is something in April of this lockdown we did, and 3 months down the line. But where you can offload this patient, because offloading is very important. If you can offload these patients very well, you have a good granulation, base of the wound is there, dermal matrix is developed, you can really take these patients and save these patients over there. Infected heel ulcer, again, very lucky enough not to have osteomyelitis in the calcaneal bone. Debridement has to be done, offloading, dressings, and then you can see good granulation tissue with voxel dressings for about 6 weeks of time, and later on a small part of the graft was applied. So again, you have to offload this foot because the patient keeps on walking, this graft might even break down. So you need to develop an orthotic from the base of the wound. You shift pressure to the metatarsal heads over here so that this patient doesn't have. Good care of the skin, moisturizing cream, and taking care of the gait analysis, how this patient's gait is there, and that tells us a heal. But to develop the base of the wound where you need to graft it or wound bed preparation is very important. So I think this is one of the solutions which I am using at my center. Many of you can try to use it, and that's all. So a lot of adjuvant therapies are there. Negative pressure wound therapy we have to use in the bigger wounds. We need to use Integra and dermal matrix. We'll show you in the workshop certain a lot of growth factors are available. Amniotic membrane products, very cost effective. We should use that in our practice. Hyperbaric oxygen therapy, very few centers in the country. Shockwave therapy, yes, good results are there. Again, you have to see what you're using. So adjuvant therapies are very important with dressings for the early healing for these wounds. So I will say that it helps in the wound bed preparation. It has an antibacterial action and effects in the microbe-free therapy. We should try to use. It is safe, doesn't have any side effect. It is friendly use. During epidemic, we can give it to the patients. We have given that multiple bottles we have given to the patient. Keep on doing the dressing, send us photographs, and telepodiatry, tele-wound care is very important for this patient. So this is some way we need to dress into this. We have also launched the website. There's a photograph of that. And thank you so much. And this is it into this. Thank you. If there's any questions, we can take now, or we have one more session and then we can take the sessions. Over to Dr. Rama.
Hello. Actually, the electrical background and those things, so I have come onto mobile. So please excuse me for that. One thing I'd like to say, after appreciating your paper, that you have really started like a film hero. You are a celebrity. This is why I did not introduce you. I thought that somebody will ask me to produce, and now it is the time to come. Our time has come that I am going to talk about you. Just give me a few minutes. I'm sure, friends, without introduction, he does not need an introduction. So what happens that you all have recognized who is he. Now, what I'm going to tell you is something very interesting. Amarpal Suri is a foot care specialist who started long back and decades back when I found him that one of the neglected disease, something which he's trying to do constructively. And from King George Medical University, I traveled to him to see his clinic. Therefore, friends, I just want to tell about it, that after doing his medical graduation from SN Medical College, Agra, Dr. Suri went to USA for higher studies in podiatry. At that time, when nobody was thinking about it, he completed podiatry Harvard Medical University, and his physical pressure offloading techniques from the Temple School of Podiatry, Philadelphia, USA. And Dr. Suri is one of the few members. He is one of the few diabetic foot specialists practicing in India, and his main field of work is in diabetic foot management and pressure offloading. And you saw that he got so advanced about telling about the voxel and those things. He was talking with experience. People are imagining about it. The Suri is working in India for last several years, and he's a chief consultant, director of podiatry services in the Diabetic Foot Care Center in New Delhi, and is the founder president of Indian Podiatry Association. He's a medical American board certified hyperbaric therapy specialist. He is a member of American Podiatric Medical Association, APMA, American Association of Wound Care, AWC, and European Diabetic Foot Study Group. Dr. Suri also runs a training program in India to train other doctors in diabetic foot care, and has trained more than thousands, 2,000 or more than that, doctors from different parts of India since last several years. Indian Podiatric Association runs these programs all over the India in different cities. Today, what I find and feel really, I feel proud of it, that he has spread his wings to not only India, all over the country. Such a huge number of people are involved in this that I tell you, Suri, you become a legend, you became a celebrity. And with those things, my best wishes to you for your all efforts. I really amazed to see your performance, the way it is changing. God bless you. Thank you very much and keep it on. Thank you.
Thank you, sir. Thank you, sir, for your kind words. Thank you so much. And all your love and your blessings which take us forward, sir. Thank you so much. I take you to my next presentation, new age dressings to manage diabetic foot ulcers. I'll just.
Hello, can you share the screen, please?
I'll share my slides.
Now you can share, sir.
Thank you. Next. Yeah. We all know in diabetic wounds, biofilm is a problem. If you look at here, $28 billion is the spend per year in United States for the primary diagnosis of a wound care. If you look at over here, bioburden is defined as the number of bacteria living on the surface that is not sterilized. So biofilm we know is in multiple of the wounds. It's basically a big problem. And whatever dressing, as I was speaking in the initial session, that we need to have a dressing or a solution or an ointment or whatever topical application we have to do, plan for a wound bed preparation, we all know that we need to take care of the biofilm. If you look at chronic wounds, they are the most widespread medical problem worldwide. 3.7 million people, more than 6 million people in India, 4 million in Germany and different parts of the world, they are suffering with chronic wounds, whether they are diabetic wounds, venous ulcers, pressure ulcers, or any type of carcinoma wounds. Mainly it is very present because of the presence of necrotic tissue, poor blood circulation. We know this patient had diffuse peripheral vascular disease, lack of granulation tissue because they are high in MMPs, proteases, and all these may make the wound difficult to heal. And most of the time, there are reopening of the wound is there. A neuropathic ulcer is there. A patient comes back to us every monthly, every weekly, that ulceration breaks down if a proper offloading or proper wound care has not happened to these patients. If you look at the microenvironment of chronic wound, that is found to have elevated level of proteases, low level of growth factors. Biofilm is a major problem in this, which Dr. Pawan has covered, and now Pawan will again show you some slides. And we have delayed wound healing. So all these problem makes the problem for a clinician or a surgeon to how to deal with these chronic wounds. And we need to have a dressing which can handle all these factors. We all know for a proper wound bed preparation, we need to have debridement, offloading, treatment of infection, management of adequate perfusion, and dressing is a major part in any wound care clinic, if you see. As I said, concept of time on dime, all delegates who are listening to this presentation or IPACON 2021 should learn the concept of time. I think most of you must be knowing about it if you are dealing in wound care. T stands for tissue, I for inflammation, M for moisture, E for edges. If whenever you see a patient at the back of the mind, you have this concept of time, that you have to look at the tissue, whether it's okay or necrotic, you need to debride it. You have to look for infection, curettage, or by your clinical sense, what type of infection is there, inflammation is there. Moisture balance, you have to make it moist. When I was a student, and when, as Dr. Ramakant sir has said, long time back, we need to make the wound dry. But now the concept is changing. We need to make the wound moist. And edges, we have to see whether they are undermined, non-advancing. If you follow these 4 points, you will be successful and your patients will be healing well. If you look at chronic wounds, 60% of these patients, they have biofilms. Acute wounds have 6% of the biofilm. So our goal should be to convert these chronic wounds to acute wounds. And that can only occur by debridement, debridement, and debridement. Do not be scary of debridement. The moment you see a new patient, you see it's a chronic wound, do a debridement, the debridement will convert. It will make the microcirculation to bleed, let the wound bleed from the periphery. And that chronic wound will convert into acute wound, and that will get reduced. Your biofilms will reduce by about 50, more than 50% of the time. So there's a silver dressing, which has got a complete and continuous cleaning action. OrgoClean AG, I've been using at my center, which has been effectively fights against the local infection, and it also minimizes the reinfection of this. So what is the concept of this dressing is that it has got these TLC AG fibers on the inner side, which goes on the wound. It contains of hydrochloride particles, which is known as CMCs, lipophilic substances, and silver sulfate. Now, what these three things, it causes a gelling effect on this. So this hydrochloride particles, along with the lipophilic substances, it gels, it makes a gel matrix on the wound. So when you apply that on the wound and see that after 24 hours or 48 hours of time, the whole of the fibers, they makes a gel on the surface of the wound. So there are two things which happen. One is it maintains moisture on the surface, and also it traps the bacteria into it all substance of the sheet which we are using. Silver sulfate, it works as a broad spectrum efficacy against large number of microorganisms, mainly against MRSA, VRE, and ESBLs. So it has got a double phasic action, that it causes the eradication of the bacteria, maintains moisture, and it also helps in the granulation tissue formation. We all know that's how silver in this sheet or any other sheet, how silver works. In contact with the exudate, the silver ion dissociate and silver becomes positively charged ions, and which has a bactericidal action, and that is the antimicrobial effect. So we want something for as a bactericidal action on the wounds of the surface. So we all know it breaks the cell wall of the bacterial system. Cytoplasmic membrane is permeable, and respiratory enzymes, it causes the inhibition to the enzymes, leading to the bacteria asphyxia, and that helps in the eradication of the bacteria. So OrgoClean works as an antimicrobial, and also it has a causes the complete action with the mechanical action on the polyabsorbent fiber. So it absorbs the exudate into its body and works as an antimicrobial. So it is a dual action of this sheet, which makes that these are the fibers of TLC silver. So TLC silver helps to trap the bacteria. Silver works as an antimicrobial. So dual action helps in eradication of the bacteria and formation of a granulation tissue into this. I'll show you some cases. This was again a venous ulcer. A good amount of biofilm was there. We started this with an OrgoClean AG. You don't need to mix any solution or any gels with this, because if you apply the gel, then the process of applying the sheet will go away. And this is within 2 weeks of time, we got a very excellent result, that all eradication, because these are very painful. With a curettage, we can try to remove this biofilm from the periphery of the wound, but it's so painful for these patients. Even giving a local anesthesia is so difficult to giving, because it's a fibrous tissue. Because in these venous ulcers, these patients doesn't come as an acute wound. As I said, they come with a chronic wound. They have 2 years, 6 years, 8 years. Recently, I saw a patient who has got 35 years of a venous ulcer. It keeps on recurring. So it's all a fibrous tissue. So giving local is so difficult, and anesthetizing these tissues are very difficult. This was the wound at about 8 weeks of time. And similarly, with a compression bandage, we were able to epithelize this wound completely. This is a 4-foot amputation. 3 toes have been amputated. A good amount of necrotic tissue is there. We cleaned this wound and started with an OrgoClean solution. And at about 8 weeks of time, we were able to graft this wound. So this helps in closure of the wounds in a better way. This is again a biofilm impregnated wound over here. A lot of biofilm was there on the surface of the wound. Luckily, we get an X-ray. The shaft of the 5th and 4th metatarsal didn't show the osteomyelitis. The head of the 5th metatarsal is here, which is exposed. We eradicated that, started with an organ. Now see, this is a sheet which we applied, clean sheet we have applied. And when the patient comes to us, this is the discharge. So look at the amount of the discharge. So it has got a very strong hygroscopic action. So with an hygroscopic action and TLC silver ions, it eradicates and traps the bacteria or the discharge which is there on the wound. And this is what we were able to get at about 2 weeks of time. So if I go back and see, I can use other modality. It's not that I can do the debridement and we can use a vac on this surface, but we have to see the cost which is going to the process. In 2 weeks of time, my wound is ready for grafting. I think we can give a chance to this type of dressings which we have. So we have to see that what type of things we can use according to the cost effectiveness to the patient also. Sometimes patients are not able to bear the cost. Sometimes these type of dressings, according to the cost, we cut it in half. We tell them take a trial scissors, or in the clinic we can cut it in a half piece, and half piece we can use on this wound. Here we have to use a full sheet, and there's a wound on the top of the ulcer also. So this wound care is not 1 day, 2 days, 3 days, or 5 days. You have to carry on for 6 to 8 weeks of time, sometimes 12 weeks of time. If the wound is not healing beyond 12 weeks of time, be alarmed. You have to reassess your wound. You have to look for the perfusion. You have to look at the osteomyelitis. You have to look for the sugars, HB1C control, or get the cultures and do. So 12 weeks of time, we all know is a basic thing, but within this, you have to decide. So we all have to see the cost effectiveness also for our patients. This is again a necrotic wound on the posterior part of the heel. You're very surprised that Achilles tendon might get exposed or might have got a curettage. We did send the culture. And similarly, we started on the UrgoClean AG, which I think best wound, where you have very amount of necrotic tissue and your tendon or bone is exposed. There you should use, I'll advise you to use this sheet, and within 2 weeks of time or 2.5 weeks, something around 18 days, this photograph is at about 18 days, we were able to eradicate the bacteria because of the TLL AG fibers, and also it has got a hygroscopic action to take away the discharge into this form. This is again a forefoot, multiple ulcers on the forefoot, and there offloading is very important. If this ulcer is come, you have to offload whatever dressings you do, and if patient keeps on walking on this sheet or on this wound, it will never heal. Even if you apply gold, silver, whatever you try to use, it will never heal. So whole wound care modality you have to use, taking care of the sugars, taking care of the discharge, and that is what this IPACON has seen. You see sessions in the morning, and today morning and yesterday morning, we had 2 diabetes sessions of very profound speakers. We have sessions by plastic surgeon, session by vascular surgeon, and we have Dr. Tarun will be covering a session on vascular surgery again, and all modalities on biofilm by Sanjay, Pawan, Dr. Arun Maya sir on offloading. We had a workshop today morning. So that is how you have to coordinate and combine the modalities of wound care. UrgoClean AG, I'll say, deconstructs the bacterial frame, destroys bacteria. It helps, prevents recolonization, also maintains moist wound environment. This is very important and helps in the granulation tissue formation. So I can use this on the patients. It inadequate proteases which are elevated in the chronic wounds, has significant antibacterial action. So you have to decide that what type of use you can be. I've shown you 2 things, box seal, where you have to get a granulation tissue formation. And this is something where you have to get rid of the bacteria, get rid of the biofilm, and also as an antimicrobial action along with the growth factors, promotion of the growth factors and inactivated proteases. So that's into this. Thank you so much. And we have a panel discussion here. I'll invite Dr. Ramakant Bemde from Aurangabad and my dear friend, Dr. Pawan from Bangalore, to share their slides. And if they can share their cases over here. And we have Prateek also to have some fast comments. And then we go to the workshop session. Thank you so much.
May I share the screen, sir?
Yes, sir.
Yeah. On the background of details of UrgoClean AG, as told by Dr. APS Suri sir, I will be directly going with the clinical cases. Actually, I use UrgoClean AG for burns cases. We have a big burns center here, but I have personally not used it for diabetic foot ulcers. So these slides were kindly given by Dr. Sanjay Sharma. So that I should explain about the advantages of UrgoClean AG. This was a 65-year-old female patient with known history of diabetes, hypertension, and rheumatoid arthritis. She came with complaint of abscess of left heel, and it was a 10 days old infected wound, appeared with unhealthy wound bed with purulent discharge. After cleaning, the wound was dressed with UrgoClean AG. And this was the picture on 18th day, and this is on 25th day. You can see that after initial 4 dressings were every third to fourth day it was changed, and then afterwards weekly the dressing was changed. And with 7 dressing changes, the wound appeared healthy with granulating tissue. This was the dimensions on 7th day, 12th day, and 25th day. You can see the wound has started becoming smaller and healthier, less exudate and less slough. And it on the 25th day, it was quite small in size with healthy granulation tissue. And on the day 0, you can see that a lot of slough and infection. So in conclusion, after 3 to 4 dressing changes with Argoclin AG, pain and exudate levels had decreased. Wound bed appeared healthy. Within 7 dressing changes, the wound size significantly reduced, and we can notice a healthy wound bed with granulating tissue. Another case, 67-year male with history of diabetes came with multiple toe ulcers, and it was 2 weeks old, where again after cleaning, Argoclin AG dressing was done. And with around 7 dressings, you can see the change. This was day 8, and this was day 38. Almost the wound epithelialized completely after 7 dressing changes. So in conclusion, Argoclin AG helps for decrease in the infection and biofilm control. There is a good desloughing property, and wounds were cleaned. There was this solution decreased infection and slough, and it reduced the exudate. It improved the healing rate and reduced wound surface area. So in summary, it is one of the good dressing option in selected and indicated diabetic foot ulcers, especially when surgical debridements are not possible due to any reason. And I say big thank you to all the team IPACON 2021. I thank Dr. Suri sir, Dr. Saxena, Dr. Manish. This is my last presentation, so I'm overwhelmed with your all the gestures, and it was a great team effort by all of you. Thank you once again, and heartiest congratulations. Thank you.
Thank you, sir. Thank you so much for sharing your cases.
Good afternoon, everyone. Sir, can I start sharing my screen?
Yes, Pawan.
Yeah. Is the screen visible?
Yes.
Okay, sir. So I'll quickly start. Good afternoon, everyone. Once again, respected chairpersons, moderator, it's really a privilege to be in the august company of so many dignitaries. And just quickly going through, I'll be just showing cases regarding Urgo Start. Now, this is another product which Urgo has come out with. This combines the factors of TLC and NOSF. That is basically, it has the lipid colloid technology that Urgo is known for, but also has nano oligosaccharide technology, which helps in taking care of chronic wounds. But again, the indication for Urgostat is slightly different from Urgo Clean AG, where we saw that Urgo Clean AG was seen was being used in very infected wounds. But here we will see that they are used in chronic wounds. We come across such wounds wherein patient has had some trauma because he's a diabetic. He has been trying to use some dressings, but the wound has stalled and not healing. Most of these wounds will invariably have some biofilm, which I talked about yesterday. Now, this is day 0 of one of the patients, a 40-year-old male, diabetic for 31 years, 20-day-old, post-traumatic, non-healing wound. And after cleaning, we simply use the Urgo Clean. And that is how it looks on week 1, and that is how it looks on week 3. So again, the selection of patients for Urgo Start is very, very important. And this is how we see that it has improved. Basically, the lipid colloidal technology takes care of the microenvironment of the wound, making sure that there are things that are necessary for this wound to heal. And as we see by the end of week 5, the wound which was not healing for the last 3 weeks has completely healed. So this can add to the armamentarium that Urgo gives us, right from Urgo Tool, Urgo Clean AG, and Urgo Start. And they have a very strong evidence-based medicine with a lot of studies showing that how these products of theirs are working. Now, this is a second patient. Again, patient had an abscess in the little toe, was deroofed somewhere. It was going all the way to the dorsum. And when he came to me, he had a non-healing wound on the little toe. Patient had been already on offloading footwear. Pain is usually not a problematic thing for all these patients, because invariably most of them are neuropathic. So when we started it, this is how the wounds look on day 1. And as you see, again, we see that the exudate and pain score, it improves dramatically over the next 2 or 3 weeks. So that is how the wounds are looking. So day 0 and week 3, the patient is still under follow-up. But yes, I am sure that this wound will heal now. It's only a matter of time. This is another case. This was the case which was very, very astonishing. Patient had come to us with history of barefoot walking, and as we all know, because of the neuropathy, patient had come back with blebs. This was an absolutely clean wound, so we had to just de-roof the wound. But we were thinking that, looking at the wound and the size of the wound, we were thinking that he might end up with us for the next 2 or 3 weeks. But just look at the way it has healed. This is at day 3. This is not week 3. This is day 3, and this is at day 6. That is only 1 week. I mean, yes, it was a superficial wound, but looking at the extent of the wound, the TLC NOSF that is there in Urgostat has really showed its effect, and that is how quickly these wounds have healed. So there you go. This is the case 4. Yes, this was a patient who had already undergone a great toe amputation and had developed a pressure ulcer on the because the patient had stopped using the offloading footwear that was given to him, came back with a pressure ulcer over the stump of the great toe. And it was already a 2-week-old wound when the patient came to us. We debrided the wound. Because there was no signs of active infection, we thought of starting him on Urgostat. And that's on day 6. That's on day 9. The wound has already started healing. It's already healed. So that is when we made sure that the patient was educated about the offloading footwear, and clearly the patient has to come back and see us probably once every 3 to 4 months to make sure that patient is not developing any complications. But again, a very good effect of Urgostat, which is shown in this. So in conclusion, Urgostat is a very good addition to the armamentarium for clean to mildly infected DFUs with biofilms. Probably selection of appropriate patient is a must for the use of Urgostat. Again, as Dr. A.P. Suri sir said, that we have to keep the time concept in mind when we are trying to deal with any of these diabetic foot problems, because you cannot just say that you will use only one dressing for all the wounds that are coming. No, that can never happen. And in fact, that thing will keep improving or becoming bad depending on how good the patient's glycemic control is, how good the patient's wound care is. So depending on that, we will have to keep changing. But I'm so thankful to Urgo that they have come out with a whole range and evidence-based range. That is, you have Urgo Clean AG, you have Urgostat. So basically, you know which products can be used in which type of diabetic foot wounds. And yes, as Dr. Suri was telling, these can also be clubbed with other Urgo products to make a complete range of diabetic foot wound ulcer products. Thank you so much.
Thank you. Thank you, Pawan, for sharing your cases. It's very nice. Really, we are delighted to have your cases over here. Over to Prateek. If you have any comments on that, Prateek, are you there? Log in.
Yes, I'm here, Dr. Suri. Hello.
Yes. Can we have your fast comments or any question from the chat box? Let me see the chat box. What are the methods to keep wound moist apart from UrgoClean? See, the best is to, if you want to maintain moisture on the wound, the best are the hydrogels. You can use hydrogel. There are multiple hydrogels available, like HydroHeal. You have Silverex Heal Gel. You can go to one of the exhibitors in the exhibitor hall, Sun Pharma. They have got a very nice hydrogel. You can have details from there. Another is Purilon gel from Coloplast. That's also a very fantastic hydrogel which you can use. Tom Smile has multiple Indian companies have hydrogel. So you can use hydrogel to maintain moisture. The difference between using a hydrogel and UrgoClean would be that UrgoClean also maintains moist environment, but it works as an antimicrobial also. Like the case I showed, or Dr. Pawan has showed you a case. So until and unless we have something in our basket which can kill on the biofilm or eradicate the biofilms, because then only you will have a very good results. There are other methods also where you can have good results, but that is the difference between this. But moisture, if you want to maintain, you can have it with a lot of other things also. Yes, Pratik.
Thank you, Dr. Suri, Dr. Pawan, Dr. Ramakant Bemde, and Honorable Chairperson Dr. Ramakant. We are really excited to virtually participate in this conference on behalf of Urgo Medical. And if I may take a few seconds to share the screen, Dr. Suri, I would like to quickly share it.
We are already late.
Is it okay? Okay, I would just verbally say. I think one thing we really are very appreciative about is our products have brought a change in your clinical practice and given you results in clinical practice, which is excellent because we have a very high level of evidence. We have publications in the top journals, but what finally matters to us is that it really works in your day-to-day clinical practice in India. So thank you for sharing your cases and your live clinical experience, which really matters to us. And as Urgo Medical, we really love your theme of I Prevent Amputation. It is very much hand in hand with our corporate mission, Save Feet, Save Lives, which we have launched during this year as a special awareness campaign for increasing the awareness among patients of early referral and diabetic foot ulcer. So thank you very much once again for this session, and we are really happy to participate with you.
Pratik, I have a question for you. One is when is your Urgostat going to be launched? Because we are waiting for that. That's
I can promise on behalf of the organization, we are doing all we can to make it available very fast, and it will be with you very soon, sir.
I know you have given it to Pawan.
It will come soon. It will come soon.
He's a smart young guy. That's why you have given him.
अरे नहीं sir, ऐसे कैसे?
Okay. There's another question in the chat box. If there's any question from the invitees, we are open to that. Or otherwise, we'll go to the next session. We have two more sessions. Very good speakers in this. Dr. Ganeshwar Athru. He's a vascular surgeon and a very enthusiastic topic he has made. And then we have Dr. Tarun Grover, a very senior vascular surgeon from Medanta Hospital. So we would love to share. There's a change that session 11 is you have somebody, a lot of people who want to go through the delegate list. You go to the main hall in the main lobby, click on join session 11. From there, from the auditorium, you can go to the session 11. It's a going from 1:30 onwards. Over to chairpersons. Dr. Ramakant, I'll have the privilege to invite Dr. Ganeshwar Athru. He is a senior vascular surgeon from Telangana, from MS General Surgery from NTR University of Health Sciences, Vijayawada, Andhra Pradesh, DNB Diplomat of National Board from Delhi, MRCS from Royal College of Surgeons, Edinburgh, FRCS from Intercollegiate Board of Surgical Training from UK, PG certificate in diagnostic vascular ultrasound, and MCH vascular and endovascular surgery from University of Edinburgh from UK, and he's the executive member of University of Leeds from UK and member of Telangana chapter of Indian Podiatry Association. Welcome, Dr. Athuru, and you can share your slides. The topic is cost effectiveness of dermal substitutes in an Indian economic perspective study. It's a very nice study done by the by Dr. Reddy's, and Dr. Ganesha Athru will take us give us the insight into this study.
Thank you very much, Dr. A.P. Suri. Good afternoon, everyone. Just one clarification: this study was not done by Dr. Reddy's laboratory. This was a study done by myself. So no problem. So the basic intention of doing this study is that most of the people, both the patients and the doctors, are concerned about the cost associated with many of the dressings available for wound care. So when there are very good and efficient dressings or supportive measures available, one of the important factor that affects the clinical care is the cost of the application, whether it is ErgoClean or Oxal or any other thing. It is about the cost of the preparation versus the effect. So for this specific reason, I have done this clinical cost effectiveness of dermal regeneration template, mainly Integra, and is related to a Indian economic perspective. So thank you very much for the introduction. I'll just skip. Before we go into the cost analysis, it is really important to understand what is the natural history of diabetic foot wounds, what are the options available, what are the substitutes and their scientific basis, their clinical effectiveness, and finally come to the cost effectiveness. So as you all know, an ulcer or the feet of a diabetic patient can slowly progress. It can get infected, and infection can progress into the deeper soft tissues and affect the bone as well, leading to amputation or death. When we see wounds like this, one of the options available to us is primary closure, or we could leave it for it to heal by secondary intention with or without the support of VAC. Sometimes we may require skin grafting or local flaps or advanced flaps. All these options are summarized and labeled as the wound care ladder, which starts with the healing by secondary intention, and the dermal matrices fall exactly in the middle of this ladder. So what are dermal substitutes? So dermal substitutes are materials that act like the dermis of the skin and support in the management of wound care. So whenever there is an injury in the skin, normally there will be bleeding, thrombosis, into which the platelets and fibroblasts come in and release TGF beta 1. This promotes the fibroblasts to differentiate into myofibroblasts, which deposit collagen. Initially, they run parallel to the wound edge, creating tensile field, and they pull the wound edges to reduce the wound size and ultimately lead to scar formation. This is how a normally secondary healed wound looks like histologically, with the collagen laid parallel to the wound. However, if we look at the wound healing with the use of dermal substitutes like Integra, this wound defect is replaced by the Integra or the dermal substitutes. There will be accumulation of platelets and fibroblasts, but they will be much less compared to a normal wound, and there will be reduced fibroblasts differentiating into myofibroblasts. So there will be reduced contraction, and the collagen will be randomly laid, which affects the contractility of the wound. So this is really important in diabetic foot, because wound contraction can actually affect the remaining joints and tendons, leading to shifting in the pressure and the myomechanics of the foot. So this is the final histology. If you look, the top one is the normal scar, and the middle one is the native skin. And with the application of Integra, you will get a histological specimen similar to native skin. So there are several indications for the dermal substitutes, but I'll be concentrating mainly on the diabetic foot ulcers. Although there are lots of dermal substitutes available, some are not available in India, and I will mainly talk about Integra in this speech. So Integra is a dermal regeneration template, which is a bilayer membrane. It consists of the top layer, which is made up of silicon, which mimics the epidermal layer, and the second layer is the dermal layer, which consists of the chondroitin 6 sulfate and type 1 collagen. So coming to clinical experience, this product has been introduced in India 2 years ago, but I have been using this for more than 10 years in UK. So I'll briefly show you a couple of cases where Integra has been very useful. The first one is a 77-year-old male being a vascular ICU only patients with diabetic foot and peripheral arterial disease. So this patient already had a third and fourth toe amputation before coming to me, and then he underwent revascularization and removal of the remaining toes except for the first toe. So this is on day 0 when we apply the Integra. I always use a POP as well to offload initially. And these are the pictures from week 1 to 4. So usually at week 4, we'll be able to remove the silicone layer, and the company recommends skin grafting at this point of time. So this patient underwent skin grafting, and this is the outcome at 10 weeks and 8 weeks post the initial procedure. So coming to the second case, there is another 70-year-old male patient who is known diabetic and hypertensive with peripheral arterial disease, who already underwent revascularization procedure in a periphery, came back with occluded graft and gangrene of the fourth toe. So this was his CT angiogram. We revascularized again using a vein graft and amputated the third, fourth, and fifth toes. So this was the wound bed. This is just before the Integra application. We initially used the VAC for 2 weeks before applying the Integra, and this is at the time of application of Integra. Week 1, week 2, week 3. So generally at week 3 and week 4, we need to make sure that the Integra is integrated well into the wound. So as you can see here, the silicone layer, although it is coming, the actual Integra hasn't been actually adherent to the tissue as such. So at 4th week, we remove the silicone layer, and week 6, week 8, and by the 20th week, it has completely healed. So in this particular case, we haven't used any skin grafting, and this is exactly similar to Dermacell and other substitutes, where although majority of the people would recommend skin grafting depending upon the size of the wound, it is not essential that these patients have to undergo skin grafting. And as you can see, the cosmetic result and the functional result is much better without skin grafting. It may take a bit longer time to heal, but ultimately the outcome is much better. So many people wonder whether we should use Integra, whether we need to have a culture negative wound before we apply the Integra. In our experience, it is not essential that you have to have a culture negative wound, but it has to be visibly clean. So this is one of a case where when I initially saw in the clinic, it was visibly clean, and by the time they reached the theater 3-4 days later with simple dressing, again there was some evidence of infection. So this was in the theater, but we proceeded with the application of Integra, excising the tissue. It grew Pseudomonas, which was resistant to all antibiotics except for colistin. This was the post-operative pictures from week 1, week 2, week 3, and so on. And here you can see the silicone layer easily peeling off compared to the previous video where it was completely adherent. So from these 3 clinical scenarios, we can understand that Integra dermal substitute is efficient in helping wound healing with or without skin grafting. And it is really important that we apply this very early, and the silicone layer has its own value. So now moving on to the financial or the cost effectiveness of Integra, it is really important to understand what are the costs associated and what are the benefits. So the actual cost of treatment, when we are considering, adding Integra, we need to only take into consideration of the extra value of Integra rather than the entire cost of the treatment. whether we use Integra or not, the wound bed preparation is really important, and good wound care is essential. This includes revascularization if it is a ischemic ulcer, use of appropriate antibiotics, surgical or medical debridement, and amputation for gangrenous tissue and offloading. In addition, we may choose to use VAC therapy or any other appropriate dressings as well, and systemically control the systemic factors like diabetic control, anemia, vitamin deficiencies, and other things. So apart from the recurring cost, the additional cost incurred by Integra is the cost of the Integra itself and the theater charges for applying it. The benefits, especially when we are analyzing in effectiveness, these can be direct, indirect, or intangible benefits. And there are several ways of analyzing it. And one of the method I have used is based on the founder study. This is the only randomized controlled trial that is available for Integra, where they have specifically looked at the clinical effectiveness of Integra in diabetic foot ulcers treatment. So briefly, this is a randomized controlled trial consisting of 3 phases. The first phase, they screened for 14 days to make sure that the wounds are chronic wounds, not healing at the pace what they should be. And then they have included in the study period where the Integra was applied and observed for 17 weeks, followed by a follow-up period of 12 weeks. So this is the randomization process. And finally, 106 people completed in the Integra group and 82 completed the complete follow-up phase in the control group. So the result showed that application of Integra improved the healing process by reduction in wound size. So the top one is the control and the bottom one is the Integra. And similarly, as weeks progress, the proportion of wounds that have completely has increased in the Integra group compared to control. So based on these findings of the randomized controlled trial, I have used a Marcos model, which assumes that whenever we have a diabetic ulcer, there are different outcomes. And these, based on each outcome, the cost and the benefits vary. So as you can see, a non-infected wound ulcer can heal, or it can get infected, gangrenous, or recur after amputation, ultimately leading to further amputations, gangrene, and amputation. So in this study, comparing both the cases and controls at week 4 and week 16, 51% of the wounds have healed in the Integra group compared to 32% in the general wound care. Similarly, serious adverse events were much less, and the moderate adverse events were also less. So serious adverse events were amputation or death, and moderate adverse events were infection, antibiotic usage. So this is week-on-week comparison with Integra and wound care. So on average, the patients in whom IDRT was used, it has healed 5 weeks faster compared to the control group. So if we include the Indian setting of costings, this can vary from place to place, but I have taken the average. It is, so the initial cost of Integra application of 5 into 5, which costs 25,000 rupees, will save for in 5 weeks a total of 65,000 rupees, and hence it is much cheaper than general wound care by saving 5 weeks of wound healing time. So we can conclude that Integra falls into the category of treatment A, which is less costly and more effective compared to general wound care in this grid. Thank you very much.
Thank you, Dr. Ganeshwar, for a nice presentation. You are true in saying that we have to see the cost effectiveness for our patient for these type of dressings. That's very important, and it is a very nice illustration what you have shown. On the outside, I want to thanks our two moderators for this session. One, Dr. Rashid from Bangladesh. He's an IPA Life member, and also he has done FDFM course. And also Dr. Indika from Sri Lanka. We have 8 to 10 life members from Bangladesh and Dr. Indika from Sri Lanka. In the morning session, we have Dr. Robin Muski from Nepal. So IPA has its associated members in the other SAARC countries. So we welcome you all for this IPA call. I would like to invite Dr. Tarun Grover. Can we have the slide, please? Senior vascular surgeon from Medanta Hospital, Gurgaon. He is a FNBE in peripheral vascular and endovascular surgery from Sir Gangaram Hospital, New Delhi. MNA MS Gangaram Hospital, New Delhi. DNB from Gangaram Hospital, New Delhi. National Board certified. And I showed you he has vast experience of vascular surgery in this part of Northern India. And he has patients from all across from Northern India to Tarun. The topic given to him, I think everybody knows, management for deep venous thrombosis in pandemic. This is a topic I think everybody knows, and everybody was suffering with this problem during this epidemic. As we know, during COVID, there were multiple of patients suffering with this venous thrombosis. Dr. Tarun.
Thank you so much, Dr. Suri, and I must congratulate you to organize such an excellent academic feast. I'm sure, and you know, the best part is the way you have chosen all the topics. It's really commendable because you have covered all the aspects of wound care, diabetic foot, and including the vascular aspect, everything. And I'm sure this is a very apt topic in today's pandemic scenario. And what I'm going to talk about is the management of COVID-related thrombosis, how to avoid thrombosis, and more importantly, if in case somebody develops, then how to treat it. And all of you will agree with me that we were hit last year around January and March. The whole world, in fact, was hit by COVID-19. And as we started seeing a large number of patients, and once these patients were treated all across the globe, people started seeing that COVID associated coagulation, there was significant data which was arising from most of the centers which were involved in treating COVID. And nobody expected what was to follow eventually, because it was a newer disease. Everybody was learning on the go. They were not aware what are the risk factors and how to prognosticate the disease, which patients will land up in the ICU. So there was a lot of, I would say, uncertainties associated with this disease, because nobody had encountered something similar to this before, especially on such a larger extent. And most importantly, when we look back now retrospectively, Rudolf Virchow, almost 5 decades earlier, he gave a concept how deep vein thrombosis develop. And there were 3 important criteria. Number 1, stasis. Number 2, endothelial injury or injury associated to the blood vessels. And third was a hypercoagulable state. And what was observed in this viral pandemic, and it's not only this viral pandemic, initial other viral diseases have also been associated with hypercoagulable state. So what was observed, that all 3 elements of Virchow triad were experienced by these patients who were admitted or were being treated at home. The cytokinin storm ended up having significant endothelial injury. The disease per se created an hypercoagulable stage. A lot of patients were immobile, which promoted vascular stasis along with the steroids. So what the whole concept, pathophysiology was involvement of all these 3 factors, and ended up in activation of coagulation cascade and led to significant amount of microthrombi in these patients. And there were certain, I would say, characteristic hematological abnormalities which were observed in these patients, which were especially leukopenia and lymphopenia. Everybody talked about the NL ratio. Everybody knows that the lymphocytic count really felt significantly low, though it was associated with mild thrombocytopenia, unlike other viral diseases where patients experience significant thrombocytopenia. Then all of us, we know that most of these patients, when their D dimer levels were checked, they were over the roof, because people had D dimers level beyond 10,000, 30,000, and all those. And because of all these derangements, the coagulation parameters were significantly deranged. And all these derangements were associated with, if somebody has a significant derangement of NL ratio, associated high D dimer levels. So relatively, were the individuals who would require eventually an ICU admission. They were the one who, because of the extensive cytokinin storm, required mechanical ventilation, and high mortality was also observed in these patients, because these patients, they had significant amount of microthrombi involving all the vascular beds, and especially the pulmonary vascular bed. Though DIC was seen in a very late stage and was not something which was seen very frequent, it was a different sort of an coagulopathy which was observed with this disease. And we know the risk factors in especially patients who had significant comorbidities like existing chronic renal disease or chronic pulmonary obstructive disease or malignancy. So these patients were the ones who had suffered mostly. And the lymphopenia especially added up with the secondary infection, and pulmonary microthrombi, intravascular coagulopathy, and all these were significantly associated with multiple comorbidities. And the clinical outcome which was seen because of these micro and macro emboli was patient who suffered from venous thromboembolism, myocardial infarction, and disseminated coagulopathy. Initially, post-mortem studies were done, and when the people, they realized that it is not the mnemonic consolidation, in fact, it is the microthrombi in the pulmonary vasculature which is leading to the extensive lung involvement. And because of these reports coming back, and so once the analysis was started doing, it was seen that there was a significant high incidence of venous and arterial thromboembolism in patients who were suffering from COVID-19 disease. And an overall 21% of venous thromboembolism was reported, which increased to 31% if these patients who required ICU admissions. And 28% patients presented with deep venous thrombosis, and 19% patients, they presented with pulmonary embolism. We did see large number of patients with arterial thromboembolism, and it was really unfortunate, being vascular surgeons, not able to help these patients, because it was very disheartening to predispose, or I would say, these patients to such an extensive thrombosis. And because of delayed presentation, not able to move around because of various lockdowns, and not able to get treatment on time, the number of amputations all of us we have performed in last 2 to 3 months were really very disheartening and very disturbing. So once, I would say, all the medical authorities, they realized that the coagulopathy associated with COVID disease is leading to significant high number of deaths and comorbidities and mortalities, then most of the medical organization across the board, they came out with their recommended guidelines, because they realized that initially, if these patients are adequately anticoagulated, and they have given proper prophylaxis, and we can control the formation of these microthrombi, we would eventually improve the outcome of these patients, and we won't let them go to that particular, I would say, across that line where, there's the point of no return, when they have such an extensive disease where these patients were not being able to salvage. So quickly, I would just summarize the guidelines which are now generally accepted. And I really hope and pray we don't see the third wave. But whatever we have learned till now, and what has been the guided recommendation, is that anticoagulation prophylaxis with low molecular weight heparin or unfractionated heparin is very important. and there is no role of antiplatelets. Now, it is very essential to understand if some patients were already on antiplatelets because of their pre-existing either coronary artery disease or a cerebral vascular event, these antiplatelets can be continued, but they do have to be combined with some anticoagulation. What the misconception was, a lot of physicians, they thought that probably if these patients are already on antiplatelets, they probably don't require anticoagulant. So what we require is in this disease is an anticoagulant, but in case they were on dual antiplatelets, we can reduce antiplatelet, bring them down to one antiplatelet and add on an anticoagulant. And standard dose of anticoagulant prophylaxis was followed, which is the established dose for all other diseases or all other conditions. Now coming to the inpatient thromboprophylaxis only. So what was observed initially was that all inpatient patients, they require the thromboprophylaxis. So I would say this was true till the first wave of epidemic, where we saw most of the patients who were having moderate to severe disease were hospitalized. But I would say this year that concept has changed, because what has happened is that a lot of patients who had moderate to severe disease, they could not even get hospital admissions. They were treated at home care settings, which means that we should not categorize that only in admitted in hospital patients they require thromboprophylaxis. All those patients who had significant comorbidities, all those patients who had moderate disease, all those patients who were immobilized, or they had a high CT score, or they were on steroids, they should have been given thromboprophylaxis, and ideally they should be given. And even following discharge, if they categorize for anticoagulation, it should be continued for at least 4 weeks beyond the discharge. No routine screening for detection of asymptomatic VT is to be followed, because there was significant high number of patients. If CT pulmonary angiograms were performed, these patients, they had significant pulmonary embolism, but it has to be understood that unless until 80% of the vasculature is involved, these patients will not develop any symptoms. And there was no indication for use of systemic thrombolysis in most patients who had acutely confirmed but asymptomatic, which means which was pulmonary embolism, which was not associated with hypotension or any shock. But systemic thrombolysis was indicated in patients who had hypotensive shock, or they were not showing any improvement, and they simultaneously had no contraindication to be given a systemic thrombolysis. Even the Indian guidelines, which were created by the Ministry of Health and Family Welfare, they suggested all patients who had moderate to severe disease, they should be anticoagulated with low molecular heparin. But again, what we observed during this wave, because of the large number of patients, there was a challenge to organize low molecular weight heparin for all these patients. So here I would say, I would like to highlight, there was a role of NOACs, which we, by NOACs we means the newer oral anticoagulants, which were used successfully and gave a good result in COVID-19 treatment. And the only thing which we have to understand is the only interaction these NOACs they have is with antiviral drugs and some antifungal drugs. So unfortunately, those patients who were admitted in the ICU and who were on antiviral drugs, LMWH was preferred instead of NOACs. Apart from all that other groups where no antivirals were used, if these patients were admitted in the hospital but not in the ICU, or they had moderate disease, they were at home, or they had certain comorbidities, all these patients were managed by NOACs. They were given the newer oral anticoagulants, and the efficacy and safety profile was as good as the low molecular heparin. And giving them timely when the disease set in, it showed a significant benefit, and we hardly have seen any patients with thrombotic complication where anticoagulation was initiated on time. So which further emphasizes that all patients who required thromboprophylaxis, if initiated at correct time, saved them from having significant high number of morbidity and mortality. And we all know that there is a significant advantage of NOACs over the existing vitamin K antagonists, the conventional anticoagulants like warfarin and acetron. And So even post-discharge, extended anticoagulation was given in selected group of patients where these patients, the biochemical markers, the D-dimers were twice the upper limit of normal. These patients had stay in the ICU. They were elderly patients. They were immobilized. So basically, what these patients, if they had risk factors, they were discharged on rivaroxaban and apixaban. And being in a tertiary hospital setup, I know most of these patients were discharged on NOACs rather than on LMWH because it was observed in the short experience across the world that these drugs also had equal benefit as compared to the lower molecular weight heparin, which were initially indicated or they are well accepted to be used as thromboprophylaxis in this group. And rivaroxaban and apixaban, which were the commonest one, which were used in India. And so I would say in this sort of an era of COVID, why NOACs have significant importance? Because there were certain, I would say, common findings which were observed. A lot of people were restricted to their homes. Everybody was working from home. Their mobility was restricted. There was lockdown. So they had limited access to medical care and general practitioner in hospital, limited access to pharmacies. A lot of people, they feel apprehensive to take the even a subcutaneous injection on their own. And most of the hospitals were, I would say, saturated and overcrowded with the acute patients. So in such a scenario where we know the disease is having a very significant chances of developing thrombosis in these patients, and it is pretty safe and efficacious to use NOACs in these patients. So this could be safely used in home care settings. And we know the major limitation which we have talked about, the initial conventional anticoagulation, because they have a narrow therapeutic range. We need to monitor INR regularly, which was a major challenge during the lockdown because there were no labs which were doing these tests because the labs were oversaturated. Nobody would come for home sample collection. You can't go out to give your blood sample to the hospital because of the fear of acquiring COVID or spreading it to others because of the lockdown, and highly variable dose response, which would have really created a lot of complication in this group of patients if they didn't have a proper INR monitoring. So US FDA has already approved rivaroxaban to prevent blood clots in acutely ill patients. So I would say off-label use of rivaroxaban was extended to the COVID-19 patients, and with a very I would say, though the company does not at this stage recommends or approve the use of rivaroxaban as treatment or thromboprophylaxis in COVID-19 patients, but with the large number of patients, what we have seen, it had really given good result. And now most of the international health agencies have endorsed in their guidelines and hospital protocols to use NOACs. So I would say NOACs are pretty safe, except for the ones who are in the ICU. So to conclude, I would say that COVID-19 has been associated with significant high number of thrombotic episode. Hypercoagulability was a prominent feature of all COVID-19 patients. Micro and macro thrombi, both involving small and large vessel, we have seen. So multiple guidelines have been published, and now it is very well established that all hospitalized patients should receive thromboprophylaxis, which I would say which should be extended to even the domiciliary care patients if they have a moderate disease, because in this scenario a lot of patients could not get a bed in the hospital. And documented VTE, continuous anticoagulation for 3 months is required, and extended prophylaxis, none versus maximum. Now, none versus wherever it's indicated should have been given to almost for 4 to 6 weeks. So that's very important. So friends, to conclude, I would say that first of all, I would really hope and pray that we don't see any other wave, but in case we happen to see any cases, we must keep our eyes open, and we should immediately start putting these patients on proper anticoagulation, because if we start them on proper anticoagulation, we're going to save them from significant morbidity. Thank you so much.
Thank you, Tarun. Yeah, I have a question in this. What percentage of your cases were having pulmonary embolism in these cases?
So, Dr. Suri, it's a very good question because that's why the guideline says that we were not chasing asymptomatic VTE, but certain post-mortem studies and some CT pulmonary angiograms which were done, because most of the CTs which were done outside were non-contrast enhanced, they were just plain CTs. But wherever regular CTs were done, 80 to 90% of patients, in fact, everyone had microthrombi involving the smaller segmental vessels. So
Yes.
that was the reason to develop pulmonary involvement. It is not I would say, normal, regular mnemonic consolidation, which is because of the parenchymal involvement. It was the vasculature which was involved, which led to the consolidation. So everybody who had this disease had some amount of microthrombi in their lungs.
Oh, yes, yes. Absolutely. We hope that we don't see any other waves.
Yeah, definitely. And next time we have a conference face-to-face sitting across in the same room.
Yes, yes. Thank you so much. Dear
Most
Chairperson,
welcome.
are there any questions there, or we can? Yeah, we're going short. We are 15 minutes late because there are live workshops going on just after this, workshop 2, 3, and 4. So thank you, Tarun, for a very nice presentation, for coming. Thanks to Dr. Anishwatru for a nice presentation, and my co-chairs, Dr. Ramakant and Dr. Pavan. Thank you so much.
Thank you so much, Dr. Suri.
Thank you, Tarun. Thank you. So nice to see you here. Over to Dr. Shrishti.
Thank you to all the moderators, chairpersons, and the speakers, Dr. APS Suri sir, Dr. Ramakant Bemde sir, Dr. Pavan Belehalli sir, Dr. Jnaneshwar Ataru sir, Dr. Tarun Grover sir. Thank you very much. Moving on. People are broken, messed up, tired, hopeless, helpless, and we are one of them. But we choose to be healers. We want to heal the world because we think we can. I would like to call on stage Dr. Sandeep Suri sir, senior diabetologist. Sir works with advanced diabetes and critical care at Holy Health Hospital, Hisar. Sir is the recipient of gold medal at CMC Vellore. I welcome you to the workshop, sir. I request you to kindly introduce the chairpersons.
Yes. At the outset, I must thank Dr. APS Suri and Dr. Rajneesh for the nice organizing very nicely the IPACON 2021. And we were very much apprehensive how things will be going and what will happen. So many nightmares and so many things were there in our minds. But let's see what is there in front of you. It's all God's blessings and their hard work that is paying the dividend to us. Now, so coming to the workshop second, we are got a very excellent galaxy of chairpersons for you. And the first I'm going to invite Dr. Imtiaz Ahmed. And sir is highly experienced. He's a senior consultant, general surgeon, and diabetic foot surgeon from Khairitabad, Hyderabad. And he has done his MS from Osmania University, 41 years of experience. He had his own diabetic foot setup at Khairitabad and is an executive board member of IPA Telangana Andhra Pradesh chapter. So welcome you, sir. Next, I'm going to invite our chairperson, Dr. Amritpal Sodhi. He's a well-known figure in North India, highly acclaimed, very knowledgeable, highly experienced. He's a consultant diabetologist, diabetic foot specialist, and non-invasive cardiologist. He is from Moga, Punjab. He has got his own hospital, whole setup of cardio-diabetic hospital at Moga. He was the person who successfully organized first ever diabetic foot symposium in Moga in Punjab in October 2016. He was organizing chairperson at first ever state level diabetic conclave 2019 in Moga in Punjab. He was honored with International Medical Excellence Award for Social Outreach in Diabetes in Bangkok 2013, Proud of Moga Award in 2015, and various other awards at different CMEs and conferences. Welcome you, sir. Yes. The third chairperson is Dr. Harish Darala. Designation and organization, he is consultant physician in diabetes and endocrinology, director Darla Healthcare, Mysore, chairman for Committee for Infectious Disease at Vikram Hospital, Mysore. He has so many laurels against his name, awarded FRCP from Edinburgh, Glasgow for exemplary work in diabetes and endocrinology, worked in UK for 5 years at various positions, Joint Secretary for Indian Podiatry Association Karnataka chapter, mentor of diabetes educator course, helped defeat diabetes trust, conducted very first one-day diabetic foot CME, Let's Save a Limb, on 15th December 2019, and welcome you, sir. And the next fourth chairperson, Dr. Sunil Soni, is a very close friend of mine from Hisar. He is the senior most plastic surgeon from Hisar. He is MCH plastic surgeon. We are really blessed to have him here at our center, and he is a really boon for our patients at Hisar, Haryana, and Northern India. He is a director, Soni Burn Plastic Surgery Hospital, Hisar. Welcome you, Dr. Soni. So can we start the workshop? And I hand over the podium to chairpersons for inviting the speakers.
Dr. Imtiaz, or can I start?
Yes, I think Dr. Suri, you should start.
Yes.
Yeah.
Start sharing. Can I share my slides?
Yes, sir, please.
Yeah, yeah.
Yes, sir.
Good afternoon, everyone. Over to you for this dressing session. We are having three very nice workshops, number 2, number 3, and number 4. The first one we have already done in the morning. Mostly I'll be taking with my all co-speakers over here. In this workshop, we have 3 speakers, myself as one of them. Then we have Dr. Francine Smith from UK. She's also joined. And Dr. Santosh Murthy from Hyderabad, Telangana. So he'll be also sharing his cases. So what we'll be doing is that 15 minutes, each of us will be taking our time. And then we have 10 to 15 minutes of discussion into this. So what we'll be showing you is mostly the dressings to all the delegates over here, because we all know that dressing is a very important part, as I was covering in my previous 2 sessions. We have to think of ourselves that what type of dressings we have to do. Whenever ideal wound dressing we have to see, it should be which promotes wound healing, which contains a moist wound environment, provides a physical barrier, should permit gaseous exchange and non-adherence to the wound. The next day when we open, we should always see that these wound dressing should not be able to adhere to the wound, and permits easy removal without pain or trauma, and capable of absorbing excessive exudate. Whatever we use foam dressings or whatever dressings we use, it should have the power to take away the exudate. Easy to use, and other thing is cost effectiveness, as we have seen with Dr. Pru's presentation. We have a lot of things in dressings like films, hydrocolloids, hydrogels, foams, alginates, hydrofibers, collagen, and ECMs. Coming down to first to hydrogels. If you look at hydrogels, what they are 99.9% water-based solutions. They have the capacity to maintain moisture on the wound bed. With the moisture, they have the capacity to do fibroblast migration, collagen deposition, and also epithelialization from the periphery of the wounds. We have Silver X Heal Gel, very cost effective, less than something around 200 rupees for that. Purilon Gel is from Coloplast. And we have nanocrystalline silver-based collagen-based cream, Nanogen from Tom Smile, and many others like Hydro Heal we have, hydrogels we have. So multiple companies have these hydrogels. I think anything in wound care we have to see. Any doctor dealing in wound care should be able to know about hydrogels, and you should judicially use hydrogels into this. They can hydrate a dry wound. They come in tubes, impregnated gauzes also. They are best for the deep wounds and dry wounds, not for the exudative wounds. If the wound is wet, then you should not use these dressing, because they will make it more moist. Usually they require a secondary dressing to absorb the moisture or to maintain moisture over the wound bed. And these are the best dressings for the moist wound healing. Hydrogel, as I said, they contain 99.9% water-based solution. Now, if you look at this wound, this has got a lot of biofilm impregnated over here. It's a 4-foot amputation. A posterior inferior plantar surface flap has been saved. And this you see granulation tissue is there, but it is a dry wound. In fact, these both the photographs are of the same patient. These are about 3 weeks before, and this is 3 weeks afterwards. Now, if you see a patient like this, you should not try to use hydrogel. You need something to remove the biofilm, kill the biofilm over here, or you take a curettage, or if you have ultrasonic debridement, you ultrasonic debridement with that, you remove this discharge or the biofilm. There's no process of doing any cultures for it. Don't be unjudicially send cultures for this, because these cultures will give you the bugs which are all totally resistant to them. Over here, if you see, now you need hydrogel to make the wound moist, and more little bit before you either do a graft, or if you want to apply a vac over this, you can apply a vac over there. But if you don't have the facility of vac, or the patient's cost constraints are there, hydrogel are the best thing for this patient. Keep on using hydrogel, very thin layer of it. You can similarly use a very thin layer of hydrocolloid sheets if you have, or you can use hydroferra sheet if you have. You can use it, but hydrogel should be judiciously used over this wound to make slowly and slowly. You see there will be a more than 50% reduction of the surface area in this. Again, a 4-foot amputation, dry wound on the periphery, on the plantar surface. There's a wound over here. Epithelialization is occurring if you see over this area, but it's a dry wound. So here comes the role of hydrogel. If I see a patient like this, I will mix hydrogel with collagen. I will take a layer of collagen fibers or a collagen sheet, mix with hydrogel, and then I will apply it over this area. And within 2 weeks of time, they will all epithelialize into this. This is again a venous ulcer, a big ulcer on the lateral part of the lower limb. You see, this is epithelialization which has already occurred. So take a curate, remove this biofilm. Still, there's a biofilm over here. And if here we are talking of the biofilm hydrogel, so yes, you can do a hydrogel, but initially I told you just before, urgo sheet, urgo screen, AG would be a better answer into this, because that sheet will maintain moisture into this and also debride this biofilm and the necrotic tissue by the TLC AG process. Coming down to foams. Multiple foams are available. You have to see in your clinic or your hospital what are the best things to do. Over here, we are using biotin silicone AG, very cost effective, very effective. This is a foam sheet which have a silicone border over this area. It prevents the lateral spread of the tissue or the fluid on the peripheral tissue. It will not got the lateral spread, and the vertical absorption is very common in this biotin AG sheet. It has silver impregnated, so it works as an antimicrobial and also has 4 times its capacity to soak the discharge into this. This is another very open cell foam sheet, neon, very effective. We use it in our practice and very cost effective. Hardly the sheet cost about 200 to 250 rupees to the patient. Another is a hydroferra blue sheet. This comes from the company from USA, very effective. We are using for many years into this. This is a hard sheet. You have to mix normal saline over this area, over the sheet. It will become very soft. And suck, and then you can squeeze that, let the normal saline go, and then you can apply a little bit of hydrogel over this surface, and then you can apply it. If I go back to this patient over here, if I have hydrofiber, hydroferra, I will use hydrogel, Silverex heal gel over this area, and then apply hydroferra sheet and this blue sheet, blue color sheet, and leave it for about 2 to 3 days of time. Let the biofilm eradicate, and all the discharge will absorb into this surface area. So that's the glamour of using this foam. These foams sometimes are a little costly to the patient, but then we have to see that we can leave these sheets for 2 to 3 days of time. So by that time, the cost will come down. Suppose a sheet is something around 800 rupees to the patient. If you are leaving that for 3 days of time, it comes down to about 200 rupees per day dressing cost to the patient. Again, this will sheet. This is a dry wound over here on the posterior surface of the wound, on the posterior surface of the heel. We are little bit allowing more granulation tissue to form over this area. So I am using hydrofiber, but if you look at hydroferra, but if you look over here, it's a dry wound. So I will need to use little bit of hydrogel into this. Oh, sorry. This is a video.
And then we can apply this on the wound. If you see here, there's very little granulation tissue here. So to over here, we can do the curing. To remove the biofilm is very important. And whenever you use, maintain a moist environment. To maintain moist environment, we have to use hydrogel.
This is a hydrogel I am applying on the sheet.
On this wound, on the sheet itself, and then we can apply that on the wound.
In this type of wound, you can leave it for about 3 days or maximum up to 4 days of time. If there's not much discharge, you can leave it for about more than 70 to 80 hours of time. And wet it with normal saline. You just have to use normal saline on that. This is again now anterior part of the leg. Again, I can use hydrofiber. There you see a discharge, biofilm, shiny layer. Peripheral, you can see this white tissue. There's a lateral spread of the discharge. So you need to have a foam sheet. Either you can use Biton AG foam sheet or Hydrofera or Neon, whatever foam sheet you have, you can use it. But don't use hydrogel now, because if you use hydrogel, it will make the wound more moist. Already the wound is moist. So use a foam sheet, will takes away the discharge and maintains moisture also there. So you have to judicially see yourself. If you have to work opposite, if the wound is dry, use hydrogel. If the wound is wet, use foam sheet to make it little bit dry. But see, you have to build up the granulation tissue or epithelialization at the periphery of the wounds. Another very important dressings to be have you in the basket is alginates. Alginates are best for the deep wound or medium to high exudate wounds, available as sheets or ropes also. It maintains moist wound bed, requires a secondary dressing. We have Aquacel AG or Caltostat, and very important is Suprasoft AG. This is very important from LR company. It's available in India, and these are the fibers. They are made from the hydrofibers are mainly, they contains entangled fibers, and they have got 5 to 6 times their capacity to absorb the moisture. So whatever exudate is there, that exudate or bacteria entangles in these fibers. So this is a very effective sheet, and we are using that, and you can leave it for about 2 days of time. If there's a lot of discharge, use it for 1 day. If there's less discharge, use it for 2 days. These are the fiber. They are spun from the calcium salts of alginic acid, moderate to heavy drainage, and these are the hydrofibers. They reduce the lateral spread of the fluid. So very effective in using. You can use them on venous ulcers also. They trap the bacteria within the fibers, and they form an intimate contact with the wound bed. So this is the glamour of this sheet. So hydrofiber again is a very important part to have it in your wound care basket. There's another powder which we are using is Ultrazil. Now Ultrazil powder, if you see, these are white granule powders. They are very effective in causing again removal of the biofilm and also help in the cavity wounds. They are mainly used for the where the cavities are there. Now interdigital cavities like that. So what you can do, you can clean it, take a curette and swab this. You can see good granulation tissue being found, but there's a deep cavity over there. So entangle, put this Ultrazil powder over there and take a gauze piece, wet it with normal saline and then put it. Because if you put a powder, it will again become dry. So the moist wound healing will not happen. So you have to moist the gauze piece and then put it over this wound. This is again another fasciotomy has been done on the lower part of the leg. So you can see in this video, very less granulation tissue is there. This is the fascia, no dead tissues are there. But you need this cavity to fill up again. But after either I apply sutures or I close it by secondary intention. So what I am trying to do is, Sudhir, can I look for this video? There's a video here, but can you see? Back. Oh, there's a video. I'm sorry, it's not working. So I will apply Ultrazil powder over this, and then I can apply a gauze piece wet with normal saline, and then I can use it over this area. This is again cavity wounds, similar two wounds on the posterior part of the two over here. Both the patients didn't have any osteomyelitis. In this patient, you see a lot of biofilm is there, a lot of debrided dead tissues are there. So take a scalpel, remove this dead tissue, take a curettage and curate this. You will find granulation tissue at the lower part of the wound. But yes, you can use Alstrozil powder and take calcium alginate sheet. A rope sheets are available. Long ropes are available, which I showed you, Silver Soft AG sheet or calcium alginate sheet. Take a small piece and put it into this cavity and wet it with normal saline or Vox seal. Vox seal will be a better solution. Put Alstrozil powder, put Vox seal with calcium alginate. So three things, because you have to fill this cavity and slowly it will granulate. Over this wound area, you see that there's a good granulation tissue form. You can still, if you want to clean it with normal saline, put Alstrozil powder, but don't use any hydrogel here. Don't use any hydrogel here because both the wounds are wet wounds. Vox seal we have already covered over here. It's a diperoxide chloric topical solution, very effective in granulation, where you have to develop this granulation tissue. So this has two bottles come. One is an activator. So you have to mix these two bottles and then you give it to the patient and they can use it. This patient we have already covered, have all the photos amputated. Not good granulation tissue is there. So we allowed this patient to do Vox seal dressings for about 2 to 3 weeks of time. By the time we have a granulation tissue over here, you see the cavities and tendons exposed over here. So they have also filled up with granulation tissue. And later on, we have grafted this wound. So these type of modalities, we can use it in our practice where we have to see, now you see there's a dry tissue here. So Vox seal will make it wet. We maintain moisture and we allow it to granulate more, and then we can take these patients for grafting. Extensive debridement, malignant melanoma, I have already covered in the session. Debridement has been done on the heel area. Then we have allowed this for Vox seal solution. Again, now you need foam sheet because there's some discharge over this area. So I'll use Vox seal with hydrophera foam on this wound, make more granulation tissue, fill up this cavity over here. In between, we have used VAC 2 or 3 times. We have used VAC on this patient, and then look at after the opening of the VAC, a good granulation tissue, and then we have done a simple. And then we have done a grafting over this wound. This is another wound on the heel area, a very bad necrotic wound. We got the MRI done to look at the osteomyelitis. This patient was having this, there's a bad ulcer. We didn't got the initial photograph. It was placed here. I'm having some problem with my presentation here. So Purilon gel is again a hydrogel from Byton AG company, Coloplast. And Purilon gel is very effective for developing this granulation tissue. You can see this dead tissue. So whenever the patient comes, you can take tooth forceps with a scalpel, try to remove this dead tissue slowly. And when you see, you can fill up with hydrofiber sheet, or you can use hydrophera sheet inside the cavity, and this necrotic tissue will be debrided. More granulation tissue will develop. But offloading is important. If the patient is walking on this heel, every time he is putting more weight. So in this type of ulcers on the heel, on the lateral part of the heel, or on the plantar surface of the heel, offloading is very important because these dressings will occur for about 3 to 4 weeks of time. So you need something or more than that, sometimes 6 weeks of time. So you need something so that patient is mobile in the house. They are going to the bathroom, they are doing their day-to-day activities. So we can use these type of them, but offloading is very important. Now, when your granulation tissue has developed, then you need some sheets where you need for epithelialization, because closure of what is the main goal of the wound healing is there, of wound management. We have to close the wound, whatever it is. If we go to the peripheral, now if my whole granulation tissue develops over here, the wound bed all is closed. What is the goal there? It will not epithelialize on this. I will graft this wound. But on a smaller wounds, I need something for epithelialization. So Emcoplast, this is an human amnion chorion allograft, very effective sheet. This comes like this. You wet it with normal saline and put it there and leave it for about 3 days of time. And collagen, India is a big country for collagen. Most of our collagen is exported all over the world. South India has excellent collagen sheets for our country. So wet collagen and dry collagen, 2 things are available. There are multiple companies. So you can discuss with your vendors and have that. So when good granulation tissue has formed, you see the wound is of the discharge. biofilm is not there, then start using this collagen sheet. If you don't need to develop or you have to wait, sometimes patient's ejection fraction is low, patient can't be taken in the OT, or can't you take them for grafting. In those cases where medical reasons are there, you can use these type of collagen sheet for epithelialization, and slowly, mainly bed sores. Bed sores are the places where a geriatric group of patients or ICU patients where necrotic tissue has been debrided, wound is ready now. There you can use collagen sheet, but use a foam sheet. Sometimes we can apply collagen, and then over the collagen outside, we can apply foam sheet so that pressure is offloaded. This is again a necrotic wound on the foot. This lady was on the bicycle and she had a burn injury on the lateral part of the arch. We started using UrgoClean, very cost effective. The full sheet you can gaze and see the patient is using a small piece with a sterile scissor. They can cut and they can apply it, and slowly you see red tissue developing over here in about a week to 10 days of time. And slowly you see these smaller wounds, they epithelialize over there. This is a bigger wound, 4-foot amputation being done. Now you need a sheet over here. There's no discharge over there. You don't need any antibiotics to be given to this patient, but I need something. Either I graft this wound, I take a small graft and just apply that. That would be an easy process. But yes, when patients say that my wound is healing, I don't want to go for a graft, then you need to a dressing which can slowly epithelialize to these patients. So UrgoClean AG is a very good sheet for this. We can apply over here. This patient had a small wound on the medial side also. You can cut a small piece and apply that over here. And offloading again is very important, because when the patient walks on this heel, he will have more pressure which is coming on the metatarsal heads or the shafts. This patient has got a mid-metatarsal amputation. So we have to offload this pressure with an AFO or a rocker sole sandal, where the pressure from the heel directly goes in front of the foot over here. If I give him a rocker sole, I'll take the pressure in the 1 or 1.5 inches ahead of this, the 4-foot amputation area. And these type of dressings are very cost effective. This we have already shared. Because of the time, I don't want to get into detail, but yes, Voxil was used. Integra, we can use a dermal matrix to build up on this red tissue, and later on we can graft these wounds like that. And Emcoplast or Voxil was used on this patient. This is again another patient where we have used Integra on the lateral medial side of the foot on the posterior surface, and then leave it for about 2 weeks of time. It takes about 15 days, as Dr. Ganeshwar has just shown you, and we wait for the silicone layer to disintegrate, and then we can remove the silicone layer, and collagen layer is there. Another very dry wound, we can use hydrogel, and then again Purilon on the anterior part of the gel. Both the tissues are dry tissues. You can see dry wounds. So here you have to maintain moisture. When the wound is wet, dry it. If the wound is dry, you have to wet it. Again, two similar wounds over here. Wet wound built with biofilm. You have to get rid of the biofilm. So VAC will be the answer here. If you don't have the VAC, UrgoClean AG, you can use foam sheets. You can use over here, but don't use hydrogel. Here, dry wound, you use hydrogel. Silverlex Heal AG is the best answer here. Use Silver XL, give it to the patient, tell him to do dressing for 15 days. Don't do anything. When he comes back after 15 days, you will find very good granulation tissue formed over. But take care of the glycemic control, offloading, blood circulation. You have to see for perfusion and normal. If the patient comes to me, I will not give any antibiotic to this patient. But here you have to give some antibiotic where there are the cavitatory wounds. Here you see a big fasciotomy has been done on the leg. Biton AG silicone sheet. A long sheet comes where you have to see. It's a long surface area. So you have to see the cost effectiveness of the dressing. If I use small sheets, the cost will increase. So I have to use a sheet which helps in the developing more granulation tissue. I will use Voxil. I will apply Voxil over this area. Now I need a sheet over here, you see. So hydrochloride can be used. And Biton AG silicone absorbs the discharge and leave it for about 2 to 3 days of time. When the patient comes after 3 days, he'll have good granulation tissue formed over here, and later on I can graft this. Look at the graft. A long graft, we have taken 3 layers of the graft, and very nicely the graft has been accepted over here. So you have to build up your wound bed preparation. So you have to think what type of dressing you have to use. Sometimes you have to use 2 or 3 types of different dressings have to be used in these type of patients, and then we will see. Autofluorescence imaging, I have already shared with you, not to get into detail. Now coming to tissue engineered wound care product. This is something in the limelight, new things, and a lot of us, we are using acellular skin substitute, single layer substitute, and bilayered tissues are available as a dermal matrix. Don't want to get into these details. Dermacell. This is one of the very good sheets we have been using. This is human acellular dermal matrix. It is a proven therapy offering complete wound resolution in a single application, now accessible for millions of patients. It's available. This is one of the patient. You can see a posterior surface of the heel being exposed. Granulation tissue is there. Good granulation tissue is here, but the heel is been exposed. So what we'll do, we will slice this layer over the granulation, this layer of the bone, and take dermal matrix, and then we have applied it over the wound area. With the dermal matrix, we have to use a VAC. This is a very good area where you have to use VAC with the dermal matrix and leave it about 15 days of time. You change between after 7 days of time. Check the dermal matrix, and then again we apply over there. I'll show you the subsequent photographs. This is that another patient with a necrotic tissue on the heel area. In fact, when this patient came, we thought of doing a below knee amputation. We debrided this wound, waited for about 10 days of time, and then I thought of applying a dermal matrix on this wound. 2 weeks after the applying of the dermal matrix, this was the granulation tissue we developed over this area. Little part of the bone was exposed. We debrided this, and later on we grafted this wound, and this is again a good granulation tissue. And then secondary graft was applied on this skin. Here you can see. So to bring this patient from this area or from this area, you can see this necrotic tissue. So we use multiple things into this, but for your awareness point of view, that at what stage we use a dermal matrix, and here we have to bring this patient to this area. This patient is totally mobile. Graft has been accepted on the sides, but secondary graft was applied over this area, and now this patient is walking absolutely normally. This is another 4-foot amputation. Lot of necrotic tissue was there. We debrided it, vagged it, and then dermal matrix was applied on this wound. This is what we got at about 2 weeks of time after the application of dermal matrix. This is at about 8 weeks from the initial when the patient came to us. We grafted this patient at this stage, and this is the wound at about 14 to 18 weeks of time. So this is how sometimes we have to mix different modalities, offloading and then taking and grafting this wound. But before grafting, we have to develop the wound bed. So for the development of the wound bed, you can use these dermal matrices like this over these patients, and it works well on this. I'll take you to a small video.
Use and pass. Swell the dermal. Clean the wound with antiseptic. Clean the wound with MS.
This was an ischemic ulcer. We debrided the anterior part of the toe
And circuit MS.
to build up the wound bed preparation. We want to develop the dermal matrix before I can graft this wound. So we applied Dermacell over this area, and then with the sutures we have to close it. The smallest size of the sheet can be taken.
Dress the wound.
But you have to see that you have to leave it for about 2 weeks of time. Sometimes we can go even 21 days, 3 weeks. Let the dermal matrix develop, because that's the best way to save this patient from other the first ray amputation. So we can close these wounds at that area only. So clinical results and studies show that Dermacell AVM is a safe and effective option for meeting the needs of variety of clinical application. It helps in the wound bed preparation, and then later on we can graft these wounds. Smaller wounds, you don't need to graft it also. Also with the collagen sheet or some hydrogels, they will epithelize slowly and slowly, you leave it. But the bigger wounds, you need to graft it. With this, I came to the end of my presentation. Over to Dr. Francine from UK. I'll stop sharing my slides.
Okay.
Yes, Dr. Francine. Yeah, chairpersons, Dr. Amritpal Sodhi.
First of all, good afternoon, dear Suji sir. And it is always a privilege to be with you. And as you are our guru, and we always take delight in being there, and especially on this IPACON. I still remember, sir, our first IPACON, which we held in New Delhi. That was also a wonderful experience. And yeah,
2009.
In 2009. And at that time,
yes,
the foundation was laid for the future conferences. And next time we are just expecting that we all would meet face to face. Francine Smith from UK, I personally welcome you on behalf of IPACON. And she is a community podiatrist from Mercy Care NHS Foundation Trust. The Francine has graduated from the Northern Southampton School of Podiatry in 2019, where she was able to publish an evidence-based paper in Forensic Podiatry. She is a member of the Society of Chiropodists and Podiatrists. She is having National Rheumatoid Arthritis Society membership. I welcome Francine Smith on this beautiful platform, and we all look forward to your participation. And I welcome you as an international faculty also. Over to Francine.
Thank you.
All right, thank you for that lovely introduction. I'm just going to share my screen here. Lovely. Okay. Here we go. So thank you for that lovely introduction. I'll be briefly discussing dressings that are available in our wound care centers today in the UK. We hope that you will implement these dressings in your clinical areas to provide comfort, reduce infections, and also with clinical-based evidence to provide successful outcome for your also patients. We understand that the negative impacts on wounds affect patients' life and their lifestyle. We understand the financial burdens that they place due to the expenses of the dressings. Due to the expense of the dressings, and also due to reduced mobility and pain. This can cause a social effect on patients' life due to their day-to-day activities, and also may cause depression and anxiety. Things to consider when applying dressings. As clinicians, we need to know the mechanism of each dressings when we're applying it. We need to also know the product availability in our area and our expertise. We need to provide comfort and support to accommodate footwear and other orthotics, and also compression bandages. We need to make sure that each dressing is evidence-based, clinical evidence-based, and also cost-friendly. The roles of wound care in dressing are, we consider the approach of dressing and says that it needs to be evidence-based and it needs to be antimicrobial. Each dressing needs to be able to accommodate exudate levels, reduce infection, improve healing time, protect the environment, and also reduce further trauma for the surrounding tissues. There are several different types of dressings, and I'll be discussing a few briefly today. We have foam dressings. Each dressings have a function towards wound healing. Some dressings are foam, such as Telegam. Some dressings are antimicrobial, such as Cutimid Sorbate and Biotin. Some are silver-based, such as Acocel AG, and some which is also hyperfiber. We also have hydrocolor dressings, such as Softpore. We also have dressings that are newly available, such as Ergostar Plus, which promote wound healing. The principles of dressings that we all know, the major important deals we need to do. If it's wet, absorb it. If it's dry, hydrate it. If it has a hole in it, fill it. And if there's necrotic tissue, remove it, by examples of debridement. These are the different dressings I'll be going through briefly today in our presentation. Ergostar Plus is one of the range of dressings that were clinically approved by the NICE guidelines for effective dressings on diabetic foot ulcers, venous leg ulcers, and pressure ulcers across the UK. Ergostar Plus is a wide range of dressings that can be used for patients with reduced mobility and other lifestyle factors that may increase long-term wound healing. They're available in 3 different forms. We have the Plus Pad, Plus Border, and also Ergo Contact. They're recommended for day one complete healing phase, which improve the quality of life for each patient. We will have the mechanism of Ergostar Plus. It helps to stimulate fibroblast and granulation of the tissue. It breaks down biofilm, which we know is important to increase wound healing. It absorbs a high level of exudate and its secretion of maintains of moist wound environment to promote healing. It also have an atraumatic and pain-free removal process. Here, we have a superficial ulcer of the right plantar area. Ergostar Plus was used and reviewed on a weekly basis. We can see that there is pink granulation tissue present, no sign of infection or biofilm. And also we use the dressings to provide continuum cleaning wound for the environment, reducing biofilms and increasing wound healing. Here we have a presentation of, this is not mine, this is taken from Ergostar Silva. Here we have a case study of an 88-year-old woman with type 2 diabetes, hypertension, cardiac issues, and had ongoing stage 4 pressure ulcers on her right Achilles tendon. Ergo Silva was used on this wound, and you can see as the wound size was immensely decreased from day 1 to day 28. The granulation tissue was present, wound margins are severely decreased, and the wound bed is healthier with no necrotic tissue present. The silver dressing was used because it was able to control the level of infection and necrotic tissue present. The silver dressing is an antimicrobial property that has helped to heal to build healthy wound bed and increase granulation tissue. Here we have another dressing, which is biotin AG. Biotin alginate is also widely used in dressings with highly permeable alginate dressings for moderate to heavy exudating wounds. It has a silicone foam adhesive, which is used for absorption of the wound and to protect the skin integrity. It can be used on pressure ulcers, venous ulcers, arterial ulcers, diabetic foot ulcers, traumatic wound, and under compression bandages. We should always remember that biotin should not be used on likely exudating wounds or to control heavy bleeding. Here we have a foam-based dressing, Telegam. Telegam is a foam-based dressing that is semi-permeable, used on chronic wounds and high level of exudating wounds from category 1 to category 2, pressure ulcers. Its silver sulfate dissolves, releasing silver ions on the dressings rapidly over a period of time. The dressing is able to get wet for patients and is mostly recommended for surgical dressings. Here we have another one, which is Acocel AG. It has an absorbent hyperfiber dressing, which is saturated with iron silver, which is good for infection. Its antimicrobial action acts on infected wounds to reduce the risk of infection while managing high exudate levels. You can see it provides an optimum wound healing microenvironment and trapping bacteria, which is also good for wound healing. Here we have a well-known dressing used in India, Cutimed Sorbag, which is a hydrophobic antimicrobial dressing, and it is used to reduce infection and promote a good healing, clean wound bed, which in turn stimulate the healing process in each wound. It's mainly used as a post-operative dressing, but also used for diabetic venous ulcers and pressure ulcers, which generally requires change interval from day 1 to 3 based on wound assessment. Its mechanism of action is sodium ions in wounds, exudate binds to the dressing fiber, resulting in release of silver ions in wound bed. These fibers swells up as locked bacteria and exudate from the wound by vertical wicking. Therefore, the dressing is highly absorbent and very effective on compression bandages. Things to remember as clinicians. Clinicians' knowledge is the key to prevent amputation. The right wound, the right dressing, and the right pathway can enable successful healing. We all want to thank you for this briefly dressing on dressings presentation, and we look forward to see you and hear the feedbacks that you use to implement these dressings within your clinic. Thank you.
Thank you, Francine, for a very nice presentation for dressings. It's a really a lot of delegates will wanted to know about the dressings you are using in UK. So I thank you so much for joining. Over to Dr. Harish, sir.
Thank you, Dr. Suri. I mean, we are coming at the end of this session. So thank you, Dr. Smith, for your valuable information. And I would like to invite Dr. Santosh Murthy for his next talk. Can I have his CV, please?
Yeah. Slide. Can we have a slide changing?
Yes, sir. Yes, sir.
Yeah.
Organizers.
Yes, sir. Yes, sir.
Can we have the CV slide?
Yes, sir.
Yeah.
Is it visible, sir?
No.
Alokji, Dr. Santosh Murthy, slide, please.
Yeah. Okay.
Yes, Dr.
Okay,
Harish.
yeah. Good afternoon, everybody. Let me invite Dr. Santosh Murthy, who's the president of IPA Telangana chapter, Andhra Pradesh. He is a consultant general podiatric and burn surgeon at Navya Multi-Speciality Hospital, Nalagonda, Telangana, and founder of Advanced Wound Healing Clinic. His achievements are: he's an international icon, gold medal awarded by Princess of France at Bangkok, top podiatric surgeon title given to Icon India Business Award at Bangalore, goal to conduct workshop in all districts of Telangana, Andhra Pradesh, and bring awareness about podiatry. So I welcome you, Dr. Santosh from IPACON2021. I hand it over to Dr. Santosh Murthy. It's yours, sir.
Is the recorded video playing?
Yeah. Can you hear us, Dr. Santosh Murthy?
There's a recorded video, so we are playing.
Yeah, sure. So, Dr. Suri, until we get, if there's any comments or anything for Dr. Smith or anybody, please.
Dr. Santosh, you can run your slides. Francine, I have a question. Do you use some type of hydrogels for your neuropathic ulcers, like dry neuropathic ulcers?
The hydrogel that we use, the most ones that we use are, sorry, I'm trying to find out.
Very good afternoon to all the delegates, to all the senior faculty members, to all the viewers who are attending IPACON. I will specially thank Dr. Suri sir for giving me this opportunity on this such a big platform, and I'm very happy to share my cases here and be a part of this very interesting workshop session. So please enjoy this program. Here I am going to show the different kinds of latest dressings. Betadine and hydrogen peroxide has been a trademark for dressings. You go any place in anywhere in the periphery, you will definitely see the dressing has been done with betadine hydrogen peroxide combination wash, followed by a betadine ointment and packing with a gauze bandage. Very rarely, some people use Vaseline gauzes. That's not the way it works. Every problem has to be addressed in a different way. For every problem, there is a different solution. There is no one mantra for all the problems. The wound is actually trying to communicate with us. If we sit and observe, it will tell what it needs to get healed. For example, there is a wound which is highly exudating. So we need an absorbent dressings to reduce the exudate. Similarly, there is a wound which is highly exudating and is also angry red in color, which means there is a lot of inflammation. So a simple absorbent dressing won't work. We need an antibiotic coated absorbent dressings. Then only the inflammation will gradually subside. So that's how we have to analyze what it needs to heal. So we have to sit and talk to the wound. So here I'm going to share some of my cases and different types of dressings like charcoal dressings. We have WAC assisted dressings. We have Exudax. With 3 different cases of necrotizing fasciitis, though the diagnosis is same, but the approach towards dressings will be different from each other. So you can see the first case, all the dead necrotic tissue has been excised, and after excising I'll be packing this wound with normal saline and an antibiotic with gauze pad dressings. Though looks a bit age old, but I still prefer doing this because I get satisfied and I get satisfactory results with it. So I'm not using anything betadine or any other thing. Now you can see there is on the first post-operative day, there is no signs of cellulitis, there is no signs of infection spreading, and the dead tissue is completely dried up, but it is tightly stuck to the base of the healthy tissue. So here I'm going to use a product called Purilon from Coloplast, and I'm a really big fan of this product. Once I apply this product and do a little bit massaging for over 2 to 5 minutes, then automatically the dead necrotic tissue gets separated from the healthy tissue. Just see how easily I'm able to pass my scissors into it and completely separate it from the base. Generally, what we do is we need anesthesia, and we also find a lot of blood loss while excising this dead necrotic tissue or the dried up tissue from the healthy skin, healthy base. It becomes very easy, and now you can see, other than the fascia, all the dead tissue has been completely removed in one sitting. Now this wound is fit for grafting, but before that I'll go for a WAC. After WAC, the grafting will be done. So this is my second case of a 90 years old male. He also present with necrotizing fasciitis, but here this is completely spreading. The surrounding skin looks edematous and looks, even after debridement, looks very infectious. So I'll be packing with normal saline dressings, but on the first post-op day, my approach will be different. Here I'm going to use Acticoat. Acticoat dressings can be used, and we can use silver based foam dressings, but here I am showing Acticoat. There's a preference from surgeon to surgeon, so here I prefer Acticoat, and I'll be applying Acticoat on this wound. So before applying Acticoat, the Acticoat has to be made wet, and now slowly I'll be removing the dressing post-operative, which was done with saline. This man is also complaining of little bit of pain. Acticoats are also available in different sizes. So this is the larger size. Once I apply the Acticoat, I'll be trimming down the edges so that it fits exactly to the wound side. Now I'll pack it with gauze pad dressings, and also put a compression bandage over it to reduce the edema. On third day, you can see beautifully healed wound without any signs of infection or inflammation. Now plan for VAC. My third necrotizing fasciitis case presented in the ER, and emergency incisions were given so that it doesn't flare up. Now you can see I'm excising all the dead tissue under anesthesia, and after debridement I'll excise all the slough which is stuck over the base. After removing slough, you see there is no much edema in the surrounding skin, though the wound looks like going to be a lot of exudate in the post-operative period. For that is the reason I am applying silver impregnated charcoal dressings. Apply a transparent dressing over it and support it with a compression bandage in order to prevent pedal edema. And on third post-op day only, I'll be opening the wound, and you see it's clear that the charcoal dressing looks wet. That means it would have absorbed all the exudate. Transparent dressings will help us know how the wound might be inside. Just remove the compression bandage, see if you are in doubt, and pack it again. The wound now looks much dried up after removing the charcoal dressing, and the signs of infection are less. A little bit of slough is there, so I'll do a sloughectomy. After sloughectomy,
it is almost life-threatening and it needs immediate intervention. Immediate intervention in terms of antibiotics, fluid.
Thank you.
And sometimes you may need debridement and supplements.
Thank you, Dr. Murthy, for a nice presentation on dressings. Yes, we have to have these innovative ideas how to do these dressings. Chairpersons, Dr. Harish and Dr. Imtiaz, if there's any questions or you have any comments on this dressings part, because Dr. Amritpal Sodhi, what type of dressings you use?
So in my settings, we use all kind of dressing depending upon the patient's affordability. And most of the time, as we have discussing here, I use alginate and hydrogels the most. Hydrogel is one of my favorite, but at the same time, hydrophilic blue we are using in the indoor settings.
Yes.
And one of my queries is, in the patients who are having ischemic foot wounds, what are your experience with the wet dressings?
With the wet dressings?
Dressings with the ischemic foot wounds.
See, if they are, if you get a CT angiography, or even if you have not got the CT angiography, is ABI index is in the range of 0.8, 0.9, you can apply very nicely. You can apply VAC dressings. It will help you. But if the ABI index is too less, something like 0.6 or 0.7, then I think you have to first go in for a perfusion or do a debridement, get rid of that necrotic dead tissue. Do not apply VAC on the necrotic tissue because it will not help us anything. So do the debridement, go to the bleeder points, and then wait for a day, and next day you can apply VAC, and it will help you along with antiplatelets. And now yesterday you see a very presentation with Dr. Rivoxabarin with aspirin with salestazole, so you can put these patients on that. So VAC dressings will help that. If your ABI index is too less, there's no perfusion coming, then VAC will not help on that those severe ischemic wounds.
Okay. So one of the patients at right now I'm having is having gas. Now it is just gas under the wound. It is not exactly the gangrene. The patient is having good wound and he's responding well to the antibiotics. Septicemia is around 40,000 TLC now coming down to 20,000. But everywhere it is a capitis is palpated.
Yes.
What we can do in these kind of patients?
Open, do fasciotomy, do extensive debridement. Extensive debridement, open that gas pockets over there. So that will, otherwise they will keep on spreading in the subcutaneous tissue. Most of these are anaerobic infections. So they will keep on spreading inside in the pocket. So give them a good local anesthesia and debride it properly. Do a long fasciotomy and wash it with normal saline. Usol, you can use that. Take gauze pieces, mix with Usol and put them inside for 1 or 2 dressing days. Voxil is very good for these type of gas under the wound dressings, because TLC is also very high only because of that only. So once you open it up, within 1 or 2 days, your TLC will immediately decrease down. And then in those bigger wounds, VAC will help very well. VAC will be very effective in that.
Thank you so much,
So
sir.
I think we have to, thank you so much. We'll close this session because we are getting half an hour late. We have 2 more workshops and then poster presentation. We have very nice poster presentation. More than 35 posters have been accepted in this. So thank you, my co-speakers, Dr. Francine from UK. Thank you so much for joining here. All the Indian delegates have learned a lot by your knowledge of what type of dressing. It's an eye-opener that similar type of dressings we are also using in our Indian patients. These are all international companies, Convatec, Coloplast, Tegaderm. These are all available here. So it emphasizes us that what type of dressings we are also using. Thank you, Santosh Murthy. You have a very innovative representation of how to do dressings over here. And all the delegates and chairperson, I thank you so much to the chairpersons and the moderators for this session. Thank you so much.
Thank you, sir. Thank you.
Dr. Shristi.
Thank you to all the moderators, chairpersons, and speakers of this session. I would like to move on to workshop 3. From learning the names of bones to fixing them, from every ew to every woe, from everything it's stinky to I'm used to it. I'm buying the first lab coat we ever had to owning the lab coat with your name written on it. Life became glorious and a graceful thing. Moving on to the aesthetics of podiatry, I welcome on stage Dr. Ajay Tiwari sir. Sir is a director and consultant diabetologist at Jai Clinic and Diabetes Care Center, Lucknow. Sir is IASO certified with diabetes for obesity management. Sir is awarded with Diabetes India Award for initiative to spread diabetes awareness. To introduce you is my honor, sir. I welcome you and I plead you to kindly introduce the chairpersons for the workshop.
Thank you, Srishti. And at the onset, I would like to thank Dr. APS Suri for organizing such a beautiful conference and very interesting concept, that is the cosmetic podiatry. So this is something I think which throughout the workshop you are looking forward for this, because this is something which is very new concept and it brings about beauty in the field. So to chair the session, we have got 3 eminent faculty. Dr. Anil Kumar Verma. So he's running his own hospital since 2012 in the name and style of Ashadeep Hospital. So that's an orthopedic setup. And he has worked as a senior orthopedic specialist for 27 years in the state government. And he has 2 years of experience as a senior orthopedician at Al Jofra, Libya. Apart from traumatic ulcers, he has been dealing with diabetic and other non-healing ulcers. So a warm welcome, Dr. Anil Kumar Verma. The second chairperson is Dr. Purapati Ramesh, and he is a senior consultant general and laparoscopic surgeon at Warangal, Telangana, and is founder of Purapati Hospital, Warangal, and is a founder member and consultant surgeon at Max Care Hospital, Warangal. So he has got over 18 years of experience, conducted many CMEs, conferences from ASI, keen interest to bring awareness and develop diabetic foot management in peripherals, and is an executive board member of IPA TS AP chapter. So, and the third eminent chairperson is Dr. Anurag Chitranshi, and he is a consultant plastic and reconstructive surgeon at Kukatpalli, Hyderabad, and he has over 15 years of experience, many publications in journals, and is editor of the IGOM DAS, and is a keen interest in academics, moderator and speaker in many conferences. So warm welcome, Dr. Anurag Chitranshi. And now I hand over the session to the eminent chairpersons for further programs.
slide, please.
Hello.
Yes, sir, you're audible.
The first speaker today is our well-known, the founder of this group, Dr. APS Suri. We all know he is a good podiatry surgeon. He is president of India Podiatry Association, member of American Podiatry Association, diabetic foot care specialist, podiatry, Harvard University, USA, Temperate University, USA, and director of Diabetic Foot Care Center, Narayana Vihar, New Delhi. We all have been hearing you, sir, since yesterday. So now you are welcome for your lecture.
Thank you, sir. Thank you, sir, for the nice words. I'll share my slides on the screen. The topic given to me is cosmetic podiatry. If you look at this branch of podiatry, this is not very new. It's since a long time, but very few centers in the whole world are working in this. There's one center in UK and about 4 to 5 centers in US where they are working with this cosmetic podiatry. If you look at dead skin, a lot of patients had calluses on the plantar surface of the foot, on the medial arch where the shoe bites are there, on the interphalangeal joints over here, or metatarsal phalangeal joints, at the site of the 5th MTP joint, at the side of the 5th interphalangeal joint, mainly in ladies. So the best course is wherever you see the calluses, and these ladies, they go to the pedicure centers regularly to debride these calluses. But if a patient is diabetic, we have to take care that we as a doctors should discourage them to go for pedicure as such and go to the medical centers or doctors where you can debride this callus. This is a 15 number blade, scalpel. You can put a number 15 blade and just debride these callus slowly. You see some bleeding points over here, not a big wound over here, but give them a moisturizing cream and a soft padded soles. If the callus is there on the periphery of the wounds, there we have to advise them to get into broader shoes, not get into the pointed footwear where the friction will be there. So we have to take care of the frictions in these areas. Onychogryphotic nails, many times, very rarely we see this, but onychomycosis is very common, where I'll be sharing one slide how to take care of onychomycosis, and Gurleen after me will also share some slides to look into this. So you need to have a clipper and debride these nails, give them an topical application of antifungal, take care of the skin over here. So these cosmetic care we have to take care, and this is all fungal infections in the nail because these patients are not able to take care of them. So this is a nail clipper. With the nail clipper, you see how nicely we have debrided this. There's no abscess cavity, no drainage, no discharge over here. Take care of the skin in these areas, and that will take care of the we can also give these topical antifungal solutions are available. Oral antifungals usually I don't give for onychomycosis. Looking at some geriatric groups or old patients are there. Even looking at the cosmetic podiatry, these are the hammer toes or claw toes. These patients have converted into these hammer toes. You can see these interdigital spaces. So footwear care is very important. We have to give them some moisturizing cream so that these patients, if these diabetic, geriatric group, or rheumatoid arthritis, sometimes blistering can occur at the interphalangeal joint, and they can land up with a problem into this. A lot of patients have diabetic dermopathy, very common in diabetic patients. There are pigmented areas over this area. So we have to take care of the sugars, because sugar is the main, and then pigmentation has occurred. Aloe vera, lecithin, and these type of ointments are very common in patients. And usually it is asymptomatic. They don't have any itching over these areas, and patients usually present with microangiopathy. So we should devise these patients for going for an ABI index and look at the peripheral angiopathy if they have that, or sometimes it's only the microangiopathy which occurs into this pigmentation area. Diabetic dermopathy. This is very common with high HbA1c level. Sugar control, giving them stockings, giving them pigmentation ointments is very common. We can give these to this patient. Usually we don't need any treatment for this, and only cosmetic lesions are there, where over the period of time these lesions or these marks will go away into this. Here you can see onychomycosis. Many patients, they have pigmentation on the nails, and they have ingrowing nails on the side of this. So we have Dremel. This is a very small instrument. It's of course a Dremel with a buffer, and we can just clean these nails. If you go on the previous, if I go back to the previous, look at the status of the nail here. After cleaning, this nails looks very good. With the Dremel, we can clean this all the fungal elements on the base, on the layers of the nail, cut them straight, and with a curate, with a small curate is there where we can clean it. This is a Dremel, and different type of attachments are available. These are easily available online. Also, you can get it from the proprietary shops. Not available here, but Amazon can have that. And with this Dremel, you can do very well cleaning of the nails and the filing. I can show you one video on this. Let me go back.
Check the infected nail of the patient. Fungal layers are removed slowly.
You need to have a good cover for your staff, the mask, gloves, mask and shield, face shield.
And the dark portion is the fungal tissue. So all onychomycosis and these fungal elements, this is very common in cosmetic surgery. You have to get rid of this. So for the beautification of the nail, either we can use laser therapy, but laser therapy is a long treatment. You need multiple settings for that. So you can use that, but this Dremel, this is a very handy instrument. You can keep it in your clinic. If you see a treatment, use them also. Removing the nail plate. Here also you see this side. I have another thing, very easily I can remove this and I can put in a buffer. I have another equipment for working on this.
Sometimes multiple settings are needed for this.
Lots of young girls have been suffering from this nail fungus, making it difficult for them to use open slippers as it doesn't look good aesthetically. We also carry out laser procedures, but it's costly and usually requires multiple sessions. Therefore, we prefer Dremel method. Podiatric care for onychomycosis is must.
Lot of time we see patients with having dry skins and cracks, maybe for diabetics and non-diabetics also. Urea, lecithin, and hydroferin based foot creams are available. And you can see within 2 weeks of time, the texture of the skin has been changed. And these are the massage the staff can do this, apply these creams, or patients can do themselves. And you can see the texture of the skin. This care is very important for diabetics, because this crack, what you are seeing over here, is very important, that this can lead to a major infection and major abscess and then a wound developed over there. So taking care of dry skin, whether it's for the cosmetic reason or non-cosmetic reason, diabetic patient, you have to be very, very careful in this. Lot of time we have telangiectasias. This is also one of the diseases where patient comes to the cosmetic clinic a lot of time. Telangiectasias and varicose veins are present in about 33% of adult women and 15% of the adult men. They may be of cosmetic concern, but superficial varices often cause significant problem. Patients have pain, aching, heaviness, the pruritus. They feel, even if they are after a little bit walking, they feel heaviness in the legs because the venous pressure is more and venous insufficiency occurs. So this is could be a medical reason. So what we expect from sclerotherapy is that disappearance of telangiectasias without any patches, pigmentation or necrosis. This is very important, that it should not spread to the subcutaneous tissue when we are using a scleroring agent. In best results are that we should see at it should not be used on the infection side, and what type of sclerosing product we is using, and a very small volume we have to inject into this. What sclerotherapy does is that it closes the ectasia, telangiectasia, and step by step worsens the venous status in the cellulite tissue. That is very important, that venous spread is decreased. The draining the volume of a superficial tissue is limited by the compression, and new drainage will develop where resistance to the flow is lower. So what will happen is that you have to apply compression. Always try to give compression stocking when we are doing sclerotherapy. I'll show you how we are doing it. How the injection is given, but compression is applied where these vessels, they get sclerosed, they are closed, and the venous blood it makes another channels to go through. So we take a very small needle, 26 gauge needle. This is the scleroring agent which is injected. You can stretch the skin, and then we can just inject about 0.1 ml only at multiple places. You can see I'm injecting here, we are injecting here, and at multiple places we can inject this closing agent inside the vein. So this is the photograph before the veins. A lot of ladies, they come, because not much in our country, but in foreign countries where skirts are very common. So female ladies, they have this difficulty or a cosmetic reason. So pre-sclerotherapy, you can see this, and this is post-sclerotherapy, post 5 months, the lesions goes away. So this is one of the therapies where you can give this scleroring agent, and with the compression stockings can be given to these ladies, and over a period of time, they usually go away. So these are something very, very common in cosmetic hair podiatry. You stretch the skin, and then you can give this scleroting agent inside the vein. They are very feeble, very small veins, so you have to inject it. A lot of time patient also complain for pigmentation of the skin over here. So moisturizing cream and stockings are the best answer for this. For some exercises, patient has to do some exercises. Walking is best for them, and then over a period of time you can see the decreasing of this pigmentation occurs in this. Another very common for cosmetic podiatry is a fat pad tissue. A lot of ladies who are wearing high heels, dorsal fat atrophy occurs. Foot contouring is very common for cosmetic reasons. Cushioning for the callus area. A lot of time in diabetics, reoccurrence occurs over there. So we can do fat pad restoration for relieving the areas under the callus area. And also this is very common for medical tourism, because a lot of medical tourism is occurring for fat pad restoration. What is fat pad atrophy? Is an acute or chronic inflammation of the infrapatellar fat pad. This syndrome is first reported by Albert Hoffa in 1904. So fat pad atrophy is where the layer of the fat that lies under the heel bone, mainly under the heel bone or metatarsal heads. These are the two areas where most of the body weight occurs. Now the patient has got a very high body weight. When he is walking and his footwear is not very proper, or he doesn't have cushioning effect or retainability in his sole, over a period of time he can develop fat pad atrophy on the heel area or under the metatarsal heads, and then that patient complains of pain. So what is fat pad restoration we do? This is off-label dermal fillers, allografts, and autologous fat transfer to improve and increase the thickness of the subdermal or subcutaneous tissue. So what we are trying to do with the fat pad restoration is that we can either take autologous, we can do the fat transfer from the same patient, and we can inject that in between the subcutaneous tissue, mainly on the heel area or under the metatarsal heads of that, to increase the thickness of this subcutaneous layer. It is performed to provide a treatment for soft tissue augmentation in feet where the atrophy or high pressure is occurring. very common for diabetic patient because the pressure is very high. So their recurrence of the ulcers can occur. And also we have done MRI studies and seen that over the period of time when the diabetic patient is walking, say patient has got diabetes for 10 years of time. So when they are walking, as the pressure comes, as the foot comes on the metatarsal heads, there's an anterior deviation of the fat pad tissue. So it anteriorly deviates from the metatarsal heads. So you can do fat pad restoration in these patients, and that is a very easy technique we can show you. Usually, fat pad atrophy, it's a atlastic adipose tissue, covers the plantar aspect of the calcaneus bone. Over here, a lot of fat is available. Due to the risk factor and advancing age, it degenerates and gets atrophied. There's a loss of shock absorbing capacity, and a lot of patients, they feel the pain under, as I said, under the heel area, where the posterior calculus of the heel is there, or under the metatarsal heads. This is where, because of the pressure continuously, the fat pad atrophy occurs, and patient presents like this, the total collapse of the fat pad tissue is there. Even we can do ultrasound and see that pre-injection, if we see how much is a fat pad tissue, and post-injection, if we see about 6 months down the line, there's an increase of the fat pad tissue. So ultrasound is the best imaging technique for after the fat pad restoration. Cosmetic reasons, we can do fat pad restoration injections under the heel area, as I said, metatarsal heads, just under the tubercle over here on the posterior inferior part of the this Achilles tendon is very common. I'll show you one of the photographs because of the high heels. Now, a lot of patients with the hallux valgus, bunions like this, geriatric group, you see the bone is totally exposed. Just there's a layer of skin over here. There's no fat tissue. Interdistal spaces in diabetic patient because of the friction. So these are the most common area. You just have to inject 2 to 3 ml of the fat pad, and then it spreads over that area, and this could be one of that areas. Fat pad atrophy is very common in these ladies. You can see their total fat pad atrophy. So fat pad restriction has occurred post injection, and this is 6 months down the line. You can see a good contour of the foot occurs in these ladies. So fat pad restriction is also very common for cosmetic reasons. Under the heel area is common, and then in the subcutaneous tissue under the bones, you can do the fat pad transfer from the autologous area. You can take it from the flanks, from the cosmetic, or from the buttock region, and that can be injected from the lateral side or from the medial side of the foot under the metatarsal heads in the subcutaneous tissue. Mainly, we use dermal fillers can also be used. Dermal fillers can also be used in the cutaneous heel area, or subsequently, as I said, over the metatarsal pads. It is also great for eradicating painful corns and calluses. A lot of patients, they have painful corns. Even after the debridement of the corns, they say that they feel the pain because the fat pad tissue is negligent over here there because of the friction between the corn and the bony prominences, mainly under the first MTP joint or the fifth MTP joint. So there, dermal fillers can be given. Mainly, it is the injection of hyaluronic acid fillers are available in our country. Also, they are available. This is one of the very best one, Liniva, and you can take Liniva, inject something around 2 to 3 ml from the lateral side or from the medial side subcutaneously into this area, and this area is totally filled up. This is again, you can see in a diabetic patient, there's total fat pad atrophy. Now this patient, when she's walking, she has a great, you can see the inflammation because of the friction between her bones and the footwear she's walking. So fat pad restoration or fat pad transfer is the best way, or we can use dermal fillers also in this area. We can give the injection of Liniva in this area. Sometimes we also use liquid silicone also, but for a very small space, it can be used on the interphalangeal joints, on the corns and calluses. Hyaluronic acid is naturally produced in the body. It is present in connective tissue and also in neural tissues. 50% is available in our skin also. As we age, hyaluronic acid deplete, and therefore wrinkles, they occur. So a lot of cosmetic clinics or dermatologists, they use hyaluronic acid for this injection. Physicians, they perform 2.3 million filler procedures in US every year. And for this, 78% of the time, hyaluronic acid based injections are being used. Some also use calcium hydroxyapatite cellulose fillers. and remaining about 11% of them, they also use poly-L-lactic acid is also used, but not in diabetic patients. Very effective or very safe is hyaluronic acid fillers for diabetic patients if your patient is diabetic. Procedure is you see where the your cushioning area where you have to inject, then take a number 26 gauge gauze needle. Insulin needles are very effective. This can be given as a dermal filler injection, which can be given from the lateral side or from the plantar surface over the area where you have to inject it under the 5th metatarsal, 4th metatarsal, or where the corn is there. In the subcutaneous tissue, we can inject it. The podiatrist or the user should have an expert knowledge of the foot anatomy to ensure the safe delivery. Sometimes hydroxyapatite injections are also given. Now this patient has got a digital ulcer at the interphalangeal joint. So you can debride this ulcer, wait for the ulcer to close down. And when your ulcer heals, because you have to prevent this for re-ulceration. So after the closure of the ulcer, you can inject it, this filler, which gives a scaffold over the lost tissue, because now the tissue has been lost because of the debridement and then the granulation tissue which has formed. And then you can do the radiograph, X-ray, and this hydroxyapatite is visible on the X-ray also. Sometimes we have to give it on the lateral side between the interphalangeal joint, but this is very common area where the corns occur. So you debride the corn, wait for something healing to occur, and then you can inject it at the metatarsal phalangeal joint at the 5th toe or interphalangeal joint at the 5th toe. Here you can see hydroxyapatite injection, which is visible, or radiograph. We can do an X-ray and then you can see. Usually when we inject that, usually it migrates, it spread to the whole area. Over that area, you can put a band for 2 or 3 days and then leave it over there. And 6 weeks post injection, you see the whole area becomes very soft and cushioned in this area, and then friction usually goes away. 5th MTP joint, 1st MTP joint, interphalangeal joint, these are the very common areas where we can inject them. This is again very common in patients who are wearing sandals or tight shoes. Friction usually occurs on the Achilles tendon posterior because we don't have much fat pad tissue here. So we can take fat pad transfer can be done over this area. And these are very common places where we have to take care of our diabetic patients, and this can be done. But when you are using these fillers on the plantar surface of the foot, you have to be very careful with the offloading, because offloading has to be done. Wherever you temporarily offloading for 3-4 days, you can apply these rings like this. You can apply then U pads, so that when the patient is mobile, the pressure goes on these filler sheets. These are called filler sheets. U pads are available. Sometimes we can apply bands like this and debride this, and then we can apply and give them an offloading shoe also. Fat pad restoration, where we can take the fat tissues, it has been separated out, thickened out, and then with a needle, you can see here, we can inject them in the subcutaneous tissue, take the number 26 or number 28 gauze needle, and then you can inject it on the lateral side of the foot, on the plantar surface of the foot, whichever area we feel that the pressure of the foot is more, and this could be one of the very good techniques where do that. Once the filler has been injected, it will soon become fixed. Hyaluronic acid attracts water molecules. It absorbs the solution over there, and then it solidifies over the period of time. And offloading padding should be also given if you are using that on the plantar surface. Videos which after Dr. Manju Mittal will share. So urodermal filler in productive practice is becoming more popular. Patients and doctors, they seek out less invasive treatment for foot pain. A lot of patients, they have pain because if they have neuropathy, they will not feel pain. But non-diabetic patients, they have a lot of pain because of the corns, calluses, intractable plantar keratosis, and ulcer prevention. Prevention of
Sir has got disconnected.
Continue with the next one.
So hello, it's Manju Mittal. Is it okay for me to continue and share my slides?
Just a quick introduction. So this is Manju Mittal from UK. She is currently a senior lecturer in the University of Northampton and has graduated from Northampton University as well in 1994. She is the fellow of Higher Academic Institute, and Manju is currently undertaking her PhD in the juvenile hallux valgus and children's bunion. She's looking at both advancing anthropometric 3D technology to measure the conditions, as well as a new innovative design for conservative treatment. She is also the member of the Society of Chiropodists and Podiatrists UK and the member of the Health and Care Professions. It is an honor for us to have you on this platform today to present on the Swift technology for Verruca. We are really looking forward to this for your presentation. And yes, you may start soon. Thank you.
Thank you for that lovely introduction, Gerline. Let's go on to the presentation and share. Okay, so I would like to mention Swift and present that today. It's a relatively new design, innovative design of treatment for verrucas, so for the human papillomavirus. It was first designed around 6 years ago in Scotland. That's where it was first developed. And subsequently, we've undertaken quite a bit of research, and we continue to do so. It's relatively new, looking at how effective it is for recalcitrant cutaneous warts. So one study that was undertaken by my colleague back in 2017 at the University of Southampton looked at 32 participants who between them had 52 recalcitrant viral cutaneous warts. The results were impressive, 75.9% resolution compared to caustic and cryotherapy treatments that we commonly use, which really show an outcome or a clearance rate of around 23 to 33%, so significantly higher. The beauty of this treatment is that it takes seconds to administer, and it's very precise, and it's very easy to use. Okay, so if I go on to, this little video was given to me by the company themselves, and it just outlines how Swift works. So if I just present that. So as you can see, the treatment is very easy to administer. If I show you this little clip here that I took in my private practice, it just shows how quickly it can be administered. What we normally do is we apply 3 to 5 2 to 3 second applications. It doesn't normally require a local anaesthetic. If patients do find it uncomfortable, it is something that we can do. Now, how is it that this treatment is so effective? And what we're finding, looking at the pathophysiology of it, is that it actually encourages the immune response towards the HPV virus. So what it does, it activates T cells and CD8 cells. It also induces the HSP70, which we have found through other research to be a critical pathway for the resolution of cutaneous warts. So again, this was given to me by the company. I do have some case studies I'd like to present hereafter as well. But what it normally involves is no more than 3 applications, and they are administered 4 weeks apart. We find sometimes, even without resolution at 12 weeks, we will definitively have resolution at 16 weeks, because the immune response is still innervated and continues to work. So we can see with these 3 case studies how effective the treatment is. Now, with the application of SWIFT, we always try, prior to using SWIFT, caustic therapy or cryotherapy. So it's not normally our first line of treatment that we try. And it's when we're unable to resolve the lesion that we recommend SWIFT thereafter. What we do find with SWIFT, there's not damage to the epidermal layer as there are or can be with caustic therapy and cryotherapy. Now, there are some contraindications, and there are patients where we can't use this. And it's those who have had surgery previously, have any replacements, metal, pacemaker. Now, we've got neuropathy and poor peripheral circulation. I do use SWIFT on diabetic patients, but I do check that their vascular and neurological status is good before administering SWIFT. Contraindications here is also immunosuppressed patients. Obviously, it activates and initiates an immune response. However, I have found a way around this, which I'll discuss in a moment. Pregnancy and breastfeeding, it's a time when we know that verrucas can spread as the immune response is reduced, and therefore it's normally administered after this period. Patients who have a very low pain threshold, again, an option of a local anaesthetic or a block is given. Young children, I won't use this under children of the age of 10. So, one case I'd like to present is an immunocompromised patient that presented. What I have done with excellent resolve is actually used imiquimod, otherwise known as Aldara. It is used for superficial basal cell carcinomas, and it's licensed for precancerous lesions. So if it is painful and if prescribed by a consultant in the UK, we're able to administer this for plantar warts. So what it does is it's actually a response modifier, and it induces interleukins 1, 6, and 8 predominantly, and initiates an immune response in those who are immunocompromised. So in this particular case study, it was a 39-year-old male who has a medical history of thrombocytopenia caused by lupus. So he had had numerous treatments, cryotherapy, he'd had salicylic acid applications, he'd had dry needling used without success. Now, this patient's lesion presented under the second metatarsal phalangeal joint, and the patient had complained of significant pain. So what we decided to do was to use SWIFT therapy and combine it with imiquimod. So he had 2 SWIFT therapies done 4 weeks apart, and then we prescribed imiquimod 5% to be applied 3 times a week on non-consecutive days with a nice occlusion placed over it. And we then we did one last treatment of Swift, and 10 weeks applications of Aldara showed a complete resolution. Yeah. So what we are finding is that patients are presenting to us in private practice predominantly. Here in the UK, in the NHS, verrucas are not treated. Plantar warts, they will not even acknowledge. So we're seeing more and more of these patients presenting to us in podiatric practice. It's not only because of pain. A lot of it is young women presenting, and it's cosmetic reasons that they want the lesions removed. So Swift, we're finding, is absolutely fantastic with excellent resolve. We will be undertaking a more long-term study at the University of Northampton looking at its effectiveness. But so far, very good. We're also going to be looking at using it for other lesions once that study has been completed. Okay, thank you.
Thank you so much for the wonderful presentation. Swift has been a new technology that we all have been using. I do use it in my clinic as well for verruca. And recently I was reading an article and it said that there was 1,000 patients that were as a caseload, and the Swift was used on them. And out of the 1,000, it showed 83% of success rate if given in 4 weeks, 4 weeks of interval time, which was amazing. But I have a question for you, if it's okay. What is the return of reoccurrence? Is it do you see any reoccurrence, or is the verruca always completely gone? What sorts of?
So with the paper that was done in 2017, so I followed up those case studies, and there were 2 participants where it had returned. But there was a significant change in their medical history and had become immunocompromised. So it was only during that phase that they had a reoccurrence. But generally, because it initiates an immune response and antibodies, which pretty much are there unless there is another systemic cause, the resolve is very good and reoccurrence very, very low. The new study that's been done, we're still awaiting results. So we will follow it up prospectively in years to come to see what reoccurrence is.
Oh, that is great. Another question, if a patient comes into your clinic with, let's say he or she has had salicylic treatment and the skin surrounding the verruca is quite fragile, would you be willing to do Swift therapy on them, or would you wait for the skin to heal and then continue with it? Does it have any contraindications?
It does, and it can just be painful at that point. So what we would normally do is just leave that lesion to resolve and settle down for 2 to 3 weeks, and then we would apply Swift.
Oh, lovely. That's great. Yeah. Okay, thank you so much for this informative presentation. Thank you.
Excellent.
All right. So moving on. Lovely.
Good afternoon, everyone, and let's go on to our next speaker. Our next speaker is Dr. Gurleen Suri. She's a practicing pediatrician from Liverpool, NHS, UK. She has done podiatry and from the University of Northampton, UK, and she's a registered practitioner with Health and Care Professional Council. She's a member of the Royal College of Podiatry, UK, and of the National Rheumatoid Arthritis Society. She specializes in wound care, biomechanics, and offloading techniques in diabetic foot. And she's currently working on an article on the specificity and accuracy of smartphone applications to detect malignant melanoma. So over to you, Dr. Gurleen.
Thank you, Mr. Anurag Chitranshi, for this wonderful introduction. So, and I would like to thank the IPA team as well for giving me the opportunity to present in this cosmetic workshop and I feel this virtual conference is a next milestone to reach our goal, which is I prevent amputation. So moving on, today I'll be talking about about a new technology that has come into the market where we're using gel therapy to reconstruct nails. So what is nail reconstruction? Often what happens is I see many patients who say they are embarrassed by their feet. Often this is due to the appearance of their nails. Whilst podiatry treatment ensures the continued health of the feet, it is often not possible to change the appearance of the nails. But this is the new technique that we can use where we reconstruct the nail using a gel. The treatment So the treatment can be used over normal nails to reconstruct the damaged nail and prevent from risk of infection. It can be used for fungal nails in conjunction with either topical or antifungal treatment, and it should help limit the spread of the fungus. Again, this gel therapy is not a treatment for fungal infections, but it will stop the spread of the fungus present. For traumatic nails, a prosthetic nail may help the new nail into growing and minimize the risk of infection, or ingrown nail. Can be used on psoriatic nails, traumatized nails, onychomycotic nails, onychococcic nails with really thick nails. It can be used on diabetic patients and any regrowth present on a TNA nail surgery. The estimated length of time for they're expected to stay on is anywhere between 6 to 8 weeks. But again, this depends on how careful the patient is with the nails and how much time do they spend in water and doing other activities like football, running, dancing, all that sort of stuff. Some patients have reported that the nail has stayed on for 10 weeks and is still going strong. So the procedure for it is if there is a damaged nail present, the nail will be reduced as much as possible, and then the nail will be roughened with the file. The toenail is then cleaned with antiseptic to remove any oils and disinfected. The solution is applied to the nail and the nail plate, which also contains an antifungal property to enhance the bonding of the gel. Then the gel is applied in layers, with each layer hardening with a UV light. This is the video which I would like to present. So where you can see the nail has been cut down, and then we're using a buffer and a file to make sure the surface is quite smooth. We can also use a nail drill to make sure the surface is quite smooth and there are no spikes present on the nail surface itself. Now we are applying the gel on the nail surface itself. So just apply one layer and then we'll use UV light to harden the nail. We can use a cotton swab to make sure any excessive nail and the solution has been removed from the surrounding nail and the apicum. And now we're using UV light to harden the nail plate. So you will keep repeating this process till the nail is quite hard and it is similar to a normal nail. It has the same similar texture. Again, just clean it, and now you can see the before and after presentation of the nail. So next slide, please. Lovely. This is an article that was published recently, which talks about the reconstruction of nail, and it tells how the rate of success is great. The evidence mentions that it is good to excellent improvement in most cases and promotes the reconstruction. Moving on, I would like to show you some examples of the before and after nails. So over here, you can see how you have a TNA regrowth, and we have used the gel technology to form the nail. Then you have an onychococcic nail. And next slide, please. Again, there's a traumatized nail present here. Then we have onychomycotic nails and how we can buffer it and then use the technology to to reconstruct the nails. So there are no present contraindications mentioned. The only thing we need to make sure is that the patient is not allergic to any of the components that we are using in the gel. So always be aware of that. There is no odor or no discoloration present after the resin is hardened under the UV light, and the nail will be completely set and it won't move. Again, this is also related to how active the patient is. If the patient is constantly wearing heels or applying constant trauma, let's say they're playing soccer, football, swimming, these are some of the factors that will reduce the lifespan of the nail. So you need to make sure that the patient is quite aware of the fact. There is no acidic component in the gel that may damage the natural nail plate, so that is a good thing. And the gel is formulated by LED gel suspension technology, which is quite safe. Again, it is a non-porous component, therefore neither moisture nor air can penetrate through the material, and thus it helps with the dealing. And since it's quite elastic, it would help with the movement of the patient's feet, so they won't feel uncomfortable or quite stiff. So with that, I would like to say thank you. And
an excellent talk, Dr. Gulin. One question I have for you. What about the onychogryphotic patients you've shown us? Any particular care for this acrylic replacement of the nail you take so that it does not really, enhance the fungal growth below the resin?
so as I had mentioned, the gel has an antifungal property, so that will help us with the situation. But again, always remember the gel is not a proper treatment for the fungus. So we can use the nail reconstruction to minimize the growth of fungus, but they still have to go on with their topical or systematic treatment, that antifungal creams or any topical medication they are taking for the fungus specifically. And again, since it is a very non-porous layer, so there is no air or water that goes between the nail and the nail plate. So again, that would inhibit the fungus growth as well.
Great.
Thank you.
Wouldn't it be good, Gulin, to clear it with a Dremel or with a before applying the gel? You can clean the fungal layer from the nail bed.
Absolutely. As I showed in the video before, when we start before that, we need to make sure that we have taken down the damaged nail, we have filed it, buffered it, and if we can take out the fungal aspect of the nail out, we try to do that as best as we can and then apply. So always make sure if you're applying the gel, the nail has to be smooth, and you can again use a Dremel to thin down the fungus infection present on the nail.
Yes. There are other surgical modalities in cosmetic podiatries like hammer toes. You can just go on for very simple procedures, which Dr. Jarrod video was there yesterday in the video session on tenotomies. Very superficial tenotomy. You can just make a small nick over here and just with a number 22 or 24 needle, you can click them, or with a number 11 blade. Another are bunions and hallus valgus. They are very common problem in the cosmetic podiatry arena. So that's the other surgical arena where you can do the surgical corrections for bunions is always there. That is one of the things which we have not covered here because of the shortage of time. And any questions, chairpersons, you can take out from the chat box. Few have answered. There's a question that where the filler has to be injected in a painful cone, in the subcutaneous tissue or in the deep tissue. So basically it should be in the deep tissue, just underneath the bone where the interphalangeal joint is there. So you can, from the medial side or lateral side, inject it in the deep tissue, not in the subcutaneous tissue. Dr. Anurag, if there's any other comments you can make, or is there any questions in your chat box?
Nothing as of now from my side, sir, but just as you mentioned, a few more cosmetic procedures like bunion corrections and toe tucks and toe shortening, and even sclerotherapy, which you have mentioned very nicely. So a whole gamut of even surgical procedures we can do. So all in all, very covered all well, very well.
Okay. Thank you so much. Thank you, Dr. Manju, Dr. Gurleen, for sharing the cosmetic podiatry presentations with us for the IPACON delegates. Thank you to all the three chairpersons. Very nicely you have depicted Best, Dr. Anurag, and everyone over there. And thank you so much for this session. Dr. Shishti.
Yes, sir. I thank all the chairpersons and speakers, Dr. Manju Mittal ma'am, Dr. Gurleen Suri ma'am, and Dr. APS Suri sir. Thank you very much. Next, we as medical professionals can't save the world, but the tendency to save the person in front of us makes a major difference. For the next workshop, I would like to call on stage Dr. Manish Kumar Jangam sir. Sir has completed his postgraduate course in advanced cardiology and advanced diabetology from Harvard Medical School, USA. I welcome you, sir. I request you to kindly introduce the chairpersons.
अलग से करके रन करूं.
Sir, please unmute.
Yes, it's my privilege to introduce Dr. Swapnil Garg. He is a professor and head of department of general surgery, Maharaja Agrasen Medical College, Agroha, Hisar. He is a consultant plastic surgeon, Shah Satnamji Specialty Hospital, Sirsa. Next slide, please. Dr. Natalia Klemenko, she is from Ukraine. She is our IPA member. She is dermatovenerologist in KYEV, Ukraine. She has a special interest in dermatology as well as podiatry and dermatology changes in diabetics. Next slide, please. It's my privilege to introduce Dr. Gautam Shah. He is the director and chief orthopedic surgeon, Asta Intensive Care, Dhulia, Maharashtra, since 2004. Orthopedic surgeon and professor of orthopedics with specialization in trauma and Elizarov surgery, polio and deformity correction surgery, and is a chief hyperbaric physician at Asta Intensive Care Center, Dhulia, since 2012 till date. Over to you, chairpersons. I think Dr. Swapnil Garg is busy with some procedure. Dr. Gautam Shah, please introduce Dr. APS Suri sir.
Slides.
Good evening, everybody. It's a great pleasure to be here in this IPACON 2021, and hats off to Dr. Amarpal Suri, who's also a good friend of mine. He is a podiatric surgeon and president of Indian Podiatric Association, member American Podiatry Association, diabetic foot specialty, podiatry Harvard University, USA, Temple University, USA, and also director in Diabetic Foot Care Center, Narayana Vihar, New Delhi. He has got lots of feather in his caps and many more to come, sir. Thank you very much, and kindly start your topic on role of biologics in DFU.
Sir, you are unmuted. You are to mute. Yes.
Thank you, Dr. Shah. I still remember the old days we were together. And I'm sharing my slides. Sudhir, I need your help. Yes, sir. Slides available? Okay. As the topic, stem cell therapy in diabetic wounds. As of date, there are no approved indication for stem cell therapy other than bone marrow transplantation. All cell therapies other than BMT should be considered as clinical trials. If you look at stem cells, they are primitive, undifferentiated cells which can self-renew infinitely and provide cells which differentiate into functional end cell with finite life. If you look at stem cells, they can be taken up by the multiple sources from the blood, from the bone marrow. People have been using for nervous system, in liver transplant, pancreas, kidneys, heart for ischemic cardiomyopathy, skin, muscle, vessels, and bones. If you look at types of stem cell, it's embryonic stem cells and adult stem cells. Both are available to be used. But the main capacity of stem cells do come by the self-renewal of the embryonic stem cells. If you look at diseases for stem cell, when I started stem cells from 2010 onwards. At that time, if you look at, there are multiple reasons, multiple diseases where stem cells can be used. But if you look at critical limb ischemia or ischemic ulcers of the leg and foot in diabetic patient untreated with conventional treatment such as bypass surgery. So it's not that we can take these stem cell, all patients into stem cell therapy. Ischemic heart disease, cardiomyopathy, untreatable conventional treatment such as angioplasty, stents, or bypass surgery. People have been using for spinal cord injuries. We have got very good results in the cirrhosis of liver, autologous immune enhancement therapy for cancer. People have been used, and a lot of other diseases where stem cells can be used. If you look at, go on the Google and see the list of the clinical trials for stem cell therapy for diabetic foot, there will be more than 6,000 papers which have already been presented or published into this area. If you look at the market potential for this technology is huge, and global revenues could be more than 10 to 15 billion US dollars by the end of last year, by 2019, before the epidemic. This was a paper we presented during the middle of the epidemic with Dr. Taranjeet Singh Dhoot in Canada, where we have shown the patients of about 600 patients with platelet-rich plasma. That was a new approach for diabetic foot ulcer wound healing we presented. If you look at sources for stem cell, it's a bone marrow aspirate we can take, which has got us one of the most strongest concentration of stem cells. We have liposuction, also have very high concentration for stem cells. Peripheral bloods, umbilical cord, and allograft is also being used for stem cells. Here we are taking the bone marrow aspiration from the iliac crest. We can take something around 100 to 110, 20 ml of the peripheral blood, which can be put in the processing bag, and it can be in the same sitting. It can be put in the unit, or it can be sent to the stem cell bank for centrifuge. And this is the buffer coat we get it. And this buffer coat we separate out and we inject in the wound, in the peripheral area of the wound. And also it has to be injected in the subcutaneous tissue in both the legs along the anterior tibial artery and the posterior tibial artery. Something loud 20 injections on the medial side and 20 injections on the lateral side has to be injected. Here you can see in this wound, we make a grid, 2 grids on the medial side and 2 grids on the lateral side. What we see in these patients, that when we do that, and we also induce hyperbaric oxygen therapy. This, if you have an assessment to hyperbaric oxygen therapy, this is very nice because 10 to 15 sittings of hyperbaric is given, which along with stem cell therapy induces new angiogenesis. What we are trying to create with this is new angiogenesis in those patients which even after vascular surgery, or even when we send these patients to vascular surgeons, they also can say that nothing can be done as endovascular procedure because it's a distal diffuse disease. In those patients, we can take these patients into stem cells, and that has given us a very good results with CT angiography can be done post at about 2 to 3 months of time. This is one of the patients where stem cells have been given in the leg, something around 50 to 60 injections have been given, and on the peripheral wound, and then sutures were applied to bring in the plantar flap, and no grafting has been done, and see how nicely the wound has healed in this patient. So this is how something we can save. The forefoot amputation has been done, but then below knee amputation can be saved in these patients. Another very interesting techniques in biologics is platelet-rich plasma. Now, since many years, like 4 or 5 years, we have shifted our practice from doing stem cells to platelet-rich plasma. Reason being, it is more cost-effective, and also it is very easy. The patient is in your hospital, in your clinic. You can just take 20 ml of his peripheral blood, put it in these test tubes,
or in the PRP kits with FRFM, we are going to show you, and then we can inject that, the buffer code we get, and that we can inject it. Autologous platelet concentrate, this is the unit, harvest unit for the centrifuge, and this is the PRP which we get, we separate out, and that can be injected subcutaneously. Also, you can take calcium alginate sheet or any silver-based sheet, and we put the leftover part in the sheet and apply that in the wound and fill the cavity and leave it for about 2 to 3 days of time. And slowly within 1 week to 2 weeks of time, we see good granulation tissue which develops on this wound. This is one of the patients where 2 toes have been amputated. We did ultrasonic debridement, we applied VAC, and then we did 2 sittings of PRP was done. And in 30 days of time and then 40 days of time, you can see surface area of the wound closes on its own, and you can see the epithelialization being occurring. No grafting was done on this patient, and later on the wound healed. No grafting was done on this patient. The small graft was applied at about 10 weeks of time and then healed. So you have to take care of the offloading in this patient, because first toe and fifth toe, they are the only ones left over. So we can give them a shoe filler with this, and later on this patient has healed well. Now there's another technique of developing gel, which myself and Dr. Ravi will show you in one of the videos, where we can take 10 ml of the peripheral blood is taken, and this is the calcium acetate citric gels in the test tube. There are 2 units transfer. You can go to the exhibitors and see the stalls over there. You can talk to the exhibitors. They are present in, both the companies are present in this conference. And this is a gel we get. We take 10 ml. Out of them, we get this FRFM gel, and that can be applied on the subcutaneous tissue and leave it for about 4 to 5 days of time. We don't need to change the dressing. And subsequently, we see the epithelialization has occurred, and these gels, they close very quickly. This is again FRFM, PRFM on the wound, necrotic wound on the heel. There's some granulation tissue coming. You have to make sure that there's no infection in the wound. We have to first eradicate the infection. Then this process of these PRFM or platelet-rich plasma occur, and subsequently we see very good results which come, and the wound starts to heal quickly. I'll show you this video. Can you run from there? Yeah. Okay, we go. This. Sorry, we have this technology problem. Another sample list. Leave it. Let me see. Okay, clinical. PRP or stem cells, whatever the biologics we can use, the skin temperature we see significantly increase after the treatment. TCPO2 treatment is increased after the treatment. Rest ABI is also increased. Ulcer incidence is decreased after treatment. Ulcer area reduces because subsequently we see that's the goal of using these biologics, that we can heal this wound area. There's no side effect, and stem cell could be a safe and efficient treatment for diabetic foot ulcers. The goal of regenerative medicine is that we have to treat these patients to replace the damaged cells or the tissues. Tissue and organs are complex structure composed of multiple cell types. So optimal cell therapies will require combination of cells. Sometimes we have to combine these therapies together so that we can have the good results. Stem cells and regenerative medicine, it requires integration of the cell products into the damaged tissue, and this generally requires the proliferating cells. Also requires differentiation into mature functional cells, and that is the goal, that how fibroblast migration or granulation tissue deposition occurs by the functional cells. So we know that this could be a very good perspective in medical science. We need to use these studies, but yes, stem cells can do wonders, but sometimes we have to combine these therapies together so that we can use them. With this, were the slides not visible?
Sir, please share again.
Huh?
They were visible partially, sir. Not all of the slides were visible.
Last part. Okay, I think I had a last part. So no problem. So we can show you some video. Let me go back, and we have 2 other speakers in this. By the time I'll rearrange my video. Technical team can help me. Technical team. Yes. Thank you. Injection we are giving in the peripheral tissue. So small injection, something around 0.5 ml. We keep on injecting in the subcutaneous tissue. This is caltostat sheet, calcium alginate. Leftover part of the PRP, we are putting that on the wound and close it. Thank you technical team for helping us. We have a very strong team working backhand. More than 20 people are working. I'm really proud of them. Thank you so much. We have very nice speakers in this session. Dr. Ravi Chitoria sir, Professor of Regenerative Medicine, Department of Plastic Surgery from Jipmer, Pondicherry. And along with them, we have Dr. Santosh Murthy and Dr. Dinakaran from Chennai, Dr. Santosh Murthy from Telangana. They'll be sharing their videos and session over this. Over to the chairpersons. And we are proud to invite Dr. Natalia Klinmenko from Ukraine. Please unmute yourself, madam. And we are proud to have you here in IPACON. Welcome. She's a dermatologist from working in Ukraine. She has a good interest in regenerative medicine. So we are really happy and thankful to you to joining in IPACON as a chairperson for this session. Thank you, madam.
Thank you very much.
Thank you. Dr. Swapnil, can you introduce Dr. Ravi Chitoria, sir?
Dr. Swapnil is not there. He is in procedure.
Okay, Dr. Manish.
Yes. It's my privilege to introduce Dr. Ravi Chitoria, sir. He is a professor of plastic surgery and head of IT wing and telemedicine department of plastic surgery, We have listened yesterday. It was almost 1 day session for him. It's that much of abundance knowledge he is having. He is working in Jipmer Pondicherry as a head of department of plastic surgery. Over to you, sir.
Thank you, chairpersons and all the faculty and the participants who have registered for this workshop. And I can see there are 9 attendees. So yesterday I have already shown you the 34 different ways of regenerating the wounds. So what I feel is of this 34, it is impossible to show you everything or to demonstrate you everything. Video wise, I have shown you each 34 videos yesterday. So I give this privilege to the participant to ask me which one they want me to show, and I will show you. So I have to share.
You can show 5 or 6, whatever the most commonly you are using.
No, I will.
PRFM would be very nice to show.
I will show you what I have planned. What I have planned for the participants. So the first I would like to show this. This is the our laboratory where the 34 sets of the, and you can see behind with me our resident Dr. Nishad. Nishad, raise your hand. And Dr. Neljo are sitting with me. They are MCH 3-year senior residents who under us are getting training and also practicing this regenerative technology. Now to start with, first I would like to introduce you all the equipments which are commonly used for this technology. So number 1, I would like to show you first the low level laser. This is the low level laser you can see on the screen. And this is the panel which is being shown to you. Then now you show the next equipment. And this is the equipment we use for harvesting the autologous platelet-rich plasma or preparing the platelet-rich fibrin matrix. And number 3. Now I will show you all the equipments one by one, and then at the end of the demonstration of this equipment, you ask me, I will explain you. Also, I will show you video. Actually, I have brought a patient also here. If time permits, we can harvest live here the whatever you will say, and we will do it, provided the time permits by the chairperson to make the attendees understand. So now, for example, I showed you yesterday in my video. So this is a small Silverman graft which we use it. This is a blade, and this we use it to harvest the small pixel grafts. So once yesterday you must have seen the video. This equipment we use it to take a small strip and then we make it pixel graft. And yesterday I showed you as simple as egg. So this is the egg which you can also have it in your practice. And if you want, today we can demonstrate you how this egg is broken and how the membrane is taken out and then made sterile and then used for the as a regeneration for the biological. Then next one is the, yesterday I showed you the hydrojet cannula where the biofilm is broken, and so that automatically the tissue starts showing the regeneration. This is the Jamshidi needle which you have been used in your internship, and this is for taking the autologous bone marrow aspirate. And once we take the bone marrow, I have shown you yesterday in video in anterior iliac spine or using the posterior iliac spine or anterior part of tibia, you can aspirate it and seedle these peripheral cells onto the wound. This is the equipment liposuction, as I showed you, syringe liposuction, where under local anesthesia you can do the harvest the fat, and then the same machine which I showed you for autologous platelet-rich plasma, after centrifugation, you get the lipoaspirate, which is a rich source of stem cell. Then the third procedure I yesterday showed you is the phenytoin tablet, which is the epileptic tablet. And this is the small bowel where we crush these tablets and then we sprinkle over the wound so that the wound starts showing the hypergranulation, the way it causes the gum hyperplasia. And then this equipment, focus this equipment. This equipment is a dermabrasion equipment. So dermabrasion equipment means I showed you, instead of preparing the cultured graft in the laboratory, you can have a non-cultured keratinocyte suspension. So dermabrasion, this is small equipment, handheld equipment. You just rub over the skin and the epidermal cell will come out, and they should not go here and there. So you can always use any antimicrobial like miprocin so that all they get stuck. All the cells get stuck to the ointment, and then you take it and use it for the wound where you want to. So next equipment is insulin. Now insulin is is a insulin derived growth factors as a human ectopid, and if you want I can show you the protocols for protocols. I can share you in my PPT. I will show you. First I will demonstrate the equipment which are commonly used. So insulin is one of the, it can be injected or it can be sprayed over the wound. And then sucralfate, yesterday I showed you in the video, which is easily available. And sucralfate is supposed to be a rich source of ulcer healing, like our peptic ulcer. So this also heals the cutaneous ulcer. And this whatever we are using, they have been discussed in our scientific presentations here in the journals. And then we thought why we should not also start using in India. And then we did our publication. Then the next is as I showed you, this is a human amniotic membrane. So it has been harvested and kept it here. It is kept it in the fridge. You can always take it out and use it. So yesterday, freshly, Nishad had gone to labor room and he has peeled it off. And today we are showing you this is the human. If you want it, I can take it out in this kidney tray and I can show you how it is. First, I will demonstrate you the various equipment. Then, as I told you, prolotherapy is a 25% dextrose, which has a rich property of granulating the tissues. So this also can be spray over the wound whenever you open the wound. And yesterday I talked about the hemoglobin spray. The hemoglobin carries the oxygen. So you can always take a simple blood of the patient and spray it. Usually there is a commercial gun available, hemoglobin spray gun. And when we read that article, then it's a very costly. Basically, you have to spray the hemoglobin. So it should take the environment oxygen and then it goes into the wound. So we did it simple way. You just take any perfume bottle, autoclave it, take a blood 10 ml, 15 ml, 5 ml and spray it over the wound, which I have shown you in the video and we published it. Similarly, I showed you this granules. This is the vitamin D granules, which are rich source of hypergranulation and antimicrobial property. They can be sprinkled over the wound. And then, of course, everybody knows the collagen. I think it is not new, whether it is a wet collagen or collagen granules or dry collagen. They also have the properties of regenerating the wound bed. And then the most important and close to our heart is the scaffolds. So now, as I was telling you, you can use silicone sheet and multiple layers of collagen and then amnion and then non-cultured keratinocyte suspension. So you can make a 4-layer of your own scaffold, suture with the suture material, catgut, and then you apply it on the wound, leave it for 21 days. Same silicone sheet can be meshed, so it becomes a meshed integra. And if you don't small wound, you don't mesh it, it is a simple integra. So this is commercially very costly, but here you can make it your own. Now, next one I showed you yesterday in my video was the blister graft. Means you apply this 50 ml syringe and generate a negative pressure, put a plunger and leave it for a few minutes, and then a bulle will form on the skin. Then you take it out epidermis and make it into a small grafts and put it on the wound. It regenerates the wound because it's a patient's own skin. And the last is the this Humbe's knife, which is very commonly used by all surgeons, plastic surgeons. This is used when a large graft to be required from the dead bodies. Like we are having a license of harvesting from dead bodies, various tissue. We are the first in the country, and the ministry has given the license. So whenever a patient dies, we harvest the patient's skin. So large skin can be taken from large handle. Similarly, the mother, father, relatives, any live allograft you can harvest with this and use it for. Exclusively we use for burns, but diabetic foot is a very small area. Nothing to worry about it. We can always use it. So with this, now I will show you I have shown you all the equipments which we commonly used. Then I will show you the various protocol which we use it, which we have made this kind of a play cards for phenytoin, steps of the APRP. So I will show you in my PPT. Probably that can be given to the participant. Please share my PPT. So after that, if the time permits me, then I will show you the application of laser. We have a laser. I can show you the harvesting of PRFM or video, whichever. So you please go number 1. Next slide. Next slide. Next slide. So these are the steps of preparing the autologous platelet-rich plasma. So those who do not know, they can save it, they can use it. And similarly, if we go to the, this is our study. And yesterday already I have shown you this video. So I don't know whether how many people will feel a repetition, or you want me to repeat those videos again, sir? What the chairperson says?
Maybe
you want me to repeat those videos?
No, sir, because we have 2 more speakers after you in this workshop.
So I think I will.
And there's 1 more workshop after your workshop. So we can devise another program with you, a webinar or something, and then we can do that with the delegates. Yeah.
So with this, I will stop here. I have shown you what all things are possible for regenerating the wound bed.
Yes.
And those who want to ask, the participants who have registered, 8 participants I can see, they have paid for this workshop. I will be very happy if we clarify their doubt and make them use in their practice.
Thank you so much, sir. Thank you so much. A question answers we can take at the end of the session, sir, workshop.
Okay, sir. Over to you then.
Thank you, sir. Thank you so much. And it's a rightly eye-opening, and you have been doing great work in regenerative medicine. That was a thing we wanted IPACON delegates to see your work and appreciate. And we have your students, and all your students have been appreciated well in the poster session. Excellent poster session we just have, sir. It's going on.
I am sorry to say they had four posters, but they were allowed only one poster. And then two of my residents, Shijna and Padma Lakshmi, they are in the emergency reimplantation case going on. They could not even present. So 8 posters, we missed it. So I don't know if later on they can be allowed, because they did a lot of hard work.
No, we can allow them. We can allow them, and there's a certificate for each posters. And actually, I'm not in the jury. We have a separate jury for that and separate team for the posters. So I
wanted Neljo to show the Botox. Botox is a new technology for diabetic foot. So, but he was not allowed. He was given only 1 paper, that was first APRP. APRP, everybody knows. I wanted to him show Botox. I wanted him to show hemoglobin spray. I wanted him to talk on the other technology, which are detailed they will speak.
Okay, let me see to add. All these young students will be, we really encourage them, and we will appreciate that.
If they are not allowed, my request is please go through their poster, and if you feel they are worthy of it, please do consider for their recognitions.
No, we will do that. We will do that. And we are coming up with a newsletter and journal. We'll post in that also. And
I will send the publications of our studies which they are doing it here.
Thank you.
That is the next in GBM we are going to discuss.
Yes, we'll discuss that today evening. Thank you so much. Thank you. And I will invite Dr. KP Dinakaran, President of Chennai chapter, to please share his videos. Because of the time constraint, we have to be a little faster. Both Dr. Dinakaran, and after Dinakaran, we have Dr. Santosh Murthy from Telangana. Please. Dr. Dinakaran is the president of the Chennai chapter of Tamil Nadu chapter of Indian Podiatry Association. He has experience of about 20 years, completed his MD medicine from Moscow. and he is doing a great work on regenerative medicine. Many cases of PRP and PRFM he has done. Dr. Dinakar, please share your slides.
Yeah, very good evening all, and I wish extend warm welcome and thanks to this kind of wonderful and great webinar. Okay, where a mass of experienced doctors and the medical professionals are present, and it is a great pleasure for me to join this workshop and where there are people across the country to share the knowledge. Okay, so I would like to now, as our mentor and Professor APS Suri has already talked lot about the PRP. So the basic things I would like to tell about the PRP is actually a defined portion of plasma fraction of autologous blood having a platelet concentration more than above baseline. For example, the baseline is like 250,000. Platelet rich plasma should be at least 10 lakhs. Okay, then only the concentration is more, then only they can have the benefit. So what is the basic benefit of PRP? If you see, basically the basic PRP function, that platelet rich plasma function as a tissue sealant, okay, and drug delivery system with the platelet initiating wound repair by releasing locally active growth factor. These growth factors aid in healing by attraction undifferentiated cells in the newly formed matrix and triggering the cell divisions. Okay, and PRP also suppress the cytokine release and limit inflammation interacting with macrophages to improve the tissue healing and regeneration. So promote new capillary growth and accelerate epithelialization in chronic.
Very good morning. I am Dr. KP Dinakaran. Today in this workshop, we are going to see how we are going to prepare PRP, platelet rich plasma. First thing is to draw 20 ml of blood from the patients. Using a EDTA tube, take it in a 215 ml centrifuge tube. Now we can start the procedure. Basically, we are using two spin method. First spin will be slow and the second spin will be faster. Okay. Now we will see how to centrifuge the sample. First of all, we will keep the tube in the centrifuge and place it in straight opposite so that it will have the balance on rotation. Okay. This soft spin rotation will be for 5 minutes. So we are setting this for 5 minutes and the gravity will be 300 gravity, that is 1200 to 1500 RPM. Okay. So once this 5 minutes is over, there will be a click sound. So then you can open the centrifuge. If you take the centrifuge tube, we can see two layer separations. Okay. So the upper layer actually is full of platelet containing plasma. Okay. And the lower is RBC and other blood cells. Okay. Now we are going to separate the upper layer without disturbing the RBC. We have separated the upper layer without disturbing the RBC in a new sterile tube using a sterile separating pipette. Okay. Then we should centrifuge the second spin, that is hot spin, which will be for 10 minutes with more than 3000 RPM, rotation per minute. That is 700 G. We are placing the centrifuge tube inside. As we told earlier, it is placed straight opposite the second tube. So we are starting the second spin, that's hot spin, for 10 minutes. So we are going to set the time 1, 2, 3, another 10 minutes. And then we are going to close the door. And then the setting will be the RPM is more than, as we told before, 3000 rotation per minute. Okay. So or 700 gravity. So after the second spin over, open the door, take the tube out and we can see the platelet palette, okay, at the bottom of the centrifuge tube. Okay, you can see very clearly the platelet pellets in the bottom. So now what we have to do is we have to discard the platelet poor plasma which is at the top. Okay, leave the first that is lowest, that 1 ml plasma to mix with the platelet pellets gently. After the separation, we have received 1 ml of platelet rich plasma. So from 10 ml of blood collected, we are getting 1 ml of PRP. For 20 ml, it's 2 ml we are getting. For prior to the procedure, we need to activate PRP. For activation, we need to add calcium chloride or thrombin 20 to 30 minutes prior to the procedure. Now we can inject the PRP to the site of the wound where you require really granulation. So where you require more support, now for growth factors you can inject. So now I am injecting in the first site, okay, and similarly we can inject in many places. After injecting, you need to do a dressing, okay, because of time frame I am not able to show all the injecting sites. So PRP is a portion of plasma fraction of autologous blood having platelet concentration above the baseline. Approximately 4 to 5 times it should be more. So PRP is easy to produce with minimal effort and can prepared as needed at the point of care. So it is very easy. So once you do the inject the platelet and then put a dressing, so you will have a lot of advantage in wound healing. And thank you very much. Thank you.
Thank you, Dr. Dinakaran. This is very nice. You have done a very nice demonstration. We are really proud of you. You are doing great work in that part of our country in Chennai, and we always want you to promote your work more and make spread IPA. And this is what IPACON is meant for, spreading education. Now I invite Dr. Santosh Murthy, President from Telangana, Andhra Pradesh. It's a combined TS/AP chapter. Dr. Santosh Murthy is a general podiatric and bariatric surgeon in Navya Multi-Specialty Hospital, Telangana. He's a founder of Advanced Wound Healing Center, and he has got many awards to his chapter. And his goal is to conduct workshop in all districts of Telangana and Andhra Pradesh, and to bring awareness about podiatry. And I assured you that he is one of the most enthusiastic members and core committee member of this virtual conference of IPACON 2021. And he has really given his heart and soul for this conference. Thank you so much, Dr. Santosh Murthy, and please share your slides. And you have to be little constrained on the time because we have one more workshop.
Santosh Murthy. It's an honor for me to be a part of this workshop on this such a big platform, sharing dais with some of the legendary personalities like Dr. APS Suri sir and Dr. Ravi Chitoria sir. I feel very thankful. So today I'll be showing some of the cases that I've done with PRP, PRFM.
This is Merisys DFU autologous biological kit from Diponet. This DFU kit contains 2 pouches. One pouch, it is leukocyte platelet rich plasma kit, LPRP kit. This LPRP kit contains 13 ml vacuum retainer with a patented gel separator. And also it is having growth factor activator. The second pouch contains Merisys PRFM platelet rich fibrin matrix kit. This kit also contains 13 ml vacuum retainer with a patented gel separator. We are trying to demonstrate the PRP formation from this kit. So we have to extract 8 ml blood and add into this vacuum retainer. We are pouring into this vacuum retainer. Yes, now the blood is added 8 ml in this vacuum retainer. And this vacutainer, we have to place it into a centrifugal machine with a balancing. Now we are balancing the centrifugal machine, and slowly we have to place it at the RPM of 3400. This is at the speed of 3400 RPM in 6 to 8 minutes to be spent. You can see that this has been formed very well, this plasma. This is platelet rich plasma. We have the supernatant plasma, about 4 ml we have to remove. We are removing this about 4 to 5 ml of supernatant plasma, which will not be having much of platelet. This is the container for the tissue activator, growth activator. This platelet rich plasma to be added in this tissue growth activator. Yes, now we added that platelet rich plasma into this tissue activator container. We'll just shake it, and this can be aspirated into a 5 ml syringe.
With PRP, PRFM. So this is a case of diabetic foot with already some fingers have been lost, which also mimics like Charcot's. As you can see the X-ray and appreciate. So they were planning for an amputation, but they didn't want, so they have come here for further management. And once I have removed those sequestered bones, now you can see the wound is looking in a much better shape. The smell, infection, everything subsided. So now I have planned to do PRP and PRFM in order to get a proper granulation tissue and close the wound. Proper approximation. You can see this PRP I'm giving on the edges of the wound, and I prefer to give in the edges with a 1 centimeter gap with 0.12 ml of insertion, because that imbibes the growth factors from the surroundings. That's what I believe. And now I have applied PRFM into the cavity area. So there was a hole which I need to fill it, for which PRFM I have applied, and all those deep areas I'll now cut the PRFM into small pieces and try to insert into the deeper areas of the wound. Now
Very nice, Dr. Santosh Murthy. Thank you so much. Thank you to all the speakers and chairpersons here for this session. Because of the time constraint, I think we won't be able to take the questions from the chat box. We will be sending by email, because we have one more workshop to run, and then we have a validatory function, poster presentation, awards are there, and then we have a GPM of the Indian Podiatry Association. Thank you to Dr. Swapnil, Dr. Natalia from Ukraine, and Dr. Gautam Shah for chairing this session. And thanks to all the speaker, Dr. Ravi Chatoria, who's a master in regenerative medicine, Dr. Santosh Murthy, and Dr. Dinakar. Over to Shrishti.
Thank you to all the chairpersons and speakers, Dr. APS Suri sir, Dr. Ravi Chitoria sir, Dr. Santosh Murthy sir, and Dr. KP Dinakaran sir. Thank you very much. The best way to find yourself is to lose yourself in the service of others. We at IPA stand on the cause I prevent amputation, but along with saving the limb with knowledge, care is equally important. Therefore, for covering the cause completely, we dedicate workshop 5 for all healthcare workers. For this session, I would like to call on stage Dr. Rajneesh Saxena Sir, Secretary IPA. Sir is a consultant diabetologist and food care specialist and successfully runs the Saxena Diabetes and Food Care Center, Ajmer. Sir is awarded with various awards like International Medical Excellence Award, Vikram Samvat Award, and many more. I welcome you to the podium, sir. I request you to kindly introduce the chairpersons of the session.
Thank you very much, Dr. Seshti. Thank you very much for your nice words. Our chairperson is Dr. Umesh Chawda, Professor General Surgery from Hisar. He is at present work as a JR Jaslok Hospital, Mumbai, and St. Stephen work as in St. Stephen we work as senior resident St. Stephen Hospital, Delhi. He is fellow of Indian Association of Gastrointestinal Endosurgeons and performing almost all general surgery procedures, including open oncosurgeries, basic laparoscopic surgery, and endourology procedures. And other chairpersons are Dr. Vinod Darewa. He is from Pune, Bihar. And last chairperson is Dr. Tanura Suroi. He is professor in Merit Subrati Medical College. He works as a treasurer for critical medicine. Now I invite our speaker, Dr. G.D. Ramchandani. G.D. Ramchandani is a well-known person. He is president of Rajasthan IPA chapter. He did MD, FRCP from Edinburgh, Glasgow, FAC, USA, and so many fellowship in his credit. He is physician and consulting diabetologist, professor and head department of internal medicine, Daswani Dental College, Kota. He is fellow of so many associations, and at present he is working as a joint secretary National API and joint secretary ICP. I invite Dr. G.D. Ramchandani for important topic, that is initiation of insulin and how to manage and start insulin, and what will be the precaution taking during the management of insulin initiation and insulin inoculation and injection. Dr. G.D. Ramchandani.
Thank you, Dr. Rajneesh Saxena. At the outset, first of all, I would like to thank Team IPACON, especially Dr. Suri, Dr. Rajneesh, Dr. Manish Kumar, and all the active team members who has given me this opportunity to deliver the very important workshop. I have seen previous workshop and they are amazing. I cannot imagine how much work you are doing. That I have not imagined that there are 34 types of regeneration techniques. It is literally beyond imagination for my side, because we are physicians and doing just examination part of the foot, and once they're getting some problem, we are referring to the surgeons. So definitely you are working so hard, and the motive is one, that is I prevent amputation. For that, I think this topic is also important for achieving this motive, because without diabetic educator, because there are three components are there, this workshop is doing for the educators. Without educator, without insulin, anything in the diabetes is incomplete. If you are preventing the amputation, definitely along with all the super specialists, you need a very good educator, or you can say podiatric educator, and insulin technique. You need insulin injection also. So I just share my slide and then just briefly I discuss within 10 minutes because we are already getting late. And one more important point, which I forgot, that this year we are celebrating 100 years of discovery. Everybody knows that Professor Banting and Best discovered, and along with Banting, Dr. MacLeod's, both were awarded Nobel Prize, and they shared this prize with the Best and Collip. And this was the first child, Leonard Thompson, who was given the first dose in 22. And so we are celebrating 100 years of insulin.
this was the first child in the India, because everybody is talking in the which was the first child, and this is the first child, Kumudini. She's Bengali, and she was given insulin by Dr. Bose in 1929 after the discovery of just 6 years after discovery. Discovery is very interesting. I'm not going in detail. So when do diabetic patients require insulin? Because whenever you're talking insulin, there is a lot of myths in the doctors and as well as for the educators and the patients also, that insulin is not a treatment, or it's a final treatment. After that, nothing is there. There are a lot of myths. So what are the indication? If everybody knows type 1 patient, if we are not achieving glycemic control with diet, exercise, and full dose of OHAs, newly diagnosed with A1C more than 9.5 and fasting sugar more than 250, PP sugar more than 350, patient with contraindicated with OHAs, pregnancy, breastfeeding, and the most important part is for the today's workshop is patient undergoing major surgery, and especially in any patient who has a diabetic foot or ulcer or something is there. If you are started insulin in the early phase, the recovery and everything is very fast. This was a paper published in the JAPI 2009 that insulin can be started at the time of diagnosis if fasting PP and A1C are high. Everybody knows the conventional insulins are available in the market. They are short acting, long acting, and intermediate acting. Long acting like NPH, lente, ultralente, and intermediate acting. They are combinations of short acting and intermediate acting. It is 25-75, 30-70, 50-50. Similarly, nowadays the newer insulins are available. They are known as analogs or analogs, and newer than in analogs. There are again 3 categories: short acting like SPART, glulicin, and Lispro. There are 3 insulins are available. In long acting insulins, Glargine, very popular insulin we are using in day-to-day practice, Detemir and Degludec. These are the working as a 24 hours, and again the premix or basic biphasic insulins are available. This is very interesting for educator, that every insulin has their special color on the cap. I just want to show you this. This is the vial, so you can just diagnose which insulin is there. Sometimes if you are removing the insulin from the refrigerator and this this paper over this is not clear, so you only by cap you can see, you can say this is NPH, or yellow cap this is rapid insulin, or orange cap this is 30-70. We are commonly using 3 type of insulin, and basal analogs have purple cap. So on the basis of this cap you can say what type of insulin is this. And in Indian market this is very difficult sometimes. We are using mostly two types of syringes are available, and similarly 2 types of insulins are available. So mostly in day-to-day practice we are using insulins which had 40 units per ml. That is 10 ml insulin contains 400 units and each ml contains 40 units. Similarly 10 ml vial is available and each ml contains 100 units. So these 2 insulins are looking like same, but the concentration is different. So the syringes are also different. For 40 unit insulin, we are using 40 IU series. For 100 unit insulins, we are using 100 IU syringe, and both syringes are different and their caps are different. This red cap and this is orange cap. Red cap means this is 40 IU and the marks by red color, and orange cap and the mark for the black color. So if we are using 40 IU syringe and taking 100 IU insulin, the concentration is 2.5 times different. Similarly, if you are using 100 IU syringe with 40 IU insulin, so always see the vial what is prescribed. It is a written 40 IU or 100 IU, because anytime if you are purchasing syringes from the medical store, we always give you 40 IU, because sometimes you don't know which type of insulin you are using. So always say your patient that this type of insulin we are using. Similarly, patient is require more than 40 IU, we may shift to the 600 IU. In 100 IU, you need this 100 IU series, and in 40 IU, this is very, very important, because many of the time, I think everybody is facing this problem that patient is always taking this one syringe and using both type of insulin to the same series. So it may lead to either severe hypo or it may lead to poor glycemic control. So both the things are there. Similarly, injection sites, there are three common sites we are using. The first common site is the anterior abdominal wall, just around the umbilicus. We are using this dummy. And the second site is anterior part of the anterior and lateral aspect of the thigh. And third is the back of the arm, that is behind this arm. Sometimes patient are using in the anterior or middle of the arm, so it leads to the directly insulin given to the muscle in biceps muscle, so it may leads to pain or rapid absorption and hypoglycemia. So these are the three common sites we are using. For abdominal part, it is said that there is it has a quick absorption. Absorption is fast in anterior abdominal wall as compared to thighs and buttocks. So this is very commonly used site. How to advise single dose? I'm not going in detail because we have a shortage of time. This diagram is given. Just take the insulin, roll in between. Whenever you are removing the insulin from the refrigerator, because it's cold insulin, sometimes it leads to the painful. So just keep in between both the palms and roll for 10 times or gently shake. So there are two things will happen. The temperature will come down, temperature will raise, and similarly, if it is a premixed insulin, it will mix. Otherwise, the NPH part is little bit heavier part, so it settle down, and R or regular part is on the top. So patient, if you are not shaking the insulin, the patient will get either regular insulin. It may lead to hyper or hypo. Again, fill the air, keep the vial like this, and just push the syringe into the vial. Again, uplift the insulin vial and fill that vial, fill that syringe, and just hold the part, make a pinch, and you inject the insulin at 90 degrees straight. Because nowadays the needles are very small size, and even insulin pen needle is a very, very small size. You can give straight, the need not to give that 45 degree. Very rarely you required in the 45 angle, especially in small children where subcutaneous tissue is very low. Mixing, nowadays we are not doing mixing, so I'm not going in detail about the mixing. Changing of the site is very important. Rotation is very important. If you are not doing, because if you are injecting insulin at the same site, it may lead to various complications like lipohypertrophy or lipodystrophy. In both the situation, if you are injecting insulin in the same lipohypertrophy or lipodystrophy, it may have an erratic absorption. We are using such type of demo piece to educate the patients that this is our abdominal integral wall, and inject right now. And this part is little bit elevated, and this is lipohypertrophy. If you're injecting insulin in this part, it may lead to rapid absorption or slow absorption. It may lead. Similarly, insulin storage is also very important. If any bottle or any vial is unopened, stored in refrigerator, and it can be used, it can be kept up to the expiry date. Unopened bottle, once it is opened, store in refrigerator and discard after 3 months. Often, sometime in hospital setting, the vials are there and they are using even after 3 months, 4 months, 6 months. So after 3 months, it should be discarded. Opened bottle, if it is kept in the room temperature at around 18 to 24 degree temperature, discard after 3 to 4 weeks. So you can use up to 3 to 4 weeks at the room temperature. But in India, because temperature is very high, up in 8-9 months, so it's advised to keep the insulin in refrigerator in the door part, not in the frozen. Should not be frozen. So store away from the source of the heat. And if refrigerator is not available, store in a clay pot or a hole in the ground. Because in our part in Rajasthan, it's very heat. In some villages, electricity problem is there. Refrigerator is not there. So we used to train that family that how to keep the insulin in clay pot or in the hole. And it should not be kept in under the sunlight because it may damage the insulin, and it should not be vigorously shaked. Otherwise, the particles are broken down. And similarly, insulin should be after removing the, after keeping from outside from the refrigerator, should be rolled, because cold insulin give rise to pain. Storage, I already discussed with you. Factors affecting insulin action: site and depth. Abdominal site is rapid faster as compared to the thighs and gluteal part. If we are doing exercise after taking insulin, it may lead to rapid absorption and patient may go into the hypoglycemia. Body temperature, insulin types. Analogs are acting within a minute. They are very fast acting, and conventional insulin, basal insulin and bolus insulin. Bolus insulin takes around 30 to 45 minutes, and basal insulins take, they are peakless. So it's depending on the type of insulin. And lipohypertrophy, it again leads to erratic absorption. And the dietary habits, what you are taking after taking the insulin. Complications, we all know hypoglycemia is very common. Local allergic reaction also seen with some insulins. Lipohypertrophy, thickening of the subcutaneous fat at the injection site, and lipohypertrophy, thinning of the SC fat at the injection site. This is the classically lipohypertrophy. Repeatedly injecting at the same site leads to the lipohypertrophy, and repeatedly injecting sometimes it leads to the lipohypertrophy. Lipohypertrophy nowadays is not seen because we are using human insulins. Previously, we used to use this bovine and porcine, and lipohypertrophy we are commonly seen in type 1 patients because they are using 4 pricks in a day. How to avoid these problems when injecting insulin? If it is painful, I think it is going into the muscle. So always check the needle. So how to overcome this problem? Change the needle regularly, and you always pinch the skin, and don't give the insulin to the muscle, because we are giving in the subcutaneous tissue. If it is going to the muscle, it may be painful or it will have rapid absorption. Similarly, insulin drips out to the intestine. That means you inject and keep this needle or that syringe for at least 10 seconds, or you count for 1, 2, 3, 4, 5, 6, like, and then remove that needle. Otherwise, it may dips out. Lack of effectiveness, injection site is not proper. Lipohypertrophy, or if you are removing the insulin quickly, you inject and just removing. If you are taking hardly 4 units, 8 units, 10 units, so it may trickle down to 4 units, so it may lead to uncontrolled diabetes. So you change the needle frequently. Other deliveries are also available in other insulin deliveries devices, like pens are available, pumps, and nowadays insulin inhalers are available in the US markets. Pens are 2 types. They are pre-filled pens. This is pre-filled. So you just see there is a thick part is there, that is NPH, and above there is a clear regular. So premix insulin, if you are not shaking this insulin in between your fingers, it may lead to this R will be injected to the patient, and patient may get hypoglycemia. So always roll down the insulin before using. Second is reusable pens. In that, various companies are available, and there is the pump, cartridge is there, and you can change this cartridge. This cartridge contains 3 ml insulin, and this is 100 IU insulin. This is 100 IU insulin. Some patients using this cartridge, and they're using, sometimes this pen is not working. So what when they're using? So always tell the patient, if we are using this cartridge, always use in the pen. Otherwise, or in case of emergency, if you are using 100 syringes, then always take 100 IU, because it is 100 IU insulin. It is not a 40 IU insulin. Pumps are available, like external insulin pumps, implantable insulin pumps, and various insulin pens are available in the Indian market. Sanofi, Novo, and Lilly, Vocard, Biocon. All these companies have their own pens. Inhaler insulins available in US market. They are not available in Indian market. They are short-acting insulin. There are various lot of problems, and they are because the viability. That's why they are not popular. And second, they are very expensive. So finally, I just say to the educators, because when we are using insulin, there are patient barrier and physician's barrier or doctor's barrier. There are a lot of things in the patient's mind. So it's our duty. Educator is not an educator. He is a basically very important person in the management of the insulin, because without educator, you cannot, I think, treat the patient. You cannot, he is not taking care of the diet part, but also is taking care of the insulin injection technique, foot care technique. That is also very important. If you are taking a good foot care at initial stage, at the time of diagnosis, and repeatedly, if you are explaining about the foot care, definitely we can achieve our motive little bit easier. That is, I prevent amputation. We can prevent our ulcer formation. So insulin therapy, role of diabetic educator, insulin should never be used as a threat. Never. Always try to explain and just explain and then use. They don't say that this is your last resort, and so never be used as a threat. It's a treatment. It's a mode of treatment, and it's a very good treatment. It is viewed at the time, at the proper time. Otherwise, you may get some problem. Fear of injection is common, so you educate them. And diabetes educators' attitude is a key to acceptance. If attitude is good, education is good, definitely will accept the insulin injection. The patient should be explained the exact need for the insulin taking. People taking insulin should be praised and encouraged to promote a positive attitude. Somebody is taking insulin, always encourage, always praise, always tell the family that you are really taking good treatment and you are really managing this diabetes very nicely. Always encourage him. Identify hypoglycemia and its prompt reporting, because insulin has a severe hypoglycemia. So every visit, educate the patient about hypoglycemia, understanding patient barriers towards insulin therapy and resolving the same. Thank you. Thank you very much for giving me this opportunity, because this topic is very lengthy, but I try to cover in 15 minutes. Thank you, sir. Thank you, entire team of IPACON.
Thank you very much, Dr. GD. Very nice presentation, and very short duration, short time, you cover all the important aspect of the insulin carrying, insulin initiation, and insulin using. Thank you very much. Now I invite our second speaker, Dr. Ashiya Nabi. She is from UAE and she is general practitioner and running own diabetic food center at UAE. Now I hand it over to Dr. Ashiya for her presentation of diabetic foot examination.
This is Dr. Ashiya Nabi from Dubai with you. My topic today is the diabetic foot examination, a positive step in the prevention of diabetes, foot ulcers, and amputation. As we all know that despite several initiatives to increase screening, only 23% to 49% of people with diabetes have their feet evaluated yearly in primary care setting. So it's a mandatory for all the primary care physician must develop a technique to evaluate the diabetic foot consistently, efficiently, and effectively. Therein, to reduce amputation rates can be expected by 45 to 85%. To begin with, history is one of the very essential part, and history, to take a focused history before beginning the comprehensive diabetic foot examination, open-end questions, inquiring whether the patient experienced any problem with their feet, skin problem, changes in their feet since their last checkup, subjective neurological changes, tobacco use history. To preserve consistency, cardinal techniques is introduced for adaptation for the diabetic foot examination in the following sequence: inspection, palpation, peripheral vascular or neurological assessment, and auscultation. To begin with, foot inspection, dermatological side should examine in a well-lit room. The skin should be inspected for excessive dryness, perspiration, any tropic changes such as pallor, cyanosis, rubor, especially or bony prominences. The intertriginous spaces between the toes must be examined for the presence of calluses, infection, or ulceration. Check between toes for fungal infection. Shoes should be examined for signs of break down or abnormal wear, as ill-fitting shoes can be found by inspecting for signs of wear or areas of the shoes that appear distorted due to foot deformities or altered biomechanical influences. So also the callus or blistering, hemorrhage into the callus, the presence of callus, particularly with hemorrhage, nail dystrophy or paronychia, should prompt the patient to refer to a specialist or specialist clinic on urgent basis. The continuing foot inspection, dermatological part, should examine again in a well-lit room. That is mandatory for all the examinations. The nail are a frequent source of problem for people with diabetes. So look for the presence of ingrowing toenails, paronychia, hypertrophy, dystrophy, or onychomyosis, nail fungus. Foot inspection, musculoskeleton part, it is essential to look for wasting of the intrinsic muscle of the feet, that is atrophic gutters in the tissue between the metatarsal, which creates altered mechanics as opposing muscle gain, the mechanical advantage culminating in digital abnormalities such as hammer toes, claw toes, prominent metatarsal head, or charcot joints, which my colleagues has already explained in a detailed way. The plantar surface of the foot should be inspected for the prominence of the metatarsal heads, which may create altered pressure and distribution with weight bearing, resulting in callus formation and ulceration. Foot inspection, vascular assessment included foot pulses and ABI if indicated. Foot pulses I'm going to demonstrate in the video section. ABI has 95% of the sensitivity and almost 100% of the specificity in identifying peripheral artery disease compared with angiography. ABI value above 1.3 are associated with increased mortality and necessitate reference to a vascular surgeon for further evaluation. Second part is the palpation. Already discussed temperature, texture, and turgor changes. However, most important to note is significant reduction in temperature, that is distal cooling, may indicate peripheral artery disease. And these patients should be promptly referred to vascular surgeon for further evaluation to save the limb. We should pay special attention to determine whether the digit deformity is rigid or flexible. Should additionally assess abnormal pressure over the digit or digital deformity causing increased plantar pressure. Another part is the auscultation. In the presence of type 2 diabetes, the prevalence of all cardiovascular disease, including carotid stenosis, abdominal aortic aneurysm, and peripheral artery disease is doubled. So the presence of at least one root at rest, that is iliac, femoral, or popliteal, increases the likelihood of peripheral artery disease when considering in patients who are symptomatic with left complaint. The most valuable individual clinical findings are the presence of cool skin, at least one root, and any palpable pulse abnormality. So always remember, any positive finding would necessitate referral to a vascular surgeon for further evaluation and testing. This is very crucial part because we can save the limb. But now the most important part of the segment of the presentation, peripheral neurological assessment, 5 clinical tests which can be performed to identify loss of protective sensations. I'm going to begin with my video.
and low. 10 gram monofilament test or Siemens-Weinstein monofilament test. Monofilament test is performed using standardized monofilament for loss of protective sensation in diabetic foot. As you can see, there are ideal 10 positions marked for demonstrating monofilament testing. 9 is on the plantar surface of the foot. Don't worry about this black mark. This is the mole of the foot. And 1 is on the dorsum surface of the foot in the web space between first and second toes, which I can show later. The test is very easy and relatively inexpensive. Some of the things, keeping in mind that the examiner should avoid applying the filament on callus areas as pressure perception is reduced in these areas. The positive test means that out of 10, 4 if the 4 locations are insensitive. Before starting the examination, the examiner should first demonstrate on the hand of the patient this technique on the hand or feet of the patient as a control. Ask your patient to close your eyes while I'll place the monofilament perpendicular to predefined area sites on the plantar surface of the foot like this. So I'm going to ask my patient if he is feeling any sensation or not. So I'm going to put the pressure till the monofilament bends, as you can see. So are you feeling any pressure? Are you feeling any pinprick sensation? The patient is saying yes. Are you feeling pinprick sensation here? Very good. So he is feeling pinprick sensation as he is not a very advanced case of diabetes. Are you feeling pinprick sensation here? Okay. Are you feeling pinprick sensation here? Here. Very good. So after applying the filament to specific sites, the patient should respond with yes or no. As my patient responded very well with yes, his all 10 areas are very much sensitive. When asked whether they perceive monofilament pressure that is being applied in case of diabetic patient, generally they will not perceive this thing, and the test is considered as either normal or abnormal. Are you feeling any pinprick sensation? Yes, he is feeling pinprick sensation, so the test is normal. Pinprick sensation test. Another examination for recognition of neuropathy is pinprick test. The pinprick test is yet another valuable, cheap and easy test to perform to assess neurological functions or dysfunction in the diabetic foot. The lack of pinprick sensation is associated with increased risk of ulceration. Now I would like first to demonstrate on my patient hand to understand the pricking sensation or his foot or what the pinprick feels like, and then ask him to close the eyes and perform the test. So I'm going to put on his feet while his eyes are open. Do you feel this pinprick sensation? So similarly, I'm going to put his hand when he is feeling the pinprick sensation. So that means I will take that as controlled. And now I will begin with the test. The examiner or I will generally should use the disposable pin to the skin or the dorsal surface of the hallux or first toe just proximal to the toenail. Repeat it on L4, L5 and S1 areas. As you can see, I have demarcated it well. So I would like to demonstrate. I will put this pressure of the pin on these areas and ask him if he is feeling any pinprick sensation. So he will say yes or no. Yes. He is feeling pinprick sensation on all these areas, yes or no. Yes. He is feeling without, I'm not putting much pressure also, and he is feeling the pressure as on this S1 area dermatome as well. So this clearly signifies that he doesn't have any kind of neuropathy as on now. An abnormal finding would be the inability to perceive pain with a pinprick over either hallux or the other L4, L5 and S1 areas, the inability of person with diabetes to perceive pain through pinprick sensation testing has been found to place them at a very increased risk of ulceration. I'll be demonstrating 128 Hertz tuning fork test, an inexpensive but very valuable tool in the examination of diabetic foot for loss of protective sensation, and is commonly available in most primary care offices and represents an easy and inexpensive means to assess loss of vibratory sensation. Before we start the test, make sure that my patient understand vibration and how it feels like. So I'm going to put it on I'm going to strike it on my hand and going to ask him whether he is feeling the vibration or not. Yes. So I'm going to repeat the same thing on the foot area. After I make my patient completely aware that how the vibration feels like, now this test involves having the patient close their eyes, followed by striking the tuning fork on the palm of mine. I'll repeat it again. I'm going to strike it on my palm hard enough that it vibrates at least for 30 to 40 seconds of its own, not more harder than that, and applying it on the plantar hallux. My patient, I'm going to ask my patient, is he feeling any vibration or not?
Yes.
Okay. Thank you. I'm going to repeat it for the malleolus now. I'm going to strike it and I'm going to put it on the malleolus. Yes. He's feeling the situation. So it's very important that to understand abnormal finding is suggestive if the patient reports no vibration through the examiner, could still perceive vibration while holding the tuning fork on the toe. Ankle reflexes. Ankle reflex testing is yet another simple bedside neurological test which, when found to be abnormal, is associated with increased risk of foot ulceration. Ankle risk can be tested by the patient seated, kneeling or lying prone. So I have asked my patient to lie prone. With the position on lying prone position, I'm going to slightly dorsiflex to 90 degree and tap the Achilles tendon just above the heel. So you can see completely ankle reflex is quite visible. The absence of ankle reflex has also been reported to place patient with diabetes at an increased risk of ulceration. Sometimes it's getting difficult to obtain the reflex. So in that case, ask the patient to flex their fingers and interlock them with one palm facing downwards and the other facing upwards. So in that case, you'll be able to hold it again and you'll be able to achieve the desirable results. So you can see this is very much normal, and here it completes the ankle reflex testing. So let's check now the pedal pulses for the neurological examination of the diabetic foot. The dorsalis pedis pulse is palpable on the dorsum of the foot in the first intermetatarsal space just lateral to the extensor tendon of the greater toe. As you can see, I have put the marking. I'm going to place my hands, 3 fingers on it, and I'm going to feel the pulse. So answer to question must be yes, and pulses present or absent. Similarly, the other pulse which I'm going to palpate, which I'm going to feel, is the posterior tibial, which is placed for which I'm going to place my fingers just behind and slightly below the medial malleolus. The posterior tibial pulse can be felt behind the below medial malleolus clearly. As I clearly said that these are 4 tests. The 5th one is VPT testing, which is generally possible now to keep in the clinics. The VPT testing employs the use of handheld biotheciometer or neurotheciometer to quantify the VPT, document a mean of 3 readings taken from each helix. A measurement of 25 volt or greater is abnormal and strongly predictive of subsequent foot ulceration. I would like to summarize my whole presentation. Recommended screening guidelines: screening for lower extremity complication at every visit for all patients with a suspected or confirmed diagnosis of diabetes. Consider implementing a risk-based referral system to connect primary screening with the specialist care is mandatory. A strength of recommendation: good quality patient-oriented evidence. Primary care providers must recognize the importance of incorporating a diabetic foot examination or screening tool as part of their practice in preventing diabetes complication. Thank you for attending. Thank you for listening to me. Stay safe, stay up to date. I prevent amputation. This was Dr. Asya Nabi with you.
Thank you, Dr. Asya. It's a nice presentation, and I think a lot of healthcare workers will be benefited by your presentation. You have taken up all the parameters to how to do a foot examination very nicely, and IPACON core committee really is thankful to you for sharing your knowledge with our delegates. Thank you so much. Over to Doctor. We have very enthusiastic speaker. Next speaker, Dr. Amit Jain from Bangalore, and he's a consultant and head of Amit Jain Institute of Diabetic Foot and Wound Care at Bangalore, in Bangalore, India. Professor, Department of Surgery at RRMCH, Bangalore. Dr. Amit Jain, and he has many awards. He has good experience into diabetic foot care, and he has a passion for diabetic foot examination and he has a special guidelines on diabetic foot management. Thank you, Dr. Amit Jain. Over to you. Dr. Amit Jain. Yes.
Should I talk on screening, sir?
Yes. Share on you.
Okay.
Yeah.
Why is this sharing not occurring? Yeah. How do I put the voice?
You can speak. We are hearing you.
Thank you, sir.
Thank you for the entire IPACON. I know I'm the last batsman today, and I'll try to perform well. As promised last year, I'll not make anybody sleep because I know everybody's tired and they would love to go home very fast. And I'll come to my specific target of what I'm going to talk about is, it's very clear what is food evaluation. There are two different entities. One is called screening and one is called examination. And we have seen that people have often mixed up those two. If you say in a simple word of schematic representation, this is how it represents that screening and examination. For all those people, examination is laborious, detailed investigation of any entity, whereas screening is only a point specific of what you want to determine. We reviewed and cleared the concepts over last 4 decades to see what is happening in diabetic foot evaluation system. And we have seen the Western recommendations that have taken place, but we have categorized them classically of how we look at a WHO criteria for screening. So we try to put all this which is existing in last 4 decades. These are examination, even the in-law 60-second and simplified 60-second tool cannot come under screening category, they come under examination. So we thought it's high time that India being a diabetes capital of the world, it's time we should have our own screening tool because having the highest population and we deal differently compared to the Western people. And it was, it's a team effort to decide that we should have a new screening tool, which is quite obvious because we have a lot of Anganwadi workers, healthcare workers. Our rural system of practice is different from Western concept. So we thought, okay, let us have our own screening tool. And that's how the Amit screening tool came into the picture. We eponymized and we tried to have this screening tool in comparison to that of screening that was happening in the breast cancer over the decades. Concept of triple assessment was similar to the breast because in diabetic foot, we have 3 pathies, the triopathy, which consists of immunopathy, infection, neuropathy, nerve damage, and vasculopathy being ischemia. So we needed to just have a screening tool that addresses these 3 entities and that's why they said this is a selected screening tool, a targeted screening tool for India. We have 3 components in this. It's called look, feel, and test. What do you do in look is simple. Just look at the 3 sites, any of the 3 issues, either an infection or an ulcer or any pre-ulcerative lesions like callus or toe deformities and nothing more than that. So it involves just look at the dorsum, look at plantar and look the toe views or the interdigital views to pick up only these 3 entities in this 3 type. The field component was very clear. Any one of the artery can be palpated. We need at least 1 artery for the blood flow, and that's why you can feel either the dorsalis pedis, which is absent in 10 to 20%. So we recommend that either go for anterior tibial or more specifically a posterior tibial, even if it's present, there's an adequate blood flow. An interest component where we wanted to evaluate the neuropathy, use any available instrument. We are not very hardcore rule that use only this is the best. Whichever is available in respective zones, they can use it ranging from tuning fork, vibra tip, biothiometer, pinprick test, Ipswich test. Even if the people are not trained, they can use as simple as ballpoint or Ipswich test in their practice. And that's how we said these are the simple gadgets good enough in a screening. I'm again minding my words. It is screening and not an examination. And enough studies have done worldwide, including in India from North India. And one of the study done that simple gadgets are good enough in screening. So you can use a Simmons monofilament. You can use a tuning fork, which can be used either at first MTP or the great toe or any bony prominence like medial malleoli or vibration threshold. These are done only when specialized centers. They cannot be used for community. We have had a publication good on this screening tool, and we realized that it's hardly 10 to 20 seconds if a person starts using it for each foot, and it'll give a good results. And we thought we will just demonstrate a small screening tool.
Here, and this is from Amit Institute of Diabetic Foot, Brindavan Area Hospital, Bangalore, and this is one of the case to demonstrate how do we do a screening tool. The Amigen screening tool is one of the original validated screening tool which we have derived from the concept of triple assessment of the breast done worldwide. It's a universal tool for detecting the breast cancer in evaluating the breast lump. The same way we have applied the same concept that if diabetic foot has a triopathy of infection, ischemia and neuropathy, then for this 3 component we also should have a triple assessment of the foot, and that's how the origin of this screening tool has come. It's hardly 10 to 20 second screening tool for the each feet which you see, and it addresses all the components. It has 3 components: the look component, the feel component, and the test component. Look components, we try to identify any presence of ulcer, infection, or pre-ulcerative conditions that can lead to an ulcer in form of thyloma or toe deformities. We also look at 3 parts: the dorsum, the plantar, and the toe in between the toe area or interdigital or web spaces where the infection like tinea pedis can be common. we feel for the pulses, and which is the dorsalis pedis or anterior tibial or posterior tibial, and we do a test component which is to evaluate the sensation of the feet. Do as simple as possible, as minimum instruments required in the patient, because it is a screening tool and not an examination tool, which people get confused and they blindly call it as a screening tool. It should be very simple. Now, if you see in this case, you look at the dorsum of the feet carefully. Okay, I've seen there is no cellulitis or redness or anything, infection. We look at the plantar aspect of the skin, and if you see carefully, I've identified one thyloma here and another thyloma here. You got it? Then we look for the web spaces, which is the interdigital area, which hardly takes 3 to 5 seconds for each feet. While doing this simultaneously, we turn and feel for the dorsalis pedis, which is well palpable, and yes, the posterior tibial here and the posterior tibial on the opposite side, well palpable. We have 3 gadgets which we commonly use on the bedside, which consist of the monofilament, which consists of the vibra tip, and tuning fork, both function in the same way. We are avoiding tuning fork nowadays because a lot of elderly people are not understanding, so these 2 tests helps us in detecting very easily the monofilament and the vibra tip for the vibration sensation. The tuning fork, try to use if there is a bony prominence, which is on the first MTP or over the medial malleolar region. So what you do, you try to vibrate the tuning fork like this place, which we have already demonstrated, and see it's still vibration. I can feel it. Madam, can you feel? No. Not feeling, right? Yes. I place the same over my one, I can feel it. Can you feel?
Yeah.
You can feel a little bit?
Yeah.
She can feel it. I also can feel it. It's still vibrating very loud. So this is one of the crude methods which can be used in any peripheral health center, medical colleges, clinics where patients are general practitioner or by Anganwadi workers. This is a monofilament. Okay, this is another way. You can use any 1 or 2, your choice based on the practice, whether on your rural side, you're in a clinical, you're a diabetes practitioner or diabetic foot practitioner. So that's why the screening tool is an open screening tool which you need to decide how many you have to use it. Now monofilament, you can use minimum 3 to 4 sites is what they say, and nowadays people have come out to 1 or 2 sites also. We use the common is the pulp of the great toe. Madam, come here. Yeah. Can you feel? No. Till you bend, try to feel. No. Okay. Can you feel? No. Okay. She's not able to feel this side also. Same feel at the pulp of the opposite. No. Yes. She's not feeling. And same here. She's not feeling. Our screening tool has got over, and this is a minimum mandatory evaluation which we are looking for the worldwide. We have renamed it for our own purpose. It is called as Amigen's linear foot test, which is LFT, look, feel and test, or linear foot test. The linear foot test means you go systematic way of how you have to feel. Thank you.
Hope I tried to simplify as much as possible, keeping in the mind that you have nurses, you have general practitioners, and we cannot teach them much complicated, but try to teach as simple as possible. This is not the end of the screening tool. We still have part 2, 3, because when we are validated and we thought that for expert, we have a different advanced screening tool. I'll be back someday in IPCON. Till then, thank you from the bottom of the heart. This is Dr. Amit Jain for diabetic foot screening.
Not someday, very soon. You'll come very soon. Thank you, Dr. Amit, for the nice illustrations. Over to chairperson. We announce. Thank you so much, Dr. Asya Nabi, Dr. G.D. Ramchandani sir, for a very nice presentation, and Dr. Amit. All the 3 speakers in this workshop 5. So we come to the end of the sessions here. Thank you so much for this workshop number 5. And I hand the mic over to Dr. Rajneesh Saxena for the announcement for the closure of this workshop and take the proceedings further.
After a long 2-day journey of academic learning, we reach the point with more knowledge, but it is not the end of journey of diabetic foot. Continue education, learning. I am very much thankful to Dr. Suri and all the committee member of IPA. I am very much thankful to all our faculty, national as well as international. They spare time from their busy schedule, even from different time zone. During late night hours, They enlighten to update the knowledge of Indian doctors and their healthcare providers. Also, I am thankful to all Indian faculties as well as chairperson, reporters and moderators. Without their active participation, no such academic meeting is successful. Special thank to all the members of scientific committee, organizing committee. Without their non-stop tiredness work, no such conference can be successful. Special thank to Dr. Manish Jangam, coordinator of all committee, who are directly, actively, tirelessly working round the clock. All the members, Dr. S. A. Daria, Dr. Puneet Saxena, Dr. G.D. Ramchandani, Dr. Sanjay Kale, Dr. Naresh Dua, Dr. Bharat Sabu, Dr. Raka Sevdev, Dr. Rajiv Kovil, Dr. Chotala, Dr. Anand Suri, Ajay Tiwari, Dr. Arun Maya, Dr. K.K. Arora, Dr. Dilip Sai, and many more. I apologize if forget to recall the name of any doctor, but all members equally participated and helped to organize the virtual conference. Overall, team leader is main person behind the success. So I can say Dr. EPS Suri is one man. Rather, I can say he is one man army against diabetic foot amputation to save the limb. I congratulate him and big clap for Dr. EPS Suri. I am also thankful to our international faculty, especially Dr. Ravi Kame Pillai from USA, our Vice President and guide. Other faculties like Dr. Jonathan, Dr. Sefero, Dr. Manju Mittal, Dr. Gurleen, Dr. Morgan Naidu, Dr. Shadia, and many more with our own national faculties. I am thankful to team of Meals and more, Mr. Jia, Mr. Rohit, under supervision of Mr. Sudhir. They cover whole conference on Zoom platform. Thanks a lot, Mr. Sudhir. Before going and thanking others for people, I would like to invite Dr. Arun Maya to announce the name of best paper and poster presentation. And it is right time to say my thanks, special thanks to our learned judges, Dr. Sandeep Suri from Haryana and Dr. Puneet Saxena, Professor and HOD, Department of Medicine, SMS Medical College, Jaipur. Thank you, sir. The award is declared by Dr. Arun Maya, sir. 2 books are awarded by Dr. Arun Maya to best paper and poster presenter. And these books are very important, very good for diabetic foot care and biomechanics of foot learning. And three mementos will be given to best poster presenter and 2 to best paper presenter. So I would like to invite Dr. Arun Maya to announce the name of the today's winner.
We are putting it on the screen also.
Yes. Thank you, sir. On behalf of the chairman as well as the organizing chairman of our IPACON2021, Dr. APS Suri sir, and General Secretary Dr. Rajneesh Saxena sir. It's a great privilege for me to announce the winner of the both poster and the oral presentation. As mentioned by the Dr. Rajneesh Saxena sir, it was a difficult task for Dr. Sandeep Suri sir, as well as Dr. Puneet Saxena sir, to evaluate as well as announce the best paper as well as the best oral poster presentation. I am pleased to inform to that we had an excellent participation from various parts of the country. From the various medical institutions have submitted both abstract as well as the poster to the IPACON2021. We, on behalf of the team, I appreciate as well as acknowledge all the presenters for their excellent work, both in the form of the poster and the oral presentation. So based on the decision of the judges, I am very privileged to announce the name. The e-poster, the best paper goes to Dr. Nishad, and the second prize goes to Dr. Vaibhav.
Oh, thank you, very nice.
For the oral
Yeah.
presentation,
Yes.
the best paper goes to Ayushi Gandhi, and the second
Screen paper.
Dr. Rashikesh Yadav Karad. Once again, on behalf of the entire team,
Thank you. Very nice.
Thank you, sir. Thank you.
Congratulations to both poster awards and both case presenters. There were many more. It was very difficult for the jury to decide who will be there. That shows that what is the level of education of diabetic foot care among our young doctors who are coming up, that they are taking the theme of Indian Podiatry Association at a higher level. But we are sending certificates to all the posters and all the case presenters. They will be given a certificate of participation from the core committee. Thank you so much to Dr. Arun Maya sir, Dr. Harshanan Poplavar, and Dr. Sabu and Dr. Rajneesh Saxena for doing the hard work of getting the posters, choosing them. There were more than 50 posters and case presenters, oral presenters. And thanks to our jury, Dr. Sandeep Suri and Dr. Puneet Saxena sir. I think your job has been very difficult to choose the best posters and best this, but then we have to do that. We have to choose somebody. It's not that other posters were not good. I'm saying they were as par excellence, but the protocol is we have to choose 2 and 2. That's it. So thank you so much. Over to Dr. Rajneesh.
Thank you very much, Dr. Suri, and thanks a lot to Dr. Arun Maya sir, because without his able guidance, we cannot organize such beautiful competition. And I also congratulate to all the winners as well as all the participants of this competition. In last core committee meeting, Dr. Suri announced that he will give consolation prize to all the participants of poster and paper. So big clap for Dr. Suri.
Thank you.
All the best to all the participants. Now, I am also very much thankful to all the pharma and industrial partners, especially IPCA, Center, Sanofi, UrgoCare, 365 Medical, Vocard, Sun, Lupin, Cipla, Coloplast, Bayer, USP, Dr. Reddy's Pharma, Prasaditi, Dipon, Boinger, Cody, Travers Medical Solution, Adivio Diagnostic.
Yes.
About 20 pharma and industry people are supporting us.
सृष्टि का नाम नहीं लिया सर, सबसे ज्यादा जरूरी था.
And high wound care, it is also very important. Without their support, this great event was not possible. I am especially thankful to Mr. Nitin of Vocard, Mr. Rakesh Gupta of Cipla, Mr. Surenderji, Mr. Chansal Srivastav, and many more who actively participate and actively help us to organize this successful conference. Lastly, I congratulate our curious, always ready to learn and ready to spread knowledge of diabetic foot care and prevent amputation, none other than our learned delegates. Without their presence, no conference can be successful. So I am thankful and congratulate them to become part of this great academic feast and part of our mission of I Prevent Amputation. I am also very much thankful to Dr. Srishti. Without her presence, without her nice announcement, conference was not possible. Lastly, I would say a few words for Dr. Suri. मजरूर सुल्तानपुरी ने कहा था, मैं अकेला ही चला था जानबे मंजिल, मगर लोग साथ आते गए और कारवां बनता गया. तो थैंक्स अ लॉट टू ऑल. और डॉक्टर सूरी के साथ जैसे कारवां बना, ये चलता रहे. इसीलिए मैं एक ही चीज कहना चाहूंगा, लॉन्ग लाइव आईपीए, जय भारत.
आपके साथ होता है. This is only
announce closure of conference.
This is only possible with a good team and hard work. Dr. Rajneesh Saxena has been my pillar. We have been together since the inspection of IPA, Dr. Ravi Kamipli, Dr. Sanjay Kale, and Dr. Naresh, everyone. Special thanks to Dr. Manish and all his team for organizing such a beautiful this program, timing. He has been the backbone behind all the training for repetitors, training for the moderators, chairing and talking to the chairpersons, and looking at the small things. Even sometime I'm busy, Dr. Rajneesh is busy. He has been the moderator and joining forces with the event people. And special thank to Shrishti. She is a young child of us, and she has taken the step forward and done very nicely. All the sessions she has moderated very well. Thank you so much. And special thank to Dr. Rajneesh. I think without his help, I won't be able to possible to organize this conference. Me and Rajneesh, we have been thinking since last 2 years, when to do. But God has decided any time of one day, and that's the time has to be started. And it was on 24th July 2021. So thank you so much for all the people. And we announce the closure of this conference. And please join back the core committee for the GPM.
Now 3 big cheers for Dr. Suri. Hip hip hooray.
IPA. Hip hip
And
hooray,
IPA also.
IPA. Thank you so much.
Thank you very much.
So we can continue here.
They have to stop recording. They have to stop recording. IT people.
Recording.
Live recording. It should not be. It should not be on YouTube also.
YouTube also. So do we keep joining here, or we have to go?
Just continue. We can continue the continue. Rajneesh sir.
First of all, discontinue YouTube recording.
That's what I'm saying.
बंद हो गया.
नहीं हुआ.
Doing sir. Give us 2 minutes, sir.
Sir, wait for 5 minutes. Then we will again assemble.
Okay.
We should be here.
We can unmute. All the panelists can unmute themselves.
बस एक शेयर सुनाऊंगा मैं जाने से पहले.
अरे
सर
मत जाइए सर. I have a question
आपके लिए
for you.
स्पेशली IPACON
डॉक्टर रवि
और सूर्य साहब के लिए, जो कि मैं देख रहा हूँ पूरे 2 दिन से. कल तो मैं कहीं बिजी था, थोड़ा कम देख पाया, बट टुडे आई वाज लिटरली इन अदर, मैं दूसरी दुनिया में हूँ आज. आपका जो काम देखा मैंने, इट्स ट्रूली अमेजिंग. जिंदगी की असली उड़ान अभी बाकी है. जिंदगी की असली उड़ान अभी बाकी है. जिंदगी के कई इम्तिहान अभी बाकी है. अभी तो नापी है मुट्ठी भर जिंदगी हमने, अभी तो सारा आसमान बाकी